السلامة. Hello, dear friends from over Europe and farther. An anniversary is always a little bit special. The 10th anniversary of the ESPES had to take place in Vienna in conjunction with the IRCAD and the EUPSA. It couldn't happen, but I'm sure it will be organized soon when IRCAD come over again to Europe. Anyhow, ESPES had to do something special for its anniversary. So why not its first e-Congress? And here we are today with over 800 attendees for this magic first. Many, many thanks to IRCAD for their very hard work and to François Becmer who make it possible. To Philippe Montupet for his fantastic commitment in organizing this first. And to the members of the executive board of the ESPES for their support and help. I declare the 10th ESPES Congress in Strasbourg and over the world open. Dear friends, have a great day.
Isabella is connected. Bonjour, Isabella.
Bonjour.
Hello.
Hello, hello. Dear colleagues, dear friends. Excuse me. Welcome to the newest and most original ESPES Congress. In a digital era, a digital Congress, how else it could have been? From the first words, I would like to address special thanks to the IRCAD team, to Professor Jacques Marescot, and to Professor François Becmer. Their help is invaluable. Our Congress is the result of a huge teamwork, but in an atypical manner. We had to adapt to a great challenge. Will we organize a Congress or not in these atypical conditions? Finally, we accepted the challenge. Organizational preparations began a long time ago for a live Congress meant to be in Vienna and turned overnight into preparations for a digital Congress realized in IRCAD Strasbourg. Many thanks to our president, Henri Steyer, as chairman, and to Philippe Montupet as Congress coordinator. They showed an overflowing enthusiasm that encompasses us all. First of all, we have created an executive task forces composed by 5 people, Henri Steyer, Philippe Montupet, Mario Mendoza, Ciro Esposito, and myself. And this ETF collaborated closely with the executive board members Fabio Chiarenza, Maria Grazia Scuderi, Nazia Ken-Dunlop, Carlos Ginet, with the head of scientific committee Alessio Piniprato, the webmaster Joseph Babala, and the executive assistant Gaia Tamaro. We are very excited due to the record number of registration, over 800 registered, and we should emphasize that the Congress has been granted 6 credits by the European Accreditation Council for continuing medical education. And also, it is very important that the Congress is free of charge. And because everything in life is cyclical, at the end of the Congress, 2 changes will take place, the President and the Honorary Secretary. So, I wish you a very interesting and exciting Congress. Thank you.
Thank you, Isabella.
Thank you.
Now, a little word from Philippe.
Thank you, Henry.
It's a great pleasure. Thank you, Isabella.
Thank you.
You should be here with us, but due to the pandemic, your flight was only delayed, I think, but it was too complicated for you to be here. So thank you very much for your brief history of the Congress. I should focus on the importance of our executive task force having prepared the Vienna Joint Congress with IPEG, because IPEG members are very close friends, and we were, all of us, very sad about the pandemic. So I have to thank and to focus on the confidence of the executive board, yourself as the secretary and with the president. We agreed, especially with the help of Ciro Esposito from the ETF, to maintain the big events of the 10th Congress. It was not only a big event, but it was unavoidable. So we had to find the solution, the best one, in the best learning center, probably in Europe. IRCAD Strasbourg, it is, for a while, for 20 years, more than 20 years. And thanks to the friendship with the director of pediatric courses in the IRCAD, with François Beckmer, he was the first friend in this big challenge of IRCAD with Jacques Maresco, the founder and the president, current president. It was possible. So it's a great pleasure. You are not here, but François is here. Please, François, could you tell some words for your excellent welcome and to thank Jacques and yourself?
Thank you, thank you. Thanks a lot, Philippe. Dear colleagues, dear friends, thanks to this e-Congress, it's now possible to remove the mask. And all the day, we will stay like that. That's extraordinary. We seem to be free again. At the beginning of this year, I remember days after days, we discovered that many congresses could not be possible, and days after days, they were canceled. We were sad, and at this moment, Philippe Montupet, remember a call from Philippe, Henri Steyer, Mario Mendoza, all the board of ESPES were sad. But you tried, you were thinking about that, and you tried to find a new solution for the ESPES meeting. Well, we discussed with Jacques Maresco, and Jacques Maresco said, obviously it's possible, it will be possible. And with his very efficient teams, well, the web search team, the audiovisual team, all of these people that are extraordinary, they work and help us for our and your ESPES society. Then everything became possible. And this e-Congress was not only a dream, but an astounding opportunity to be able to meet together and to share our experiences and friendship. That's very important too during a Congress. Please, so take advantage of this extraordinary opportunity to get our annual Congress, even if it seems to be impossible at spring. And we expect you will participate all the day as possible and send your chat, send your questions and open discussions and give your remarks. The success of this e-Congress will only depend on you. Of course, you are alone, perhaps with some friends and colleagues in your office. You are alone behind your laptop, but we will be able to listen to excellent presentations and to discuss as usual. We hope it will be like that. Keep in touch during all the day and imagine we are all together in Strasbourg, in IRCAD, and for this new kind of e-Congress. Thanks a lot, and thanks again to Jacques Maresco and his marvelous team.
Thank you, François. You, President?
Some very practical things before we begin the session. if you want, it is repeated on the screens, but if you are not so able to use Zoom and things like that, don't forget that if you want to ask for a question, you can raise your hand. There is a button on your screen, but you can also send an SMS through the chat. Don't forget that. And at the end of the Congress, don't forget to stay in the rooms, because there will be, like usual, 2 awards that will be distributed by the Scientific Committee and Alessio Pini-Prato. So if you want to know if one of your paper was elected as the best paper of the Congress, stay at the end of the Congress to receive your award. Philippe?
Yes, thank you, Henri. I just should give you some brief report of the history of the scientific program. First, we had to choose a way to select communication and presenters. Second, to chair it. So we decided this with 2 excellent collaborators from the executive board, who are Nazia Kendelop and Alessio Pini-Prato, and close with the president, to adopt a method which is, and which was, first, to agree the best presentation selected beforehand for the Vienna Congress, but in full respect of our friends from IPEG. As you know, we started to have a very good webinar last week. But we maintain a congress, not a webinar, a one-day congress. First, the best paper, and respectful from the IPEG selection. Second, to chair the sessions, we decided to involve our executive board. It was impossible to check for other chairman, it was too late, and each member of our executive board was involved this year as a chair. It will be excellent because they were members of the executive board. Now we have very few minutes, and I'd like to present you our technical staff of the IRCAD, just behind the window. And please, you can move the camera to present your team, the team of different, okay, okay. You have Mario Mendoza. He's like a very, very strong technician for ESPES, but also for IRCAD too. Close to him was Carlos Alves, and you have David Indelbrand, Melody, Di Rosa, and Meyer, Alsatian and Italian, and Thibaut Ballant. Hello, Thibaut. So we are very close, we are very efficient. It's only 5 minutes to start the first session. Each session will last 1 hour, no more, no less. And we just do enjoy a few minutes to resume the pleasure to be here with us and all of you. Thank you for more than 800 participants and registrants this morning. More than 800, a big success. And thank you, the IRCAD. Thank you, President. Thank you, Francois. Jacques Maresco is in Paris for us. He's invited by our president for, I don't know, maybe a celebration. So he's from his heart with us. Thank you, Jacques.
So I think it's 5 minutes before the first session will begin. So like in all congresses, it's time for a coffee break. So everybody have a good coffee break, and we see us back at 9. Okay, here we are in the Congress again. I hope the coffee break was great. So it's my pleasure for the first session to introduce to you your first chairperson, Alessio Piniprato, who is the head of the scientific committee of the ESPES. It's also the occasion for me to tell you that Alessio will have some very important information to share with everybody at the end of the Congress during the General Assembly. Also time for me to say that at the end of a session, you will have poll questions organized by Mario Mendoza, but he will explain that to you. And before we begin, because I see that the first speaker is Anna Catarina Barroso, so it's a great pleasure for me to say to Anna Catarina a big kiss. Alessio.
Thank you, Henry. Thank you so much for giving me the opportunity to chair this first section on GI and colorectal hepatobiliary. And I want to thank the organization and to underline the impressive energy and enthusiasm that Philippe provided for this organization. And I'm really impressed. So just to go straight to the presentations, the first speaker of this session is Dr. Barroso, that was already introduced by Henry, who will present a paper regarding laparoscopic pyloromyotomy as an introduction to minimally invasive surgery of the neonate. 5 minutes presentation, 3 minutes of discussion. So please, Dr. Barroso.
Good morning, everyone. I'm really happy to be here today. So thank you. I am speaking from Braga, Portugal, where I am a resident in pediatric surgery, and I am talking about laparoscopic pyloromyotomy as an introduction to minimally invasive surgery of the neonate and infant. Since it was described by Hirschsprung, the major events that marked the history of hypertrophic pyloric stenosis was, of course, the introduction of Fredette Ramstedt pyloromyotomy, and later, the laparoscopic pyloromyotomy, first described by Alain et Grousseau, that is now considered the evidence-based choice. But is it safe for residents to start with? Authors have been writing about it and stating that it has excellent success rate with low morbidity, and it is a safe, effective procedure in a resident teaching environment. So our aim was to assess our surgical results and evaluate the safety of the procedure when performed by residents. At our department, from June 2011 to July 2020, we have operated on 45 neonates and infants who undergone laparoscopic pyloromyotomy, who had a mean age of 34 days old. We collected data on surgeon category, duration of the procedure, per and post-operative complications, time to full feeding, and length of stay. And then we created 2 groups, the surgeries performed by the assistants and the group with the surgeries performed by the resident in order to compare both outcomes. And this is a video of how we do it. We place a 5mm umbilical trocar for the optics and 2 stab incisions. And now I'll challenge you to find out which one is the resident performed surgery and which one is the assistant's. So what we do is we use the Alain-Grousseau pylorotome to make a linear incision. And for that, we select a vascular area of the pylorus, so we don't use coagulation. Then we use the spreader to open the muscle layer and we open it well, especially in the gastric tip. At the end, we ask the anesthesiologist to fill the stomach with air in order to confirm the mucosa integrity. And in case you didn't find out yet, the resident always takes a little longer than the assistant, just to make sure everything is done properly. And that's it. And these were our results. 73% of surgeries were performed by assistants, while 27% were performed by residents. In these days, in the last 2 years, more than half of the surgeries are performed by residents. So outcomes were very similar among both groups. Duration of the procedure was slightly higher in the residents group, but it was not statistically significant. And there were no differences in pair and post-operative complications, time to full feeding, or length of stay. So to conclude, we think laparoscopic pylori myotomy can be safely performed by the resident under surveillance and support of an experienced assistant, and so it should be part of basic skills training in minimally invasive pediatric surgery. Thank you so much for your attention.
Thank you, Caterina, and appreciate you being strict to the timing. And so if there are any questions, otherwise, I've prepared a couple of questions that can be useful to understand your study. Can we show them, or I will just go straight to the questions because we've done okay. I'm not sure if you can see them. Okay. I was wondering if you did standardize the post-operative refeeding in these patients, and if it was different from what you previously did with open pylori myotomy.
Okay, so what we do in these neonates and infants is when they are awake and we think they are really awake, we start full feedings, and we just wait for them to tolerate. Sometimes around 30% of them will vomit after surgery, but still we think the best approach is to start already on full feedings. And it's not very different from what we used to do with open surgery. But we think that with laparoscopic surgery, they will vomit will be less frequent than what used to be with open surgery.
Okay, thank you. The other question, okay, there's a question from Paris, from Dr. Bernard, who asks if the assistant was present and scrubbed on the surgical field, or the resident was alone, I mean, without his assistants on the field.
Okay, my department started to have residents from 2016. So by the time the assistants thought it was the time for the first resident to start doing the procedure, as long as he is at the hospital, normally the resident is doing the surgery.
Okay, there's just space for another questions. Otherwise, I want to ask you, if nobody else wants to add anything, if you randomly assign the procedure to a resident or to assistants, or if you choose the patients on which to operate. I mean, if the patients that were operated by the residents were different in terms of weight, general conditions, or not. There's a slide with the questions if you want to read it.
So what we think is that even if it's the resident, as long as he is with the experienced surgeon, we will do it whenever, whatever the weight of the patient. So that's not a contraindication for the resident to perform the surgery.
Okay, just the last question, because I've seen another question here. I think this is the last, because we need to go straight on. A question from Irene Digues. Which year does residents start doing the procedure?
Sorry, I didn't understand, and I
Sorry.
can't see the question.
Okay, which year does the resident start doing this procedure?
It is variable, but I would say third year, fourth year. But what's most important is that before doing the surgery for the first time, we do have to practice laparoscopic surgery at the lab. So we have that facility, we can do it. So that's more important, that we show that we have skills to do it before doing it for the first time at the hospital.
Okay, thank you. I apologize for the other questions, but I think we need to go to the next presenter. So thank you so much, Katarina.
Thank you.
And congratulations.
It was really a pleasure.
So the second presentation is a technical innovation and is presented by Dr. Benko from Vienna, Austria. And the title is First Laparoscopic Pediatric Nesson Fund Application Using the Human Extension Handle Software-Driven Platform. So please, 5 minutes presentation and 3 minutes discussion.
Good morning, ladies and gentlemen. Warm greetings from Vienna. It is a great pleasure and thank you for the opportunity to share our experience with the first-time use of a new laparoscopic platform in pediatric fundoplication. The authors have nothing to disclose. The demanding steps in pediatric Nissen fundoplication are the creation of the retroesophageal space and the hyatoplasty. The human extension or hand-X system offers the advantages of robotic surgery to overcome the drawbacks of straight instruments in modern laparoscopy. The hand-X system is a new handheld, fully articulating 5mm software-driven platform, which we used in the following case. We present a Nissen fundoplication done in a 12-year-old neurologically impaired patient. He was born in the 34th week of gestation and suffering from perinatal asphyxia. He presented with gastroesophageal reflux disease, presenting with histologically conformed esophagitis with confluent ulcers in the distal esophagus. Now we will switch over to the intraoperative video. Let's check just a second. Anti-reflux surgery. One of the initial steps is the dissection of the right and left crus. In this case with dense adhesions due to chronic inflammation of the esophagus. The angle of His is mobilized. One of the key steps is the creation of the retroesophageal space. The hand-X is brought into the abdominal cavity from the patient's left side. The angulation of the instrument allows mobilization of the retroesophageal space and a controlled passage of the instrument behind the esophagus. The hyatoplasty is challenging with conventional instruments, especially in small children and infants. The angulation of the instrument can be locked at any angle. The locked instrument can be used to push the esophagus aside to ease the stitch on the left crus. The instrument stays locked to grasp the needle after the passage through the right crus. The articulating tip is used to perform intercorporal knots as usual. The instrument is also helpful in picking up the loose end of the suture. slipping knot is tied, but without a loose end in between. The hyatoplasty is completed. The formation of the 360-degree Nissen wrap should include the esophagus. The fundus has been already stitched on the patient's left side. The angulation of the instrument allows the needle to follow a 90-degree angle to the desired plane of tissue. The passage of the needle through the muscularis of the esophagus is controlled without any tension. The posterior fundus is grasped and pulled through the retroesophageal window. This platform overcomes the disadvantages of a straight instrument. You can see its full range of motion. The instrument is locked in the desired position, the needle is picked up in the correct angle, and only the tip is rotated to perform a controlled stitch. The 360-degree fundoplication is completed via the final sliding knot. So thank you so much for your patience, and again, warm greetings from Vienna, and I would like to hear your questions.
Okay, thank you so much. You've been sharp as well. There's a question from Dr. Buchner, who asks if the instrument is heavy and if it is easy to handle and to hold the device.
I didn't understand everything, but to hold the device, probably we could, I don't know if we can come back on the presentation, but the device is just handheld, and it is connected in the OR, and there are two different parts. One is reusable, and the other part is a one-way instrument. Only the tip of the instrument is not reusable.
Yeah, Dr. Weber asked if it is heavy. I mean, if it is very...
the weight. No, the
Yeah.
weight. No, it is not. Yeah, it is. You feel it in your hands. The weight is, but it's not stressing on your hands. We used it in both hands, on right and the left hand, and it takes quite a time of training before. It took us 1.5 days of quite intensive lab training, and this is the first case we did, and this is the first time we used it in a patient.
Okay, there are two questions which are the same I was thinking before seeing the presentation, which are from Dr. Bustangi and Dr. Siedler, and they ask the size of the port used, if there are 5 or 10 millimeters, and the cost of the device.
The ports are 5 millimeters. We use only 5 millimeter ports, and the camera was also 5 millimeter camera. And the cost I cannot tell you exactly, but this is quite new on the market, and we didn't talk about the price. I'm sorry, but this is something they will put out in the near future, I think.
Okay. There's another question. Okay, they are asking if you used, or if perhaps you will use in infants or only adolescents.
Since it is a 5 millimeter port, and I think it's a little bit too big for use it on children smaller than 5 kilos of weight, because the rotating tip uses a little bit of space, and this is the limitation for very tiny children, I think.
Yeah, that's just another last question, which asks you, when did you start feeding the patient back after surgery?
We give them feedings on the same day. So we start with medications on the same day and then advance to full feeds in the first 24 hours.
Okay, I thank you so much. I don't think there are any other questions because I don't see anything coming up. And thank you and congratulations for the presentation.
Thank you so much.
Okay, we go to the next one, which comes from Paris. Dr. Pio will present robotic ileocecal resection for Crohn's disease in a pediatric setting. 5-minute presentation, 3 minutes discussion.
Dear Chairman, dear colleagues, thank you for this opportunity. I'm a fellow in Pediatric General Surgery unit directed by Professor Bonnard in Robert Debré Hospital in Paris. So today I will show you our preliminary experience on the robotic approach for the treatment of Crohn's disease in case of ileocecal stenosis. So, as you know, the ECHO and ESPES guidelines well indicate the indication for surgery, but the approach and the surgical approach to this condition is not validated, and preliminary experience on this approach and with minimal invasive surgery is reported in the last 10 years. The current literature in adult surgery show different procedures to the treatment of Crohn's disease for adults, but in pediatrics to date there are not paper or experience reported. So as you can show, a robotic setting is a setting with the robot that come in the up front of the patient. The dorsal lamb is sur-elevated, and we use a suprapubic approach with 4 ports and an assistant port in the left inferior abdominal quadrant. So I will show you the technical procedure.
I don't know if your video is sounded, because
Yeah.
there's no sound. You can perhaps comment it.
You cannot hear the sound?
No.
Okay. So we started with the told dissection. So the dissection is done to the low, to the up. We control the mesocolonic plane with a vessel sealer device. So we use a stapler and a robotic stapler to cut the ileus and the colon. And we will perform an isoperistaltic side-to-side anastomosis. This is a stay suture to help us to perform the anastomosis. So we perform the ileotomy and colotomy with monopolar scissor, and we will perform the posterior suture mechanically. And we will perform a continuous suture for the anterior wall of the anastomosis. So we will close the mesocolon window. and we will remove the bowel with a plastic bag. So you can show at follow-up the postoperative cosmetic results. So for this procedure, the consult time was 125 minutes. We did not have intraoperative or postoperative complication, and discharge from the surgical unit was done after 3 days. And we have no complication for this patient at the 6-month follow-up. I want to say you that we operate to date 4 patients. We have one complication in one patient with a postoperative abscess that would not require any surgical procedure. And this is in the only patient that at surgery had an inflammatory status and a very severe occlusion. Thank you so much.
Thank you, Dr. Pio. And there's a question. They asked, Dr. Balat asks if you lavage, if you irrigate the bowel, the peritoneal cavity, and if you leave the drain.
No, we never leave a drain. We use the assistant port to do aspiration during the opening of the ileus and the cecum. We don't perform any kind of specific preparation for this kind of patient.
Okay. Okay. There's another question here. Did you consider the stapler anastomosis? I think that you already answered to this one.
Yeah, for the posterior suture.
Okay. I have. In the meanwhile, I wait if anybody else asks you anything. I didn't understand if you performed a marginal or a proximal ligation of the ileophilic vessels.
It is a distal ligation. Okay. Because the resection is the distal ligation if the resection is limited to the cecal segment of the bowel. Okay. We do not have the necessity to ligate more below. We ligate obviously below if the resection is more extended to the colon or to the ileum, to the terminal ileus.
In case the stricture is carries a big abscess or a big thickening, to ligate proximally allows you to avoid difficulties while doing marginal hemostasis and marginal ligation. Anyway, I got another question. Given your expertise on this area of robotics and inflammatory diseases, do you think there's a possibility to perform structuroplastic or other procedures in pediatrics? And which are the indications you suggest for robotics in pediatrics?
I think that this approach is very interesting for the colon approach in this kind of patient. Here we started with the ileocecal resection, and to date we have not the necessity to perform a structuroplastic, but I think that we can expand the indication of the robotic surgery for the colon approach, because as you know, with the suprapubic approach, we have a clear and directly exposition to the colon, and for the right colon, the left colon. And I think also for the bowel, we can use the same approach.
Okay, thank you. I just wonder if anybody else has got any questions. If Philippe, Henry, or I will go over. Thank you, Dr. Pio, and congratulations for your presentation and the video.
Thank you so much.
So the next presentation is from Turkey. Dr. Lingon will present a laparoscopic gastric transposition in a patient with total situs inversus with corrosive burns. Again, 5 minutes presentation, 3 minutes discussion.
Good morning, everybody. Good morning, every colleagues. Thank you for all. And today I will present a case, and I am Ibrahim Uygun from Turkey. Sorry. Can you hear me, please?
Yes, we can.
Okay. I will present to you laparoscopic gastric transposition in a patient with total situs inversus with corrosive burn. The patient was a 9 years old male with corrosive burn due to ingestion of drink cleaner. He had also situs inversus totalis, you see, and he had persistent and long segment esophageal stricture. After 18 dilatation, his family accepted esophageal replacement at the end. And laparoscopic gastric position, gastric pull-up procedure was performed successfully. Hook cautery and ligature were used in the operation. You see, the stomach and spleen are on the right. Firstly, the stomach was dissected by protecting the right gastric artery, especially according to patient left gastric artery because he had situs inversus totalis. And then esophagus was totally dissected by transhiatal and cervical approaches. By using hook cautery, also ligature, and also cervical incision, blunt dissection by finger, we used. This is esophagus and dissection of the esophagus by hook cautery. This procedure is almost the same for the not situs inversus totalis patient. However, we should be careful because all internal organ was the opposite side. Dilatation of the hiatus. Hiatus was ligated and dilated. There were excessive adhesion in the middle esophagus, which is the burned area especially. Transcervical finger dissection helped to do esophageal dissection. After all dissection were done, the stomach and esophagus were pulled up through the mediastinum to the cervical area. You see. Then esophagus was resected and cervical esophageal gastrostomy was done. This is the port, and this is esophagus and also gastrium. This is resected esophagus. Yes. And the patient has no problem during follow-up and can swallow all food and resume normal life for 3 years. Thank you for your attention.
Thank you for your presentation and for the video. I don't see now actually any questions, so I will start asking you if you did pyloromyotomy or pyloroplasty, and if you did a jejunostomy, or if you didn't do anything of this.
Could you repeat, because sound is...
Sorry, I'm asking if you performed the pyloroplasty or not, and if you performed a jejunostomy for the immediate post-operative period or not.
We don't any jejunal procedure or pyloromyotomy because we think it's not needed, and also we use gastric decompression, and we not use any jejunal jejunostomy or other ostomy.
Okay, there's a question from the president, Henry.
Congratulations for your paper. How long is the follow-up of this patient until now? And do you have swallowing problems with this patient or not?
The follow-up was 3 years, and also he can swallow all food, and there is no any esophageal stricture.
There's another question. I remind you that the question should be sent with the rising hand and not with the chat anyway. They are asking if and where, sorry, did you place the anastomosis on the stomach? I mean, did you anastomize the esophagus to the cardiac or to another site in the stomach?
The sound is very bad, and
so the question is, where did you do the anastomosis of the esophagus on the stomach? Where did you do the anastomosis?
Fundus.
Okay.
Fundus is also standard, and we cannot use the esophageal stop.
Okay.
We cannot.
Congratulations.
Thank you so much for all.
Okay, thank you. Oh, sorry, there's another question from Dr. Beckner. He's asking, how did you close the diaphragm in order to avoid a secondary hernia?
Your sound is
okay. I repeat the question.
Okay,
I repeat the question.
Okay.
How did you close the diaphragm? Or did you close the diaphragm, the hiatus?
We dilated hiatal, esophageal hiatus, because through the mediastinum, stomach go up, and we do not closure the stomach to diaphragm, but sometimes we used stick stomach to diaphragm, but not routinely.
Okay. So thank you so much, and congratulations for your presentation.
Thank you. Thank you.
So we are in time. I mean, we are in advance actually, and so we can go to the last presentation from Germany. And Dr. Kubler will present on laparoscopic resection of coliacal cysts technical details, controversies, and long-term outcome. So please, 5 minutes and 3 minutes discussion.
Thank you very much, Mr. Chairman. Sorry, I have a slight cold. Choledochal or how is it working? Actually, my computer froze. Sorry. Okay, here we go. Choledochal cysts are also called choledochal malformations are rare, especially in Europe. They need to be excised to avoid problems, especially late malignancy. The first cases of laparoscopic treatment have been published 25 years ago. And after the first series, now a meta-analysis of laparoscopic versus conventional surgery has been published. In this meta-analysis, conventional surgery was associated with short operation time, but the advantages of laparoscopy were shorter time to feed and discharge, and also a slightly lower complication rate, especially intraoperative blood transfusion and adhesions. But there are also critical voices regarding laparoscopy. Several authors have described high complications rates after laparoscopic resection, and the group of Jan Hulscher in the Netherlands identified the laparoscopic approach as an independent risk factor in their cohort. And based on their results, they questioned whether laparoscopy should be used in European centers that have not so high incidence. So we had a look at our data and retrospectively analyzed our complete cohort of patients with choledochal malformation since 1978. All in all, 102 patients. 59 of them were operated laparoscopically, 43 of them conventionally. And the complication rate was slightly lower in the laparoscopy group compared to the open group. Of course, there's a little bias in the result with patient selection. There was a clear institutional learning curve with the rate of complications decreasing constantly with each 20 consecutive patients. This learning curve has also been reported in the big series from Asia. In these series, 200, 400 patients, the complication rate is minimal. If I put my own learning curve next to it, I'm not so bad, but still there are some 100 patients to go. What you can see is that the operation times are slowly decreasing. A very important aspect of choledochal malformations is the increased risk of malignancy in untreated patients. Here, a review we did showing an increasing risk with age and a very low risk in childhood. So what's causing this? In choledochal cysts, there's biliary stasis and increased concrement formation. And there's also typically a long common channel that causes pancreatic reflux in the biliary tract. All of this leads to a chronic inflammation of the biliary tract. This chronic inflammation leads to a sequence of hyperplasia, metaplasia, dysplasia, and finally carcinoma, stages that are characterized by certain markers. So to prevent this sequence, we have to prevent the inflammation. And therefore, good bile flow is more important than complete cyst resection. We examined the stage of the biliary epithelium in our patients at the time of cyst resection and screened tissue samples for two early markers, K-RACE and BRAF. The average age was 2.2 years, and also we detected sometimes strong inflammatory changes, even in patients without clinical symptoms. None of the patients at this age showed our markers of early degeneration. In line with this, we did not detect any case of biliary carcinoma in any of the patients in our cohort. So in conclusion, in our cohort, the complication rate of laparoscopic hepatocolionostomy was lower compared to conventional surgery. There's a clear and ongoing learning curve, and early operation appears to minimize the risk of the hyperplasia, dysplasia, carcinoma sequence. Laparoscopy is a way to go. Thank you, and special thanks to my co-workers, Mariuka, Omid Madadi Sanyani, and Nujut Chukri. Thank you.
Congratulations, really impressive results and learning curve. And there's a question from the audience. The Dr. Chahid is asking if you included the conversions in the complication rate of laparoscopic surgery.
Yes, we included the conversions. And actually, most of the complications were in the converted patients.
Okay, and I have a couple of questions in the meanwhile. Wait, there's a question from the audience from Professor Wagner. He's writing, to have a good bar flow, what is your recommendation for the length of the transposed loop?
I think it depends a little bit on the age and the size of the patient. And the length of the loop is not as crucial as in biliary atresia patients, but usually we use a length of a little bit more than 30 centimeters.
Okay, thank you. I was wondering how many surgeons do perform this highly advanced laparoscopic surgery in your center?
The choledochal cyst resection and hepatogoenostomy, 2 surgeons are doing laparoscopically, and another surgeon is doing it openly.
Okay.
And in our cohort, so when we go 30 years ago, there were 3 other surgeons doing open cyst resection.
And from Dr. Hanan Mitu, he's asking if you've got any comment on a particle duodenostomy for congenital malformation.
Our experience with this is quite limited. We did, I think, 2 patients openly with short bowel. So we did the hepaticoduodenostomy to save bowel. But we are a little bit afraid of the reported incidence of biliary reflux. So we leave this up to the Asian centers to really explore the long-term consequences. We are very happy with the hepaticoduodenostomy. We don't see any problems related to this. So we are reluctant to change.
Okay. There are another couple of questions from Dr. Bustangi. He's saying, excellent. Do you leave part of the cyst to make the anastomosis easier, or you do complete resection?
In many times, the cyst is going up into the liver, and we will not go into the liver for the preparation. We try to go into the pancreas as deep as possible and take out everything of the cyst in this area. And we will go up to the liver, to the place where just shortly under the liver surface, where you can safely perform an anastomosis, but we will not resect the liver parenchyma in order to get a complete resection. I think establishment of good flow and prevention of pancreatic reflux is more important than the complete resection.
Okay, the last question here is from Dr. Sidler. How was the hepaticoduodenostomy sutured? Would glue assist in prevention leaks?
So I prefer single, so interrupted sutures, but this I think is personal preference. I'm just more used to do it and feel more comfortable with this. I know many people are doing it with running sutures and they are doing fine. I use Vicryl. Many people use PDS or Monocryl. The leakage rate is actually in the laparoscopic group quite low. I think this is also due to the very good vision you have during the anastomosis. If we are not completely comfortable, sometimes we leave it drain, but usually we don't leave it drain after the operation.
Okay,
I hope this answers the question.
Okay, the last question, because I think this was a very interesting topic. They're asking Dr. Raman Mitud, again, he's asking if you perform a perioperative cholangiogram or an MRI, for example.
Well, that's a very good question. Usually we don't necessarily do it. We do an ultrasound as like standard diagnostics, and we don't do necessarily further diagnostics. In unclear cases, an MRCP is helpful. And if there is obstruction, we like to do an ERCP and stenting and papillotomy in order to relieve the obstruction. But this in young patients is a little bit different because there is always the risk of biliary, so cystic form of biliary atresia. So when you have a patient below 3 months, 4 months of age who presents with a cystic structure or like a choledochal cyst and obstruction, it's quite likely that you are facing a cystic form of biliary atresia. So then prompt surgery is mandatory. And in these cases, we prefer the open approach because we have not had so good results with the laparoscopic Kasai.
So thank you for your honesty. And I think that was a very interesting topic. Thank you for your presentation. And I thank again all the presenters for being sharp and for being very brilliant with their topic and presentation. We've got 10 minutes in advance, so I think that there's space for the pool questions.
Exactly.
And,
we have the time for one pool questions. We invite all the participants to answer to this question, and then you will have the result very quick. So, do you think that laparoscopy could be the best surgical approach in the treatment for choledochal malformations? You have 3 options, and we invite everybody to vote. Yes, everything is voting. We're waiting.
Joachim?
We're waiting for.
Joachim? Hello, Joachim. Do you have a robot in Hanover?
We have,
Did
but
you try it with the robot?
We did not try the choledochal malformation because usually the patients we operate are quite young. So right now we are operating mostly below the age of 2, and I think it's a bit small for the robot.
Okay, we're going to share the result of the questions. 86%
Yes.
vote. There you go. This is a good result. Perfect. Alessio, do you have some comments?
well, if we sum up the yes and the robotic surgery, this means that 84% will opt for minimal invasive surgery, which is something very new and something very impressive. And I agree with this pool question. So thank you, Mario, for adding this.
Thank you very much. And we would like to remind to everybody that you can ask all the questions that you want. You can go to the questions and answers tab, or remember that also you can push the button, raise your hand at the bottom of your screen, and you can be able also to place your question directly with your microphone and interact directly with the speakers. Henry?
So, and it's also the moment to remind the industry that we need a robot adapted to little children. Please.
We can patent them, and then we can participate in the development of those. Anyway, I want to, just as we've got 5 minutes before the next session, I want to thank again Philippe, Henry, and all the ESPES board for allowing me to start with this session, which was very interesting, and all the presenters were brilliant. So I think this is a good start for this Congress. Thank you so much.
Okay, thank you, Alessio. I think we will have a 5-minute coffee break because we have to contact all the other people. 4 minutes. We have to contact all the other people for the next session. So a little short coffee break. I think Mario has something to add.
Yes,
Mario?
at 10, we will start.
At 10, we will start again with the next session. See you in a few minutes.
Perfect, see you.
Hello, good morning again. It's starting for the second session, which will be chaired by a woman, good parity in the ESPES society. Nazia is from Necker from Alat Hospital. She's in charge and she's committed for thoracic surgery. And also, Nazia, I thank you very much. I'm very grateful, like Henri, because you worked a lot for this Congress, for the scientific program with Alessio and other board members. Thank you to start your very good session with 6 presentations.
6 presentation indeed, so we'll try not to be late. And just I would like to really thanks again, Henri, Philippe and Mario for the great job they did also, and thanks of course IRCAD and François Beckmer for this incredible opportunity they gave us to organize this very great first e-Congress. So the first presentation will be also from a woman, from Louise Montalva, and she will talk to us about ERAS protocol in pediatric thoracoscopic surgery. Louise, please, 5 minutes.
Hello, thank you for giving me the opportunity of presenting our work. I will now share the presentation. Okay, should be good. So yes, I'm also from Paris, from Robert Debré Hospital, and I'll be presenting our work regarding ERAS protocol for pediatric thoracoscopy that allowed us same-day discharge. So thoracoscopy was first reported in children in 1976 for lung biopsies. Until the mid-90s, it was mainly a diagnostic procedure with minor intrathoracic manipulations. Between the mid-90s and 2002, all pediatric conditions that had been previously approached using thoracotomy could be successfully treated with thoracoscopy. Nowadays, thoracoscopy is widely implemented worldwide, although not all surgeons choose to use thoracoscopy for the most complex procedures, such as PDA ligation or lung resection. So recent evidence has shown that choosing thoracoscopy has variable benefits depending on the type of procedure. Regarding PDA ligation or CDH repair, for instance, thoracoscopy decreased operative time and length of hospital stay especially, but also comes with an increase in the complication rates. So understandably, the use of thoracoscopy is controversial for those two conditions. Regarding esophageal repair, there was no difference in the length of stay or complications. However, when it comes to lung resection, a recent systematic review, including 36 studies, showed a decrease in length of hospital stay and complication rates. This highlights that thoracoscopy is the ideal approach for congenital pulmonary airway malformation in children. So enhanced recovery after surgery has been widely implemented worldwide. It aims to optimize perioperative care in order to improve recovery, reduce postoperative morbidity, and decrease overall cost. Up to 21 items before, during, and after surgery can help achieve these goals. However, a recent survey showed that only 20% of American pediatric surgeons are already implementing ERAS protocols in children. Moreover, a recent systematic review in pediatric surgery picked up only 5 articles that included ERAS after pediatric surgery. So can ERAS be applied to pediatric thoracoscopy? We first implemented ERAS protocols in 2010, which we modified in 2013. But the cornerstone of our protocol was the progressive decrease in the use of pleural drains. Pleural drains used to be routine before 2010, and by 2013, no pleural drains were used for extralobar sequestration, minor pulmonary edge resection, and bronchogenic cysts. This protocol led to a decrease in the length of hospital stay from 4 to 2 days with this protocol. But mainly, it's raised the question of performing thoracoscopy as a day case surgery, as these children did not have a drain anymore, but required overnight stay. So the aim of the study was to evaluate the outcomes of children undergoing thoracoscopy as outpatients. We conducted a retrospective study between October 2015 and December 2019, including all children that underwent thoracoscopy as outpatients. In our institution, we are lucky to have a very well-developed ambulatory surgical department where each child arrives in the morning, receives a teddy bear and anti-slip socks if he is in age of walking, and goes home in the evening. In order to be eligible for this type of surgery, the minimal post-conceptional age was 60 weeks, which means between 4 and 5 months for a term baby. The child has to show no signs of active infection, and the parents have to speak and understand French in order to extensively be informed about the surgery. So our ERAS protocol included 16 items before, during, and after surgery. The surgery was performed in a lateral position, and we inserted a 5mm 30-degree camera just under the tip of a shoulder blade. We then inserted 2 to 3 operative pores measuring 3 or 5 millimeters, depending on the type of procedure. And once the resection had been performed, we administer a single dose of local anesthesia using a paravertebral catheter. This catheter is introduced under vision with a thoracoscopy and is taken out once the single dose is performed. We then, the lung is then expanded using ventilation and the pneumothorax is exsufflated using a drain. Once all the air is extracted, we take out the drain and close the skin. After surgery, the child is quickly fed and mobilized. He only receives non-opioid oral painkillers. And 2 hours after surgery, we perform a chest X-ray. The child goes home in the evening, and the next day a nurse calls the parents to make sure that the child is doing well. And the child is then seen 1 month later in the clinic by the surgeon. So the criteria for same-day discharge is a stable hemodynamic state, pain control with oral paracetamol and ibuprofen, and a chest X-ray which is normal 2 hours after surgery. The child also has to tolerate feeds in order to go home. The primary outcomes of our study was same-day discharge, complications, and 30-day readmission. A total of 21 children underwent thoracoscopy as outpatients during these 4 years. More than half of the children had extralobar sequestrations, 24% had intralobar sequestrations, and 90% had bronchogenic cysts. All lesions had been diagnosed prenatally, and the median age at surgery was 6.3 months. Regarding the outcome, 95% of the children were able to be discharged on the same day. The only child that wasn't discharged had actually an infected intralobar sequestration and required a hospital stay for IV antibiotics and monitoring. He actually underwent an inferior lobectomy 2 months later for misdiagnosed CCAM. There were no complications during and after surgery, and no child was readmitted within 30 days. So as a conclusion, same-day discharge after thoracoscopy is feasible and safe for selected children. This ERAS protocol is now fully implemented in our center and has allowed us to adjust prenatal counseling for pregnancies with congenital pulmonary airway malformation. We now tell the parents that the child will likely be operated as a day case surgery, depending of course on the type of lesion. So ERAS protocols have been implemented later in pediatric surgery compared to adult surgery. We have recently performed a systematic review and meta-analysis on ERAS in pediatric minimally invasive surgery. We actually found 9 articles, which is more than the 5 articles a few years ago, showing an increased interest in the subject. And we found with our meta-analysis that ERAS actually decreased length of stay and 30-day readmissions after minimally invasive surgery. So we believe that children are ideal candidates for ERAS, but also for day case surgery, as this is less difficult for families to actually not stay overnight at the hospital. As this recent study in 2019 just said, we believe that the era for pediatric ERAS is here. Thank you for your attention.
Thank you very much, Luis. So we are just a little bit late, so we have to move on. Thank you for sure for this impressive work, and for sure we have to move on and to go further, find new solutions, especially in this difficult economic situation. Just one question. So one question from François Beckmer. The question is, how do you evaluate pain and discomfort at home for all these children?
So we evaluate the pain before they leave. So if they are painful, despite the paracetamol and the ibuprofen, we wouldn't be discharging them. So in the evening, we tell the parents what to look for if he's painful, just as any other day case surgery. When we operate hernias in day case surgery, we let them go home, but the parents have to be able to assess and understand the different signs that have to make them call us. And then the next day, the nurse also evaluates the pain by asking questions to the parents. So of course, it's not direct assessment as we would have at the hospital, but for now it has worked well. So,
and in case
just as minor surgeries that we also perform as day case surgeries.
And in case of problems, they are required to come back to the emergencies?
Yet we haven't had any child come back within 30 days.
Okay.
For now. And that's 21 cases.
And in case?
In one case, the child wasn't discharged because the lesion was infected. So we actually had to keep on, we had to administer antibiotics for 5 days and monitor the kid. And he actually had misdiagnosed CCAM. So he underwent a lobectomy 2 months later.
Okay. Thank you very much. I'm sorry because there's another question, but we have no time for that. We'll maybe discuss it later on. I will keep it in mind. And we will move on to the next presentation. Thank you, Louise. Thank you very much. So the next presentation will be from Sarah Fernandez. It will be about thymic surgery. Sarah, please, will you share your screen?
Hello.
Hello.
Good morning.
Good morning.
I'm Sarah. Thank you for giving me the opportunity of sharing our work with you. I'm now presenting you a video that shows a minimal invasive resection of a large mediastinal mass that ultimately led to the diagnosis of a thymoma. This is the case of an asymptomatic 6-year-old girl that by the age of 2 was diagnosed with an incidental finding of a pericardial mass on a plain X-ray, a routine X-ray. Back then, the thoracic CT scan showed a thymic hyperplasia and an expectant attitude was decided. By the age of 5, the maintenance of this image of mediastinal enlargement led to further investigation, and the thoracic MRI showed a large pericardial right-sided mass with approximately 6 centimeters, maintaining the suspicion of a thymic hyperplasia, but not excluding the diagnosis of a thymoma. Therefore, surgical resection was offered. Thoracoscopic right-sided approach was decided. These were the perioperative considerations. We have used three ports of 5 millimeters inserted in these positions. And at the first inspection of the thoracic cavity, a large mediastinal mass was promptly identified with well-defined borders. Here we can see the inspection of the limits of the mass and the relations with the surrounding structures. The phrenic nerve was easily identified during this inspection for anatomical reference, and our resection begins with the opening of the mediastinal pleura with a vessel sealing device. As we saw before, since only the medial and superior border of the mass are attached to the surrounding structures, our dissection begins in the medial border, moving cranially until reaching the upper pole. We have used the vessel sealing device because it allows a more hemostatic dissection, maintaining a good quality of view of our operative field. As we see, we are progressing superiorly until reaching the upper pole. Here is where one of the critical steps of dissection takes place. We can see here the separation from the innominate vein with a blunt dissector, and here the separation from the superior vena cava. Now we are trying to dissect the right thymic vessels, again with the blunt dissector, and then we ligate them with a vessel sealing device, releasing this pole. The cervical part of the thymus was crest caudally to allow dissection from the surrounding structures. This was a bit more easier than the rest. And finally, our piece is completely released. The surgical extraction of the piece was accomplished with extension of one of the thoracic incisions and pulled out with a clamp. This is the macroscopic aspect of the mass. At the final inspection, no significant bleeding and no immediate complications were seen. The patient was admitted in the intensive care unit for surveillance in the first day. The chest drain was removed in the first day after surgery, and the patient was discharged home 2 days after surgery and had an eventful recovery. Histological exam showed a complete excision of a B2 thymoma. Since the resection was complete, no additional treatment was necessary, and the patient remains on clinical and imagological follow-up for the last 2 years and free of disease. Thank you all for your attention.
Thank you very much for this really nice presentation. Just I'm checking the time, of course. Sorry. Yes, nice. One question from the audience, I think. You spoke about once again. You spoke about double lumen tube intubation.
Yes.
What was the device used, and how is it available for very young children? And what is your practice?
The device for the exclusion.
Yes.
It was a double lumen tube. I don't know the right what really was the device. It was a double lumen tube inserted by the anesthesiologist. It's a standard procedure here at our center.
Because actually, Sarah, sorry, the double lumen tube is quite for biggest kids, around 30 kilograms. And
yeah, but this patient, by the age of 6, she was about 32 kilograms, so 32. It was a bit easy.
And
sorry.
What would be the question further is what would be your option for younger kids, because this thymic disease could of course occur.
Well, if thoracoscopic resection was not possible because of the interference of the lung, we have to maybe do it open with a thoracotomy. Luckily, we have been able to intubate this child just with a double lumen tube, but I think it will be an option, thoracotomy, as is reported by many centers.
No, but of course other possibilities can be used, blockers or selective intubation, it could be an option.
Okay. Maybe, yeah.
Okay. Just sorry. Another question is from Dr. Desai and Ashish. What was the CO2 insufflation pressure used during your operative time in this kind of surgery?
Sorry, I didn't hear you.
Sorry. What was the CO2 insufflation pressure that you used?
We have only used about 2 to 4 centimeters of water. It was almost not necessary because the pulmonary exclusion was really helpful.
Okay, thanks. Another question from Dr. Veronica Arriaga is which were the laboratory results before the surgery? Which about the laboratory results before your surgery? Where were they from? Your biopsy, I guess?
Before surgery, we only the information, the imagological information. Since the mass was too large, resection was decided with no biopsy, with no pre-operative biopsy. So the diagnosis was only found after the surgical specimen analysis.
Thank you. And the last question is, you are thanked by Dr. Nasir Boutsangi for your excellent video. And the question is, the resection, was it completed from all the right side or not?
The resection was complete, and the mesococcus staging was at a type 2 stage. The second stage showed only microscopic invasion of the capsule was seen on the histological analysis. So we consider the resection complete in all of the borders. Yes.
Thank you very
I don't
much.
think if I answer the question.
I think that, I mean, it was a left-sided complementary surgery needed or not?
No. We were able to pull the gland on the right side, and all of the gland was resected only the right side of the approach.
Thank you very much, Sarah. Thank you.
Thank you.
We will move on to the next presentation. The next presentation will be from Fluvia Del Conte. Fluvia, please.
Good morning to everyone. Now I start sharing my screen. So the aim of this study was to report the European multicentric experience with thoracoscopy management of children with congenital bronchopulmonary airway malformation. Congenitally bronchopulmonary airway malformation, mainly represented by congenital cystic adenomatoid malformation and pulmonary sequestration, are the most common prenatally diagnosed intrathoracic masses. Clinically, they can cause acute respiratory neonatal distress or infection throughout childhood, or they can remain asymptomatic. In our cases, we retrospectively review 102 cases in our series, was principally represented by CCAM and pulmonary sequestrations. As for preparative workup, we perform in all cases ultrasound, chest X-ray, and CT scan. For the patient was placed in lateral decubitus with operative side up, and the surgeon was located in front of the patients. For the first trocar, it was placed using an open technique on the middle axillary line through the 5th or 6th intercostal space. Generally with the port of the camera, a 5mm 30-degree camera. Two other ports, 3 and 5mm, generally are placed in triangulation. As for the technique, that can vary by the affected lobe and the type of malformation. So generally, we start mobilizing the lobe and taking care to identify any aberrant systemic vessel supplying the lesion that must be ligated and divided. Then we divide it in, first pulmonary artery, pulmonary vein, and bronchus. At the end of procedures, we can remove the lobe, the lesion by an enlarged excisions, whole or mostly. So the procedure was completely successfully using 3 ports in all cases. We perform 18 upper lobe resection, 20 middle lobe resection, and 64 lower lobe resection. We found in 35 cases an incomplete fissures, and we reported only 3 complication postoperative, with only 1 required reintervention. At the end of surgery, all symptomatic patients become asymptomatic, and for the chest X-rays at 1 month and 1 year after surgery, they were all normal. We reported also excellent cosmetic outcome. So we would like to underline some key points about thoracoscopy lobectomy. First of all, we think that have accurate preparative imaging for the lesion. It's very important, in particular to identify any aberrant vessel supplying the lesions. As for the optimal timing of surgery, we agree with the majority of the author that elective surgery must be accomplished around 1 year of age. As Rothenberg report, he found in all the patients that were apparently asymptomatic a various degree of inflammation that made surgery harder and dangerous. So our protocol for asymptomatic patients is to follow them and repeat a CT scan at 3 or 6 months of age. And if the lesion is confirmed, we plan the surgery in the next months. Another important point is the surgeon experience that remain fundamental for this type of surgery. In particular, it's very important to have in deep knowledge of the anatomy of pulmonary artery, veins, and bronch to perform also the more difficult surgery like incomplete fissures. So we recommended to perform first procedures under the guidance of an expert tutor. Last but not least, the importance of using new technologies. In particular, in our study, we found that the average operative time significantly decreased in patients in whom the vessel division and bronchial sealing were performed using sealing device compared with sutural ligations. As you can see in the videos, using sealing device, it's very simpler than sutural ligation. So in conclusion, thoracoscopy pulmonary lobectomy is a relatively quick and safe procedure with excellent cosmetic outcome, and it offers all missed advantages, but as usual, it requires a high skills level. So thank you for your attention.
Thank you very much, Fulvia. So thank you for this nice presentation and of course your videos. Thank you for this synthesis. And I think there's questions, a lot of questions actually. I'm late.
Nasia, there's going to be a participation also of Arnaud Bonnard, qu'il y a un petit commentaire à faire. Donc, il est en train de se brancher.
So try. Arnaud is trying. No, I think nobody for the moment. Arnaud, yes?
Yeah, can you hear me?
Yes. Definitely.
Okay, just a comment on the placement of the port and the trocar. I mean, it's depending how you want to perform the lobectomy, and if you want to make dissections of the fissure parallel or perpendicular, and you can use the one described by Fulvia. When the surgeon is placed on the front of the patients, but the other solutions is the surgeons placed at the foot of the patients and put the trocar in the lower chest, and to make the dissection of the fissure right away and perpendicular. So you can use also this placement of the trocar.
Definitely, thank you, Arnaud. There's a question from Dr. Ashish Desai. The question is, Fulvia, what was the longest operative time? Because we know that's for sure, and you said it's a really demanding surgery, and in case of inflammation, it could be quite hard. So what was the longest operative time?
Yes, I can reshare my screen and show the results. And one moment. It was 160 minutes, the longest one.
Okay, for 160 minutes to 2 hours and a half, more or less, a little bit less. So I may say maybe a comment that of course it could seem quite long, but sometimes it's difficult, and for sure the benefits for the post-operative course seems to me really better than a thoracotomy. So I think it's worth it. But maybe you have a comment, Flavia?
No.
No. Thank you. So thank you very much for this nice presentation. And so we'll move on to the next speaker. The next speaker will be Quentin Baloulet. Quentin, are you here? Quentin will talk to us about non-irradiant process.
Good morning. Good morning. I will share my screen. Is it okay? Do you see the screen?
Yes. Perfectly.
Yes. So,
yes.
Okay. Let's move on. I'm Quentin Balouet from Limoges, France, and I am really grateful for presenting this pilot study about non-irradiant full assessment of chest wall deformities. Thorax deformity are composed with two kinds of chest wall deformities, pectus excavatum and pectus carinatum. There are also hybrid forms like pouter pigeon breast. The main problem with those deformities is diagnosis assessment. Now the gold standard for those deformities, the gold standard diagnosis is chest CT scan with a lot of X-ray. The matter is to replace this tool imaging by a non-irradiant one like MRI or an imaging tool imaging, which is a 3D scanning. You can see it's like a camera, and on the lower part of the screen, it's allowed to measure the surface of the body, and for example, the chest or other part of the body. And it's really important because we can use it in the consultation, because sometimes the treatment is surgery, but sometimes it's orthopedic treatment, and we need regular follow-up. So the main problem of this study was the possibility to get sufficient information without X-ray. So is it possible to replace chest CT scan? On the left side of the screen, you can see a chest CT scan. And we see that it gives internal information of the anatomy to give the length between the vertebra and the sternum. With the other device, like the 3D scanning, you have another information with this external lens. So it's not the same index, which is called the external Haller index. The main objective of our study was to compare a standard protocol using standard chest CT with a non-irradiant protocol, 3D scanning and MRI. We included all pectus deformities, and we used both Haller index and external Haller index. You can see here the study design. The old protocol was chest CT scan with a Haller index and asymmetry index, and functional information using echocardiography. The MRI has the advantage to give morphological information, but also functional information because it gives cardiac function, and the 3D scanning. Our matter was to compare the different indexes. Is there a correlation between those indexes? But our matter was also to wonder if there was a concordance when two observers are taking these images into account. Population study, 11 patients, most of them were boys, same proportion between excavatum and carinatum. Most of them had orthopedic treatment, braces or other devices, and surgery, nurse procedure for 2 patients. First part of the results, you can see that there was a good correlation between the Haller index and the external Haller index. There was this line, which represents on the lower part of the screen, a good correlation between MRI and 3D scanning, but also between chest CT scan and 3D scanning. So this correlation allowed to make a relation between the rate of the Haller index, for example, 3.2, with external Haller index correspond to 1.7. So there is a good correlation between those indexes. The second part of the results was that there was a good inter-observer concordance. For all these three exams, 3D scanning, MRI, and chest CT scan, there was between many observers a good correlation. Its CC was more than 0.9. This was a really good statistical results. So discussion now, this strong correlation between 3D scanning, MRI, and CT scan give us the possibility to use MRI or 3D scanning for the consultation. There is a strong inter-observer concordance too. MRI was a fast protocol and was well accepted by children, and the 3D scanning is easy to use in consultation, and it can be delegated to a nurse colleague, for example. The limit of our study are that the Haller index is maybe not the best index, as we know, because we cannot distinguish the severe form of pectus deformity from the other. And there is also a variability during the breathing cycle of this index. And the other limit of the study was that as a pilot study, it was a small population. So in conclusion, if the question is, can we use alternate imaging tool to assess those deformities? The response is yes, we can use MRI, and 3D scanning as another tool during consultation, which allows frequent consultation and frequent measurement of the progression of the treatment. So we hope that it will soon belong to the protocol, as it's a project for adult people. Thank you for your attention.
Thank you very much, Quentin. Thanks for your presentation. So we will go to the first question. The first question is from Dr. Choidis. The question is it really that important clinically to know the Haller index as a surgical indication, and perhaps you use it as just as a monitoring of non-invasive treatment? So you talked about this Haller index, of course.
Yes. Sometimes after operation of orthopedic treatments, the Haller index is not really different before and after the treatment, because we didn't correct the Haller index, but we correct the difference of length between the two hemithorax. So we think that the Haller index is maybe not sufficient to assess the progression of the treatment. I don't know if it's a question.
I think so. Thank you. And other two questions that I will give you together because they are nearly comes together. One from François Beckmer is that maybe just a 3D evaluation alone could be a good option. And the second that comes together is, what about the cost of your technique? But for sure, it's a non-irradiant technique, but is it worth financially for a follow-up?
Yeah, that was, thank you for the question, because this question was important for us. I think we are talking about the 3D scanning, because MRI, we just, we can do one-shot MRI at the beginning or at the end of the treatment, and the aim is just to follow up with the 3D scanning. 3D scanning, we presented here a device which is supposed to be the simplest one. Simplest means a good precision, as you can saw. The cost is the devices itself. It's a function with iPad, Mac. So you need a tablet tablet iPad, so it's 800 euros, 700 euros. The camera with the iPad is 500 euros, but what is really expensive is the programs for the computer is
The software computer.
Yes, software is 10,000 euro. It exists more expensive devices are supposed to be to get more precision. They are about 25,000 euro. In Limoges, we have the simplest one, and we think it's enough to make the follow-up of the patients.
Thank you very much, Quentin. Thank you. So,
Nasia, we have a
yes.
question from the audience directly for Veronica Arriaga.
Yes, I missed it. Mario, so please, yes. Veronica.
Voilà. Véronica Arriaga, si vous êtes prêt, vous pouvez poser la question. If you want to ask your question, Veronica Arriaga, we are ready. You need to unmute your microphone.
Maybe later on, Mario, if you don't mind.
Okay, we can go to the next question.
Okay, so we'll move to the next presentation because time is running for sure. And the next presentation will be from Ahmed El Hatab. Ahmed, please.
Good morning. Thank you for giving me this chance. Okay, so I'm going today to talk about thoracoscopy versus thoracotomy in the repair of esophageal atresia with distal tracheoesophageal fistula. So the first successful thoracoscopic repair of type A esophageal atresia was done by Steve Rothenberg in 1999, and 1 year later he did the first successful repair for type C esophageal atresia. And the main expected advantage of thoracoscopy is to avoid the deformities that may follow thoracotomy. So our study aimed to compare our surgical results and early outcome between the thoracoscopic approach and the open one for esophageal atresia with distal fistula. Our studies, a retrospective bicentric one, included all patients with type C esophageal atresia between 2008 and 2018. 187 patients were included, 140 patients were operated by thoracotomy, and 47 patients were operated by thoracoscopy. The surgical approach was chosen according to the surgeon's preference. So we had 2 deaths among the thoracoscopy group and 6 deaths among the thoracotomy group. All of them were related to multiple associated congenital anomalies and especially complex cardiac conditions. So the statistical analysis of the results included 45 patients in thoracoscopy group and 134 patients in thoracotomy group. The mean gestational age and the mean birth weight were significantly lower in the thoracotomy group, with also significantly higher number of premature babies. Well, however, the rate of associated congenital anomalies and the congenital cardiac anomalies also were comparable between the both groups. The thoracoscopy was associated with significantly longer operative time and was also associated with significantly higher endotidal CO2 levels, either intraoperatively or at the end of the procedure. Although the endotidal CO2 levels was not significantly different between the 2 groups at the start of the procedure. And also we would mention that these high CO2 levels didn't have effect on the post-operative course of the thoracoscopic group. For the post-operative course, the thoracoscopy has achieved shorter period of ventilation and also shorter period of hospitalization. However, when we adjusted the results to include only the full-term babies, there was no statistically significant difference between the 2 groups. Regarding the complication rate, although the thoracoscopy has achieved a lower rate of anastomotic leakage, but there was no statistically significance. Also, for the other complications like anastomotic strictures, recurrent fistula, need for fundoplication, or need for aortopexy, there was no statistically significant difference between the both groups. We can find that our results are comparable to the results of one of the earliest done comparative studies, which included only 25 patients, but they found significantly longer operative time in thoracoscopy and significantly higher intraoperative CO2 levels also. And this is a meta-analysis that was done in 2016. based on 80 studies, included 450 patients. They found significant longer operative time in thoracoscopy and significant shorter ventilation and hospitalization periods. However, they didn't take into consideration that the body weight were lower in thoracotomy group in some of the included studies. So we can conclude that surgical outcome of thoracoscopic repair of esophageal atresia with distal fistula is comparable to the open one, with no higher complications, and with the advantage of avoiding skeletal deformities and better cosmesis. And the additional probable advantage may be the shorter ventilation period and shorter hospitalization period, but randomized control trial with large number of cases is needed to confirm these results and to control the possible bias regarding the prematurity and the associated anomalies when choosing the surgical approach. Thank you.
Thank you very much, Ahmed, for your nice presentation. So first, one question just by now is from Dr. Azare, is about chest deformity, because you said that chest deformity was observed up to 60%, and the comment is 60% chest deformity after thoracotomy group appears a high rate. So have you any comment?
Yeah, the point is depend on how do you mention the postoperative deformities. For example, some studies consider just the unequal intercostal spaces between the both sides is a deformity. Some results consider the scoliosis as a deformity. So it depends on how you evaluate the data. But generally, maybe in the thoracoscopy also there is some minimal deformities, but the percentage on higher estimation may be less than 10%. But in the higher estimation of thoracotomy, it may reach about 60%.
Yes, thank you. I definitely agree. The other question is, of course, the center of this study is from Dr. Prasad and also Dr. Al-Abdullah. Is about any bias in the selection of the thoracoscopic group. And the question is there a patient selection bias? Or the second question is, do you have a criteria to choose a neonate for thoracoscopy?
Yeah, actually, in this study, there was no definite selection criteria. This, of course, was a retrospective study. But when we analyzed the data, we found significant difference between the both groups regarding the prematurity and gestational age and body weight. So actually, there was significantly statistical difference, but there is no pre-mentioned selection criteria. So it depends mainly on the preference of the surgeon and maybe on the other associated anomalies with the estimation of the surgeon also, but there is no pre-mentioned selection criteria.
And maybe, sorry, Ahmed, maybe also on the anesthesiologist, because
of course,
it's also a factor.
So, there is no definite selection criteria now, but mainly I think that the body weight may be not the limiting factor till now, because in this study we had a baby was 1,400 grams only and was operated successfully with thoracoscopy. But I think that the main limitation may be the complex cardiac disorders, because it may interfere with the insufflation of CO2 and with the interoperative course. So I think this may be the main limitation. But you know that previously there was a report that below 2,000 grams is not possible for thoracoscopy. And of course, this is not the case now, because many patients were operated with less than this weight.
Thank you very much, Ahmed. Henri Steyer, I have a question.
Yes, I have a question. You know that there are more and more question raising about the CO2 and about the anesthetic medication used that could be not so good for the brain of the children on a long run. And the problem is that in thoracoscopic surgery, the time of operation is much more longer, at least in the beginning, in comparison with the thoracotomy. So did you include all the cases in the thoracoscopic group, even the first one you did, or were there some exclusion criteria of the first? And did you study the learning curve?
Yeah, actually, all thoracoscopic group were mentioned, all thoracoscopic surgery from the start of this procedure. But of course, as you mentioned, the learning curve matter. Of course, the first one, for example, in 2012 or 2013, they didn't have the same operative time as 2019. Of course, this is a fact. But we didn't till now compare the early results with the later results, because thoracoscopic approach started in 2013, so it is about 6 years. So I think maybe 4 years or 5 years later we can make this comparison. But I think this is a paper done in Germany, comparing the first 5 experience and first 5-year experience and second 5 years experience, and they found significant difference, of course, with the learning curve progression, of course.
So I think it's very important to follow those children neurologically on a long term at 5 years, 7 years, 10 years. I think they must be followed neurologically to see if there are not little differences, because it's important to know that, I think, in the future.
Yeah, and I think also there is some prospective studies done to assess the cerebral perfusion during the thoracoscopic insufflation of CO2, and they didn't find that significant difference intraoperatively, but not on the long outcome. So of course it will be useful to assess, of course.
Thank you very much, Ahmed. Thank you for your presentation and of course for your answers and to the questions. So we'll have to move. So we will move to the last presentation. The last presentation is from Dr. Dokmoko and about neuroblastoma surgery.
I hope you can hear me. Hello, everyone. Dear presidents.
Yes, we can.
Okay. Dear chairperson and dear colleagues, I will be presenting the first case of thoracoscopic total excision of a thoracoabdominal neuroblastoma, and I have none to declare. For thoracoabdominal neuroblastomas, generally wide abdominal incisions or thoracoabdominal incisions are preferred to get rid of the tumor exactly. Up to date, there is just one recent publication about minimally invasive approach for these specific tumors, and I will be presenting the thoracoscopic excision. Our patient is a 5-year-old boy who was investigated due to suffering from abdominal pain, and a 9-centimeter long and 4 and 3 were the other dimensions mass in the posterior mediastinum extending to the retroperitoneum was detected. As you can see here, the mass was encasing the aorta also. And after the biochemical evaluations, the NSA and the urine catecholamines, and which confirmed by the TrueCut biopsy, it was a neuroblastoma, poorly differentiated, and he had also multiple bone and bone marrow metastases. So it was a stage 4 high-risk neuroblastoma, and got the Turkish Pediatric Oncology Group chemotherapy. Unfortunately, there was a minimal response. As you can see here, the encasement decreased to 180 degrees, but most of the mass volume remained, and you can see some kind of calcifications, just the same. And I forgot to tell that there was no neural foramina extension into the spinal canal. So the surgical plan was to excise it, if possible, totally. And due to the previous TrueCut biopsy through the thorax, we planned to go from lateral to find the cranial border of the tumor first, and just go below on the craniocaudal axis later up to the retroperitoneum. So these were the port sites in the first phase of the surgery. And this was the appearance. You see the adhesions to the hiatus and the mediastinum. So we start with mediastinal dissection to free the lung parenchyma from the thoracic wall. We used either ligashure or bipolar forceps. And we tried to free the lung parenchyma from the hiatus and the mass, but unfortunately it was not possible. So we did a wedge resection. And then we tried to assess the cranial border of the tumor. So the first thing was to open the pleura and identify the intercostal vein, which drained into the azygos vein. And that was the first phase of the operation. Then we moved our telescope upwards and put another 4th port on the backside of the patient and went on with the surgery. Now we are more craniocaudal looking, as you can see, and we are dissecting the azygos vein, and then we identified the ductus thoracicus and clipped it. Then we needed to do some peri-aortic dissection because it had encased earlier and identify the aortic branches to the mass. When we get to know that the azygos vein cannot be saved, we ligated it, and after we tried to elevate the tumor, we could do the retro-aortic dissection to get rid of the maximum volume of the mass while we are clipping the feeding branches. Then the mass was freed from the hiatus and a transhiatal retroperitoneal dissection was moved on. This is the calcific lymph node, and when we thought that we have reached the extent of our dissection, we made a fluoroscopic control which confirmed that we are on the lumbar second, and we identified the ductus thoracicus and clipped it caudally. And for the last part, which is a normal looking ganglia root, we marked with multiple clips. And excised the mass through the 12mm port. So this was the final appearance. As you can see, there was no macroscopically seen residual mass, and it was a 9mm with the pulmonary retrosection. The hiatus was repaired with just one non-absorbable suture. The post-operative follow-up was eventless. The chest drain has been off in 2 days. There was no complication, and the patient was discharged on POD4. And you can see the clips here up to L3, nearly lumbar third vertebra that we could have gone for dissection. And for the follow-up, in the first 2 weeks, the imaging showed some middle intensity on the MRI, which was thought to be related with the inflammatory response after surgery, and that was confirmed by the 1-year MRI imaging. And besides, due to the time limit, I did not mention too much about the other aspects, but to tell, with the immunotherapy, the number of the metastases decreased in the 1-year follow-up of the patient. So we can conclude that total thoracoscopic excision of these spatial thoracoabdominal neurogenic tumors, even extending to the second or third lumbar vertebra, is possible, safe, and efficient, but of course in selected patients. Thank you for your time.
Thank you. Thank you very much for your really nice presentation. I'm very sorry because we have no time for questions, but maybe just one comment, just one from François Beckmer. I read it to you. Excellent. I totally agree with his presentation. You have one concern he says the prone lateral decubitus position as for the esophageal atresia is easier and should be easier for this kind of dissection.
Well, of course, Professor Buckmore is one of the pioneers and probably is thinking ahead of me, but you know, I might have just presented this presentation in 5 minutes, but the operation has taken more than 5 hours. So, and I was not just quite very comfortable with the peri-aortic dissection, especially on the left side of the aorta. And the reason that we have positioned the patient left laterally was that if we needed to go to the other side or more anteriorly, so in prone position, I guess it will be a little bit more difficult to dissect anteriorly and on the left side. But of course, with more gaining with more experience, that may also be done. Thank you.
So thank you very much. We definitely are very impressed by your surgery. Thank you very much. So we close the session with 1 minute late. So sorry everybody, but now it's time to move on to the next step.
Thank you very much, Nazia. Thank you, all speakers. And it was an excellent session.
It was great, great, great.
Just a few words to introduce the next session, which was decided as a UPSA guest lecture. And Professor Metzelder will be presented by Ciro. Good morning, Ciro. I have to focus on the fact of Professor Martin Metzelder help us when preparing the Vienna Congress, and he helped us to find rooms for national gathering, what is very important in our ESPES congresses. Today, we are not able to do that, but it's a great pleasure to have the acceptance of Martin to be our guest. And Ciro, you can present him, of course.
Thank you very much, Philippe. It's a pleasure to do the introduction of Professor Martin Metzelder. I prepared some slides to show you. I hope that you can see my screen. As I told you, it's a pleasure for me to perform the introduction of Professor Martin Metzelder. Before starting, I would like to give you an information as for ESPES side. As you know, last year in August 19, we published the ESPES Manual of Pediatric Minimally Invasive Surgery, and we received a report from Springer in the last few days, and since its online publication at the end of August 19, there have been a total of about 30,000 downloads for ESPES book on Springer Link. And I am delighted to tell you that our book was among the top 25 most downloaded Springer ebooks collection in this year, and I am very happy to give you this news. Coming back to Martin Metzelder, Martin was born in Germany in 65. He's a young guy, and as for his education, he has his education in Germany and part of it in Brazil. Martin was an officer in 19 in German Navy, but I think that above all, he's a true gentleman. As for his medical studies, he had medical degree in Germany, and he had 2 specializations in general surgery first, and then in pediatric surgery. As for his scientific activity, if you search for Martin Metzelder on PubMed, you have hundreds of publications. And as for his main focus of interest, they are congenital malformation, pediatric oncology, pediatric urology, above all invasive pediatric surgery, and a lot of new technology and study of basic science. His position, he was first of all head of pediatric surgery at University of Essen, Germany, and since 2014, he is head of Department of Pediatric Surgery of Medical University of Vienna in Austria, a huge department. Martin is a high-profile surgeon. I have the pleasure to meet him all around the world. Martin teaches mini-invasive surgery in every course of laparoscopy in all over the world. He's a true leader. He has a lot of colleagues, and this photo is one dinner with his fabulous team of Vienna. He's also a real sportsman. Above all, he's expert in ski, and you can see in several congresses with several friends as Philippe Montupet, Jürgen Schliff, and Arnaud Bonnard. He's also a wonderful father. This is the two wonderful daughters that Martin had. This is one trip on a boat some years ago. And he's also a cool guy. It seems a godfather in this photo. This is a photo took on the IPEG with Mattis at Hawaii a couple of years ago. And for sure, Martin is a good friend. He's a good friend of all pediatric surgeons. He's my personal friend. And you can see with a lot of friends in a lot of congress all over the world. Mr. Chairman, dear Chairman, it's a true pleasure for me to introduce the lecture of Professor Martin Metzelder. Please, Martin.
Thank you very much, Giro, for this kind introduction. And I would like to say thank you to our program chair and to our president. Thank you very much, Henri, and thank you very much, Philippe. And I need to start with my presentation and share the where is it? Can you see the shared presentation?
No, we can see a white screen.
Oh. I place it here maybe. So go back.
Now I can see your screen.
You see it?
Can you run your video? And run your presentation.
Is it?
Yes.
I can't see nothing now. Can you hear me?
You have to share again. You have unshared your screen.
This is a little bit crazy. It's a
Don't worry, be happy.
It worked yesterday. Is it now visible or not?
No, no. Drop it on the other screen. Now I can see it.
So I try.
Slideshow mode.
Pardon?
Go ahead. Slideshow mode. Come on.
Okay. Sorry about that.
Switch the icon at the top of your screen, the left icon. Tauschen.
Tauschen. Okay.
Can you see the icon? Anzeigen. Yeah.
Sorry about that. Okay, so at least it should work now. So first of all, again, thank you. And one of my favorite fields of interest is CPAM and all the other congenital cystic lung malformations as well. So all of you aware that CPAM, there's still an unknown exact pathogenesis. And recently, and that is due to the fact that we have advanced tools, antenatal ultrasound and MRIs available, we notice an increasing incidence. On the other hand, classifications are inhomogeneous and based on clinical relevance and histopathology. And there's an ongoing worldwide debate on elective surgical resection, especially in asymptomatic patients. And we see clinically often asymptomatic patients. But on the other hand, who knows how often we deal with patients where the symptoms are underestimated, because there are some data available that resected specimen in asymptomatic cases often indicate inflammation. And a very important point is that we have an increasing amount of evidence suggesting malignant development in CPAM. So the problem to deal with CPAM starts before birth. And there's a review and some information from this review from Kenneth Wong from 2018 informed us about, and we know that clinically, that we have, due to the fact that we can use advanced ultrasound, we can detect CPAM by the 20th of week of gestation. And I think the most important thing is that we can differ between microcystic and macrocystic lesions. And in our department and several other institutions as well, this goes to the fact that fetal MRI is planned. And I think the majority of us, we know that we have a trend of the CPAM lesion to increase in size until the 26th week of gestation, and then hopefully, or the majority, becomes smaller, and that means that might cause a lower risk to develop a hydrop. But if that doesn't occur and the lesion is increasing, we had that several times in our department as well, in our institution, then we have to distinguish if there's another underlying disease, for example, bronchial atresia or congenital lung emphysema, and we do a redo. And that means if that is still the fact that this is increasing, then we have to perform a plan B, let's say like this. So we know that some cases, they continue and worsen up to fetal hydrops. And I personally have no experience with that, but I know, of course, that there's the possibility to place a thoracoamniotic shunt, and in the most microcystic lesions, steroids are available and useful as well. But however, size of the cyst varies, it is not predictable. And on a rare occasion, even if there's a very severe and large cystic lung malformation that might cause problems immediately after birth, exit procedures are in the field of treatment as well. So we had an EUPSA survey 2 years ago, and 181 members from 48 countries were asked to follow the survey. 75 operated on asymptomatic patients. And you can see that the majority of cases were operated between the age from 6 to 12 months. And the indication, just by the feeling or just by answering the questions, about 86 believed to decrease the risk of infection, 63 believed to decrease the risk of cancer, and 62 believed to decrease the risk of symptoms development. And we are all aware that this is just not fully solved. There are so many question marks. So this is just, by the way, and I think a worthwhile algorithm to deal with these antenatally diagnosed CPAMs. And the thing why I showed to you, this is from the US again. They recommend to perform a CT of the thorax before 3 months of age and operate even very, very early. And we follow almost everything, but we perform the first CT later. Even we wait till 6 months if the patients are asymptomatic. And of course, we add the operation later as well. So there are several questions, I think. Question one could be, are there predictable parameters for CPAM regression? And I just looked for this work from Kunisaki, is originally Japanese, but from the US as well, and colleagues. And they looked they analyzed 100 consecutive fetuses in a single center, and they found out that there were 17 lesions undetectable at the 35th week of gestation. And to correlate that with postnatal CT imaging, they had almost a complete regression, obviously, in about 10 or 11 patients. So there are cases which regress, but we cannot say that in advance. Another question is, or another aspect is, how can we verify asymptomatic patients? Should we wait and see? How do we monitor these patients? This is work presented in Pediatric Surgery International in 2018, and that was a review including 19 retrospective studies on 353 patients. And a quarter of these patients expectantly managed became symptomatic, requiring surgery. You might ask, what means symptomatic? This is a very good question. The median age at symptom development was 7.5 months, so that the author concluded that 1 in 4 asymptomatic patients will probably develop symptoms. Another thing is, what about timing of resection? In the last thoracic section, we heard about this work from Duran, and this is a group from Stephen Rothenberg, and they performed a retrospective analysis on impact of timing. And to keep it short, after dividing these 63 patients in 3 groups, all of them were below the age of 12 months. There was no significant difference with regard to morbidity and complications. Another thing is, I mentioned that before, what about inflammation? There's a very interesting work now, very recently presented from the Rotterdam group, and they did a lot of other investigations as well. But one endpoint of this study was, there were 50 CPAM patients, 25 type 1 and 25 type 2, and there were specifying no differentiation between asymptomatic and symptomatic, but the endpoint was inflammation on the specimen. So signs of inflammation were found in 34%. This is 1/3. And in detail, 4 patients or 4 cases had chronic inflammation, 8 chronic active inflammation, and 5 had mucostasis. Are there any benefits or anticipated benefits of early surgery? People think that that might minimize the risk of malignancy because it's operated anyway. We might even reduce the risk of complications, infection, pneumothorax, to reduce postoperative complications following elective surgery. That means if patient had already several episodes of inflammation, that is more difficult, and to avoid long periods of observation, less radiation. And even observation period, if it's longer than a couple of months or a year, that might cause anxiety. And there's certainly a risk of misinterpretation of imaging. Another question is, or another aspect is, there are certainly risk of surgery as well. Complications, morbidity, mortality. There's one publication in pediatric pulmonology from 2016 from Nigel Hall and colleagues, And I know that he is more a person who has some ideas to wait and see, especially in asymptomatic patients. But fair enough. So they had 60 asymptomatic patients. They were operated thoracoscopically, the majority, and had a complication rate of 23% and no deaths. 11 minor complications. I don't go to that in detail, but 3 major complications. And I would like to look at the tension pneumothorax with undiagnosed CDH on the 5th day postoperatively. Yes, that might happen. And so with regard to that, what we heard in the former thoracic session on impressive data on day surgery, I'm a little bit more old-fashioned to this regard. So we keep patients at the end 2 or 3 days, sometimes even 5 days, and we place a tube, even there is no good evidence for that. But I'm really worried that that might happen. On the other hand, near fatal hypovolemic bleeding from an aberrant vessel on the 7th postoperative day is another thing. And I just want to show you how to deal with that. This is just a surgical thing. Of course, if we see in a hybrid lesion, CPAM plus intralobar sequestration, so-called hybrid lesion, a long intrathoracic vessel, small diameter, like you see here, I have no trouble to seal that. If it is short or a bigger diameter, sutures, because that is more safe, I think. And all other transdiaphragmal vessels, irrespective length or diameter, we suture that. That is just a detail on techniques. So coming back, what is better, VETS or thoracotomy? I don't have to convince you because we are in an ESPES community. So of course I favor VETS as well. And there's a study from Lau and again Kenneth Wong, and they looked at differences between on pulmonary function test parameters, and you can nicely see that the FBC and the FEV1, they were significantly better in the thoracoscopic group. What I'm not, I'm a little bit irritated and not convinced if that is to impaired respiratory muscular, I don't know. Another thing, what I find very interesting is there is a recent multi-institutional registry for children with operative congenital malformations. So that is including CPAMs and others as well. There were 11 children, hospitals, 500 patients, and they performed 230 elective lobectomies in asymptomatic patients. However, VATS was only used in 102 cases, below 50%. All the others were open thoracotomies. So at the end, they reported on substantial practice variation in preoperative evaluation and operative management. I find this very interesting because we hear so many things what we can do, and I'm a little bit surprised that in the US they don't do too many. And this was the caseload and the timing in this series, and you can see differences between several centers with regard to the caseload, and here you see the age of operation. So, and you can see the majority were performed between 4 and 6 months of age. As I said, probably in Europe, we go a little bit later, between 6 and 12 months. What are the advantages? I mean, we did that in Hanover when I was in Hanover about 10 years ago. We had a nice series, I think, and looking on lobectomies that was comparing 12 VETS lobectomies, whereas the 17 conventional conventional resections, and there were some other entities as well. And you can see that the incidence of thoracic wall deformities and the incidence of scoliosis was significantly lower in the minimally invasive group, despite better cosmetic and patient satisfaction. Okay, I think the main question or a major issue is how can we interpret work with regard to potential malignant development? there's really controversy. And especially if somebody has never seen that in his own cohort, they're very, very restrictive sometimes. And so we have to be part of this in large series and multi-center studies. And this is an ongoing process, although with regard to these EARN strategies for the moment. So this is the first publication. This is from Trieste, from Federica Pedriva, and she reviewed and found 134 eligible publications on the association between congenital cystic lung malformation and lung tumors in children and in adults. And obviously there were 76 children, this is the mean age, and the pleuropulmonary blastoma was found in 31, most frequently associated with CPAM, and the adults, of course, were older, and there was adeno-CR in 20 and bronchial alveolar in 20 cases, which were associated with former CCLM. Another thing which is for me very important is some colleagues advocate you can find out from the imaging if that is suspicious for CPAM or for PPB, and I will show you later some aspects from Feinberg and from Nigel Hall. But in this case, Nasr and colleagues, they looked at their own patients between 1999 and 2008, and they had 74 CCAM resections. In these days, it was still called a CCAM. And out of 129 CCAMs, so there was quite a number of monitored patients as well. And they found 5 PPB cases, 3 out of 5 initially diagnosed as CPAMs, not clinically nor radiologically distinguishable from CCAM. There was a single center cohort, of course, and the incidence for the CCAM was 1 in 2,000, and respectively for the PPB in 1 to 250,000. The mortality rate, irrespective of chemotherapy and all these things, of these PPB patients was 20% only. That means they reported on PPB among benign lesions of 4%. And these are some pictures from their publication. And both figures were cystic lesion diagnosed preoperatively as CCAMs. And post-resection, pathology revealed PPB in both cases. And I couldn't say, and even the work or the reports we have, I think it is, although these are only axial views from it's just a piece from the whole CT, but I couldn't say that. So this is an issue. So what do we know from more basic research? There's one study presented in 2013 from Lesme and colleagues in Orphanet Journal of Rare Diseases to the role of, or whether the fibrous growth factor 10 signal differs between CPAM and type 1 PPB. And to keep it short, the expression in CPAM type 1 and 2 was significantly higher than in type 1 PPB, and the controls were healthy lungs. There was no difference between CPAMs versus controls. So this is just one piece of the puzzle to overcome the trouble if there is at the end a real, let's say, real data which indicate if we should operate on even asymptomatic patients or not. Another study, and this is again the Rotterdam group, they performed immunohistochemistry and next generation studies to investigate potential biomarkers to predict the presence of mucinous proliferations in CPAM. So again, these 25 CPAM type 1 and type 2. Why is that? Because multiple areas of mucinous proliferation are thought to be a precursor of mucinous adenocarcinoma in situ, and are found in 30% of CPAM type 1. And there's an overlap of gene mutation between mucinous proliferation in CPAM type 1 and lung adenocarcinomas, like the KRAS mutations that is present in up to 25% of all human tumors. So they used a gene map of 40 genes, and next slide shows the results. The mucinous proliferations, they were found in 11 samples, all carrying KRAS mutations in area of mucinous proliferations and non-mucinous CPAM tissue. But normal surrounding lung tissue was negative. 5 out of 12 samples without mucinous proliferations, in these cases, CPAM also carried KRAS mutations that might meet, or that was the conclusion, that KRAS mutation in non-mucinous CPAM tissue may identify lesions with a potential for malignant degradation and may guide histopathological assessment and patient follow-up. Surgical techniques. I keep that short because it is such a big topic. Of course, it remains debatable. We have, of course, comparable data on the outcome between segmentectomy and lobectomy. But there are some arguments what you should prefer. I go through that a little bit. We have, of course, a compensatory lung tissue growth following lobectomy in infants. This is shown here. That is limited, of course. So pro-lung sparing. It is, of course, our VATS magnification eases preparation for segmentectomy. And it has been shown by several authors that there's a low morbidity and it is appropriate, especially for bilateral or extensive disease, but when limited to anatomic segments. Small lesion, wait and see, or segmentectomy. The area of the lesion plays a role. Here are all the segments. To keep it short, my feeling is, and that is in accordance with adult thoracic surgeons as well, that upper segments of upper lobe are easier to identify and to operate than some lower segments of lower lobes, especially when they are hybrid lesions. And anyway, if we should perform segmentectomies for hybrid lesions is another question. But what are the potential disadvantages? Risk of incomplete removal or risk of unintended injury. And on the other hand, to exclude residual disease, there's probably a CT required. And in case of a redo, severe adhesions at the fissure have been published. I have still some videos, but I see, maybe you see that as well, that my computer don't want to work with me any longer. And I spent already 22, almost 23 minutes, so that I finish now. And I thank you very much for your attention. Thank you.
Thank you very much, Martin, for your impressive lecture. This is a lecture. For this reason, there is no discussion. And above all, we have a couple of minutes of delay. I would like to thank you very much in name of ESPES for your impressive lecture. And thank you very much. And I give the word to IRCAD staff to continue the Congress. Thank you very much, Martin.
Thank you. Thank you.
Thank you, Martin. Congratulations. It was a wonderful and didactic lecture. Now we are in time, and it's a really important time, the time for the president of the society, Henry, very good friend, to give his lecture, his president lecture. As everyone knows, Henry is the head of the Queen Fabiola University Hospital in Brussels. And not only is in charge of this unit, but also is our president with a spirit of modernity for the society to increase the quality of our scientific spirit and also to increase the modernity with a e-learning project. Henry is working on which, and his last privilege is to be married with an anesthesiologist, Cosette. I'm happy and greetings to Cosette now, and we are hearing our President Henry for his presidential address.
Thank you so much, Philippe. It's of course a great pleasure for me to give this my last presidential address. I will say that I will speak a little bit about the future, but you cannot speak about the future if you have no past. And I think a lot to my past, and for that I'm sure he is there. I want to thank in particular Jeff Valla. I worked with him for so many years. We did so many funny things, and I learned a lot with him. And so Jeff, thank you again for all that. And you will see that the magic of digital is incredible, because you see me here a little bit with my microphone here, and in a few seconds, with the help of the IRCAD staff, they will transport me to a COVID-protected garden to give my presidential address. So staff, it's to you. Dear colleagues, dear friends, my presidential address today will develop some ideas around how Homo sapiens will become Homo Deus, following the famous books of Mr. Harari, or more precisely about human and artificial intelligence. During the last decennia, biologists became convinced that a human preparing some coffee is an algorithm. Or taking an animal example, a monkey who sees a banana bunch and not far away a lion responds to a complex algorithm. How far am I from the banana? How far is the lion? How quick can the lion run? And high? Is the lion hungry? And high, etc. Some centuries ago, our human knowledge increased slowly, and by the way, political or economical changes too. Nowadays, our knowledge is increasing very quickly. 30% of what a medical student is learning today will be obsolete at the end of his studies. Theoretically, we will be able to understand the evolution of the world much better. But look to the COVID pandemic, it's just the opposite. Things are changing too quickly. Will artificial intelligence help us in understanding the world with the risk of finally replacing us? Yes, why not? In the opinion of a lot of people, the hand of the pharaohs and the death of Jesus Christ are to be considered as positive evolution. Perhaps that the hand of humans, then replaced by transhumans or even robots, will also be a good thing, at least for our planet. So if we want to get some power in the decisions that our world has to take, we have first to understand better artificial intelligence. Today, if you look to pure performance, you can see that artificial intelligence is far not so good as our brain. Nevertheless, artificial intelligence has some big advantages and is, for the moment, a very good candidate in order to replace us in monotonous tasks. And medicine is exactly one of the specialties where there are thousands and thousands of monotonous tasks. Remember what we still are asking to our medical students: to learn lists, to learn algorithms, to learn doses. This is something artificial intelligence can do much better than we. But except a powerful and energy-sparing system, our brain has also several advantages. If you think again about medicine, you understand quickly that multitasking, decision-making, and accumulation of skills are some of the particularities of this job. How do we do that? With our 5 senses and our emotions. So we can state that artificial intelligence will be used more and more, and with success, in conjunction with human intelligence in medicine, but not only. Artificial intelligence can be divided in different branches. One big difference to make is between artificial intelligence and machine learning. For the moment, most of the tools we use every day, home or in our medical job, is finally machine learning. Machine learning accumulates data in order to be more accurate. Artificial intelligence accumulates knowledge in order to be more successful. Today, we are mostly in the first evolution of artificial intelligence. So what is artificial intelligence actually able to do for us? 2 main things: improve security of repetitive work, and that in a 24 hours a day. But recent advances show that artificial intelligence is moving quickly from simple to more complex tasks. Deep learning systems are able to adapt to our questions, to begin multitasks, answer to 2 linked questions, for example, or learn from its errors. And that with a beautiful face. Let us go through some examples of the invasion of artificial intelligence into medical science. It's very important, so as you can see. There are even now special journals about that field. In medical science, we divide artificial intelligence more in virtual and physical, more than artificial intelligence and machine learning. But this is quite the same. On this slide, you will see the logos of the 2 most advanced systems that are on the market nowadays. The first is Watson. It's the first one, the most robust, with the longest portfolio. And then AlphaGo, a deep learning system. artificial intelligence is developed by more and more companies in more and more parts of medicine. If we look more to deep learning, we can see that it's a little bit like our brain is working. We receive data, symptoms, physical examination of a patient. We make some differential diagnosis. We enter all that in our brain and our database, and we make connections, introducing eventually new elements like images, biology, and finally, we have the diagnosis. You see that deep learning artificial intelligence is working a little bit in the same way than our brain for those tasks. There are a lot of publications about the use of artificial intelligence, and if you look to them, you can see that it covers quite all the specialties in medical science. And if you look to the FDA-approved algorithms that are in use in the USA and abroad, you can see that there are more and more over the years. So as you can imagine, we are able to be submitted to artificial intelligence from far before our birth to the end of our life. So here are two examples of how artificial intelligence can be positive or negative. On the positive part, there are publications now showing that for dermatologic diagnosis, artificial intelligence is much far better than the dermatologist. But if we consider, for example, mammographies, we can see that there is a huge study done with artificial intelligence showing that specificity and sensitivity of artificial intelligence is not far over 80%, and that 90% of the radiologists are far over 90%. Another example is the study of the lymph node invasion in breast cancer on an histologic point of view. And there, the LINA project shows that the artificial intelligence can show the pathologist where to look, and that increases its accuracy very much. That are just some examples of the wide range of tasks where virtual artificial intelligence entered our world. So it's in French, but back to From the Garden, it's just, you know it, to tell you how a CT scan can be sent to this society, and where artificial intelligence and algorithms with the help of radiologists work on that to make three-dimensional images, and in particular to see how everything is conducted, and then it goes back to the surgeon. And in this example, there was a suspicion of a tumor in one of the lobes of the liver on the CT scan, and after reconstruction with the system, it was shown that the tumors were not in the lobes where the radiologist diagnosed the tumor before this reconstruction. So you can see that artificial intelligence can help us a lot to increase the security of our diagnosis. And of course, with all the different tools we have now, we can do education. With all these tools, we can explain better to the patient what happens and what we will do. We can use it in the operating room. We can still use it also with the robot. You see, there are a lot of examples. There's just one, a very beautiful one, and it comes from Strasbourg. And then in some years, our younger colleagues will operate with this instrumentation on the head there, and you will have a guidance where to put your trocars and where to operate. So the future is artificial intelligence, probably more interesting for surgeons. Physical and artificial intelligence can take some ways you never imagined. Different types of artificial intelligence will soon invade also our medical education system. Simulation before doing live will become the rule for the safety of the patient. ESPES, your society, will develop its own simulation lab for the service of its members. Grants were given for that, but it's always possible to give. Go this evening, right now, to the ESPES website and click on the donate button if you think this e-congress was fruitful. Concerning robotic surgery, you have to know that we are still into the middle age of this type of surgery. On this slide, you can see a table summarizing what robots will do over the years in cars on the upper part and in surgical robotics on the lower part. In surgery, we will perhaps evolve to level 4, but never get to level 5 because we have to control exactly what the robot is doing. And here we are back to machine learning. Today, the robot is just a digitally driven system helping the surgeon to do more precisely some tasks, but with a lot of constraints. And that's why, in most circumstances, the robot doesn't prove mostly its superiority in comparison with a well-trained surgeon. But what if we learn the robot to do task by task, and we construct an algorithm? For example, if you are 2 millimeters from the artery, open the jaws, etc. And what, for example, if we adapt a deep learning system to the robot? An example in cardiac surgery, the robot says, the cardiac valve is up down. I do it again and turn it before entering the upper vena cava. So the robot will learn from its mistakes. And what finally, if we reward the system, if it makes positive advancement in a task? In conclusion, artificial intelligence, yes, if it is used to get, for example, the miracle of the Hudson. No, if it is used to manipulate an election. But let us always think, so as stated by Hawkins, about alignment and capability control of artificial intelligence. But let us finally not be afraid by artificial intelligence, but perhaps by our human intelligence. Let us not forget that human intelligence can be very, very sad. Looking to all what happens in science since COVID virus invaded the world, may I remind you that medical science in particular must follow strict rules, well described by one of my brothers in a paper. Let I read it with you. A research stance towards action is a research strategy used to deal with an indeterminate situation. It aims to fulfill both academic requirements and those of the society dealing with wicked problems. It involves the choices made concerning the given situation at all steps in the process of knowledge production. 1. The translation of real-life problems into a scientific issue. 2. The choice of appropriate methods to tackle an addressable question. 3. The production of scientific knowledge. And 4. The use of scientific knowledge to transform the situation. And let us think about what we really want to become: a transhuman, an immortal. Comte Sponville, a French philosopher, tells us that medicine is a great thing, but it cannot take the place of politics, morals, or spirituality. Why? Because health is like money, a good that I can desire. On the opposite, courage or generosity are values that we can admire and we need so much today. Dear colleagues, dear friends, following another French philosopher, Edgar Morin, let us not forget that knowledge is a navigation in an ocean of uncertainties through archipelagos of certainties. And you know that I like navigation. Time for me to say it was an honor to be your president and to thank so many, many times my wife for her incredible generosity and courage supporting me over the years.
Thank you, thank you. It was a wonderful talk, dear Henri. And also, we are on time for a short break of 1 hour, but stay with us, stay connected. During this break, you can have a breakfast if you are in America. We can have a lunch in Central European time or dinner elsewhere. I have to say, during this break, on the screen, don't turn off. We have good advice from the IRCAD Center for teaching courses and also for the life of the IRCAD staff and of the ESPES itself. Thank you very much to stay with us, and see you at 1 p.m. Thank you.
everyone. See you later.
Hello.
President. Good.
Hello, everybody. We are back on track.
Hello.
Hello, everybody. All the speakers there for this
Hello.
roundtable. Juan, you are there?
Hello.
Juan?
Yes.
Yes, I am. Juan. Hello, Fabio.
Hello.
Good afternoon. Hello, Thomas. And where is my young colleague, Luc? I see him there. Hello, Luc.
Hello. Good afternoon,
You hear us very well?
We do. Yes.
Okay, fantastic. So I hope that everybody had a good lunch.
Not
we are
yet.
back- Not yet. I know, normal. In Spain, it's at 3 o'clock.
Yes.
In Italy, never.
In Italy, never. Just a coffee.
Yes.
So we are here to speak about an up-to-date thing, of course. It's the aerosolization that is suspected with COVID, but perhaps not only with COVID. We have now a roundtable to see how surgeons deal with this since the COVID pandemic is there. And we asked speakers to tell us about different devices that can be used. And at the end, there will be some poll to see what the people in the audience will do. Don't forget at the end, when there is a discussion, to raise your hand through the computer or to send chats, because you have the opportunity to discuss a lot. And I ask, of course, the speakers to get in time for their speeches. So the first speakers, we will speak about prevention of aerosol formation in minimal invasive surgery in general, the principles, is my very good friend, Joan de Agustin from Madrid. Juan, we listen to you.
Thank you. Thank you very much. And I'm very happy to be here today. I was enjoying a lot this morning, and I think it's a historical moment because we are connecting from all over the world from our offices or our houses. So welcome everybody, and I will start right away. This is well, it's in a form of video because of the videos that I included. So I have no conflict of interest in this talk. And my talk will be about all the general aspects of aerosolization in the operating room. But first, I would like to tell you with this slide to show you in this table how long the virus can be viable in the infectious material. And if you can see here, this is a comparison between SARS-CoV-2 in red and SARS-CoV-1 in blue. That is not such a big difference in between them. This is the permanence of the virus in the, I'm showing you in aerosols for at least 3 hours in the ambient. And in different materials, you can see here the copper that can last for 20 hours, cardboard for 40 hours, stainless steel for almost 60 hours, and plastic in 80 hours of permanence of the virus. So in aerosol, it's not such a long time, but it's very lasting, especially in the operating rooms that we are working on. So respiratory aerosols are produced with particles less than 5 microns and can be produced at the first time by the ventilation from the anesthetic point of work. So, and also with respiratory procedures that we can done in the patient, and during laparoscopy or thoracoscopy. And we have to use protection devices when we are confronted with patients with suspicion or tested positive for coronavirus. And we use personal protective equipment, face shields, surgical masks, and suction devices. It's important to realize that the first time anesthetic conditions can be important. And I'm going to show you 3 points. The first is that if there is no airway manipulation, like in diagnostic techniques, it can be managed only placing a surgical mask on the patient and administer oxygen underneath the mask. When we have to try to avoid ventilation with a face mask and a bag. And also the third one is that if we are going to use a respirator system, we have to use high efficiency filters that prevents contamination, use low volumes of gas, and do not hyperventilate. And also we have to avoid leaks. For this, also it's important to do a fast track intubation. That is very recommended. From the second part is during the minimal invasive surgery, aerosolization can be produced during the use of electrocoagulation or CO2 desufflation and port leaking. There are some recommendations by the most known scientific societies to try to avoid aerosolization during the minimal invasive surgery. That is using filtration devices to evacuate the pneumoperitoneum, to avoid port venting, to improve our vision, if possible to use ultrafiltration system in the proper insufflator with a mode of desufflation. But in case we don't have that feature, we have to stop insufflating and to use suction devices, regular suction through the least dependent port for desufflation. To remove the specimens only when gas is evacuated. Try not to use surgical drains, although I think it can be used when we don't have any more pressure inside the abdomen or thoracic cavity. So I think this is not mandatory. Also, to close the wound after the sufflation is completed, avoid hand-assisted surgery, and if possible, to use trocars with balloons and low pressure. So the next slide, I will like to go through the protection devices, and I'm not going to talk about personal protection equipment, only just a hint, but quite a lot about facial shields and facial masks. In this work that it was published in August, we can see three different types of masks. The first one is N95 or FFP2. That is the most reliable one, and you can see that is when it is applied, the filtration through the mask is very minimum, almost to zero, all along the procedure. When we use a surgical mask with tapes and with ties behind the head, it can be very efficient. Almost there is only 20% of filtration of particles through the masks. And when you use this kind of masks, like this one, this is going down almost to 50%. So it's important to know what kind of mask do we have to use, and we recommend FFP2. And there is a very interesting work trying to study these face shields, and with very nice films, trying to reproduce sneezes or cough, and with a laser to see what is happening around us. And you can see that the air is in a short distance around the head, but also in the long distance. We are going to see right now. In the far field, long distance, with the same procedures, we can see that it's difficult to prevent aerosolization using only a face shield. So a face mask has to be used. And sorry, in this face mask, the authors of this work studied the valved mask, and it's very interesting that for personal protection is fine, but for aerosolization is a big problem around the people who are using it. As you can see, the air is moving with particles very far from the subject. So next will come this closed mask, the FFP2 mask. You can see here, okay? Yes, here. And this is very efficient. The problem is close to the nose, that aerosols can spread out up to our head. So next we will see the two surgical ones. This is the surgical common mask that is a good quality facial mask that is quite good, but also aerosolization can take place, especially over the head. And a bad facial mask that we have to see that there is no protection at all. So we have to prevent also not only aerosolization from the devices or the surgery, but also from the people who are working in the operating room. So protective equipment for surgeons must be also a special consideration. I show you here one of them that we were using during the pandemic that has a special ventilation device, and they can allow you to perform surgical procedures comfortable and safe. And finally, for conclusion, I would like to remember these important features. The one is that the operating room has to be hermetically closed and use a negative pressure if it's possible. If not, it has to be ventilated after each procedure. With patients with COVID-19. Anesthesia must use a fast-track intubation protocols and try to avoid leaking from all the connectors and ventilations. In minimal invasive surgery, we have to prevent CO2 leakage, to use filters, and to have a safe desufflation maneuvers. And we have to try to avoid venting from the ports and so on, that we will be on later with the next speakers. To use proper protective protection equipment, and the protocols of putting on and taking off, it's very essential to avoid contamination. As we could see in this video, to use appropriate face mask and shields, and try to get involved with protocols, because we will learn a lot of things related with physics and infectious problem with the virus. And that's all. Thank you for your attention, and I will be sure in joining the next speakers, because they will get into depth. Thank you very much.
Thank you, Juan. Is Fabio there? Yes, I see him.
I'm here.
Hello, Fabio. Fabio Chiarenza is the head of the department in Vicenza, where he organized last year a fantastic and immemorable congress. So he has perhaps the most difficult part of this round table, speaking about what exists normally before the COVID. So the filters and other adaptations on standard insufflation system. How did they do in Italy?
Now it's quite good, but we're waiting for the second wave, probably. I don't know what will happen. And so every one of us has this doubt, and we hope that we will be protected, us and all the child and all the people that work here. And I want to thank, first of all, the president of the ESPES and the Congress, all the board, obviously also IRCAD that gave us the host to for this Congress, the first Congress, online Congress. I hope that you can see my slides. I don't know.
Well.
Can you see?
Yes, very well.
Okay. Now we are going to speak about the evacuation surgical smoke during COVID-19 pandemic. I have nothing to disclose.
Fabio,
Sorry, your content is not well shared. We can see the presenter view, the presenter mode. If you can switch, yes.
You switch to
presenter mode.
To slideshow. You have to switch to slideshow.
You have to switch presenter mode. You're on presenter mode, so we can see your notes.
Where is
click on
Impostazione e visualizzazione.
Thank you.
Okay, perfect. I try to see.
Duplicate.
Could be good.
Yes. Thank you.
Good. Thank you to the council. I tried yesterday, but now it's okay. So I'm going to speak about the smoke production, and during the operation. Okay, we know that all the fog, all the smokes are produced by the electrosurgical instruments that heat and burn tissue, and so they produce smoke. Smoke, and as I saw before, is very dangerous, because in case of COVID, it can transmit also a lot of bacteria and a lot also of toxic substances. Now we are speaking about, can you see? Okay, sorry. Thank you. Which are the main components of the surgical smoke? 95% we know that there is a water vapor, and 5% of content is of toxic gas, cellular materials, virus and bacteria, and carbonaceous tissue. In this bad period, we had a lot of literature that, and a lot of guidelines, a lot of everything that try to prevent the contamination of the virus with the air, and so with the personnel, with people of the operator room at Onoli, with all the doctors. Also, our group of ESPES group produced a paper coordinated by Alessio Pinuprato, in which we explain our recommendation about the treatment of the operator theater during the COVID-19 positive patient. We identified 121 documents, and with a total of 11 full text documents, and we propose some suggestion, that is, the consider conservative treatment, obviously, whenever safely possible, dedicated theater, column, reusable instruments, etc., for to prevent contamination, prefer disposable instrumentation and cables, use low CO2 insufflation pressure, and but above all, use a device that can, in case of desufflation, can protect all the theater from the contamination of the virus. Just before to speak of the filters, I will speak about the particulate. As Juan told before, there are different kinds of particulate. We must keep attention to, particularly to particles that has the diameter less or equal to 0.1 nanometers, because this kind of particle goes directly to the lung, and obviously coronavirus has an average size of 0.1 micron, so it goes through the airways directly to the alveoli, pulmonary alveoli, as we know very well, with the consequence that we have had and we have today. So how to prevent particulate diffusion of virus? Obviously, we can have to use filters, mask. I saw you just before, very nice video of one, and filters that can block the diffusion of the virus in the theater and in the operator room. What kind of filters? We have a lot of filters that we can use, but the most usable filters that can prevent the diffusion of the virus are the alpha filters, ultra low penetration air filters, that can safely block particles very little, 0.1 micron. And in our case, it's perfect for coronavirus. Speaking about the type of filtering system, we have mainly two systems. We have a passive filtration system, very simple, and we will see after where to use, and active filters that are devices that have the capability to aspiration of the fog and gas. The passive filtration system must be connected directly to the trocar without any device, and must be equipped with alpha filters, as I told you before. And about the active filters, we have a dedicated device with an active aspiration that must be equipped also with a filtration system. How is composed a filter? A filter is composed in various ways, but the most common is composed by microfiber sheets that are intervalated by aluminum septa and can block the diffusion of the virus, even if there is a pressure that can spread the gas. So we will speak now about the passive filters that are more common, are easy to find, easy to use, and we will see after how we can compare with active filters, which are the advantages and disadvantages of these filters. Then we have active filters that are devices originally created for remove the smoke in operatory field, because we know that the smoke also without virus can create damage to our lung, to our health, and so this kind of active filters were created for this scopus. Eventually, this filter can also create a pressure inside the abdominal cavity, but we will see after. In pandemic period, this kind of filters were equipped with alpha filters combined and were very useful to prevent coronavirus effusion. When we speak about electronic device, we can have mainly two kinds of active filtration, because main companies produce a lot of devices that can filtering and also can make insufflation. So we can swap into kind of filters, exclusive evacuation filters, of both insufflation and evacuation filters. This is the main difference from the device. This kind of filter, this is only gas evacuation system, is obviously a device that have only the aim to aspirate the gas and to filter the gas from the abdominal cavity in order to prevent the effusion in the abdominal cavity. The advantage of this filter is that this can be used with the special device also in open surgery. We have a special pencil that can also aspirate the fog during the operation. The insufflation aspiration filters have the advantage that can insufflate gas and also aspirate gas, connecting and coordination with insufflation aspiration, maintaining in the abdominal cavity the stable pressure. Various society try to do scientific society try to do a comparison between different systems of filtration system, but the main difference can be, for example, that some device can do open and laparoscopic surgery, and the other very important characteristic is that not every filtration device is equipped with filters, alpha filters. Some of these are not equipped. So please check if you buy the filters, the active filters, that must be equipped with alpha filters. Which are the advantages, disadvantages? Combined insufflation evacuation, I told you before, the main advantage is that it can maintain the same pressure during the operation while there is suction, there is infusion of gas, and so the pressure stays constantly good. The costs are obviously higher compared with the other exclusive evacuation systems that are very useful and can be mainly used also for open surgery. In this case, insufflation evacuation is much more difficult. And finally, what is the comparison between a passive and active system is obvious. the low cost comparing with high cost. Simple use because you have only to connect to the trocar. There's no maintenance. Slow, but the fact is that sometimes if you have more smoke, it's difficult to evacuate fast and complete the fog from the field. So this could be a problem. In case of active system, this is very good because you can have the constant pressure inside the abdomen and you can clean very well the field, the field, filtering very well the gas. In conclusion, in case in COVID patient, even if the transmission of virus is not sure, the use of filter in smoke system connected with trocar is strongly recommended. Verify that the filter used at least an alpha type. The active aspiration device equipped with filters is advisable. In case of passive filtration, use a trocar at least of 5 m to leave the gas go out easily. And pay attention also to the fluid aspiration. Thank you for your attention.
Thank you. Thank you, Fabio. Thank you so much. So now the word is to Luc Joyeux. Luc Joyeux is one of my young colleagues in Brussels, but he works also part-time with Jan de Prest in KU Leuven, where he's doing fetal surgery. And we asked him to come to speak about a special and a new device, a little bit of aspiration insufflation, which was developed a little bit in fetal surgery. And there are some advantages to add some new tools on this insufflation systems, perhaps. Luc, it's up to you. Thanks to look to your time, please.
Thank you very much, Henri. Thank you very much, everyone. Can you hear me?
Yes, very well.
Perfect. So thank you for giving me this opportunity and your trust. So I wanted to discuss today about humidification and warming of CO2 in children. So as you've heard, so briefly, the first problem we currently are facing is the COVID itself, the virus. So I won't go into those details. It can be found in any surfaces, as well as in the peritoneal fluid and the gut as well. This has been extensively shown. And so in laparoscopic surgery, the main issue is the aerosolization. What kind of solutions do we have? So it's been also discussed briefly. We need a low pressure, we need a one-way system, a closed valve system, plus a good filtration. The second problem that we currently face is the CO2 in itself. And if we want to reach patient safety, it's a key. In adults, it's been already shown that CO2, the standard CO2 that we use, which is dry, plus it's cold at 20 Celsius, it causes peritoneal desiccation and inflammation. That can lead to quite some issues, hypothermia in patients, post-op shoulder pain and allergic requirements, longer length of stay, adhesion formation. Those are the main complications. And what about children? So, and fetuses as well, because it's also one of the key discussion of today. So it can also lead to inflammation of any sort of peritoneal or pleural membrane, as well as increased absorption of CO2 in the blood. So this causes acidosis and hypercapnia. It's been shown during thoracoscopic surgery in neonate, laparoscopic surgery, and also in fetal surgery. And it also increases the hypermetabolic response of children. And it might lead to cerebral hypoxia as well. So what solution do we have? Humidification and warming of the CO2 is one of them. So in adults, it's been shown to prevent hypothermia. So there are quite some literature about that, systematic reviews and meta-analysis. It also decreases pain, and it might reduce adhesions. This has only been shown in animal models. And so what about children and fetuses? So maybe we have data already saying that it improves respiratory acidosis, and this was shown during fetoscopic surgery for spina bifida in animals as well as in humans. However, there are remaining safety concerns. Fetal acidosis still persists, and there might be some brain and fetal membranes damages. So that's something we wanted to study in our lab. Have tested the safety of simulated fetoscopic spina bifida repair using heated and humidified CO2 under a controlled anesthesia and fetal lamp. As a primary outcome, we used the pH of the fetus. So it had to be within clinically acceptable range, which is 7.23. And we had different of secondary outcomes, acid-base status for the fetus, for the mother, hemodynamics, and also histology of the brain and fetal membranes. So following a large hysterotomy, we placed a catheter in the carotid artery of the fetus, and then we marked the lumbar defect. We placed the catheter for the different tests, and then we performed a 3-port fetoscopic repair. So 2 fetal surgeons were involved and 1 MFM specialist for the anesthesia and for the fetal exposure. So this is the setup, as you can see. So we place the ports through an exteriorized uterus, and we have the different steps where we dissect defects. So we sort of create it, and then we close in 3 layers, the muscle, then we put a patch that we stitch, and then we close the skin with a running suture, and we test the water tightness. So we had 2 groups, one under a lab, sort of lab anesthesia, and the second one under a real clinical anesthesia with humidification of the gas. And we didn't have any differences in terms of surgical characteristics, watertight, OSAT score, which is the quality, duration of the surgery, and duration of the insufflation. However, we saw tremendous differences, significant in terms of safety results. So the fetal pH and the fetal PCO2 were within normal range at baseline and at the end, and also within clinically acceptable range. That's the highlight that you see in gray. And the blue line is the one for the clinical anesthesia. And all the other parameters, oxygen, bicarbonate, lactate, and heart rate were also within normal range. The mother, the U, was also with normal parameters from baseline and during insufflation, only with this protocol. And when we looked at the membranes, the amniotic membranes, there were virtually no inflammation whatsoever. As well as for the brain, there was a difference, significant difference, specifically for the prefrontal cortex between the setup that we have and the older one. So higher neuron and lower apoptotic cells in the brain. So in conclusion, we can say that a simulated fetoscopic repair is safe under humidification, and the future work that we're currently undergoing in Leuven and in Brussels is in neonate and infants. We need to do experimental studies to confirm those results in rabbits, which is a good model for neonates, and also clinically in our patients. The second conclusion we can make is, based on the former recommendations, we need to check those boxes and use a one-way closed valve system, but also we need a humidified and heated CO2 system. So there are many things on the market that you've seen, but from what I've seen and to my knowledge, the currently only system that we have is this one. It's an American system, Lexion, where you can really get the gas into the abdominal cavity or thoracic cavity of the patient, and then you have a suction system that fully evacuated closed system with the proper filtration system. So that's my key message today. So thank you for your attention, and I'm happy to take any questions, I guess, at the end.
Thank you so much, Luc. It was very, very impressive, like always, your work on fetal surgery.
Thank you.
There is another system that is considered as closed, but some people say it's not so closed as we think. So to speak about that, because it's used a lot in robotic surgery, because it makes a very steady insufflation during robotic surgery, we asked Thomas Blanc from Paris, who is a day user of the robotic system, to tell us a little bit about this filtration system. Thomas?
Yes,
Thank
good
you.
afternoon. Thank you very much for your invitation and congratulations for this wonderful virtual congress. So we will talk about the IRCAD system. I have no disclosure. So in 2002, the European Association for Endoscopic Surgery made recommendation for the pneumoperitoneum for laparoscopic surgery. First recommendation, to apply the lowest possible pressure level. And second recommendation, at the end of the operation, you have to remove all the residual gas. They recommend the lowest intra-abdominal pressure, allowing adequate exposure of the operative field rather than using a routine pressure. So they advise to use 5 to 7 millimeters of mercury instead of 12 to 15. In 2014, a systematic review and a meta-analysis was published about the low pressure versus standard pressure pneumoperitoneum for laparoscopic cholecystectomy. And the conclusion was a low pressure pneumoperitoneum significantly decreased postoperative pain with a shorter length of hospital stay. So we will talk about the IRCAD system. I don't know if everybody knows this system. So the IRCAD is a class of valve-free insufflation system that enables a stable pneumoperitoneum with continuous smoke evacuation and carbon dioxide recirculation during laparoscopic surgery. And it facilitates smoke evacuation and filtration with 0.01 micrometers ultra-low penetrating air filter. So you have a valveless trocar, either 8 millimeter or 12 millimeter, and a 3-lumen filter that you have to connect to the trocar. So this is the valve-free trocar. You have 3 channels. The inner channel is for insufflation. The outer channel is for the monitoring of the intra-abdominal pressure. And the intermediate channel is for recirculation of CO2 and smoke evacuation. So this is a video to understand the system maintains stable pneumoperitoneum by recirculating filtered CO2 through tiny pressure nozzle within the proximal airseal cannula to create an airseal pressure barrier that is equal in force to the patient's intra-abdominal pressure. And the airseal mode allows the surgeon to operate with sustainable low pressure while maintaining the expected laparoscopic working space. So we have started to use the IRCAD system at the beginning of the robotic program in Necker in 2016. And it is very convenient because you have a stable pneumoperitoneum and you very quickly, you have a very good point of view on your operative field. So for instance, this is a 1-year girl with adrenal neuroblastoma. So you're working in a very tiny space in between the liver and the kidney. And the IRCAD system is very convenient for this kind of surgery. So the IRCAD mode provides automatic and constant smoke evacuation, improving visualization while maintaining stable pneumoperitoneum. So this is a comparison between IRCAD and standard insufflator. On the left, you have the IRCAD. With IRCAD, you have significantly less variability in pressure readings compared to standard insufflator, and you have less time spent within borderline range with pressure readings higher than 18 or lower than 12 millimeters. So when you start to do suction, for instance, here, you do 10 seconds of suction. With air seal, you have a very slight decrease at the start of suction or leakage, but pressure is maintained higher than 13 millimeters. With a standard insufflator, you have a more substantial decrease in pressure to values of 7 to 13 millimeters, which was followed by overpressure recovery after the leakage or the suction was stopped. So what are the recommendation for the COVID patient? So first recommendation, the SAGES, the Society of American Gastrointestinal and Endoscopic Surgeon. First, they recommend the ULPA filters that can remove 99% of airborne particles with minimum particles penetration size of 0.05 microns. And so they ask that all the pneumoperitoneum should be safely evacuated from the port attached to the filtration device before closure, before trocar removal, before specimen extraction, or before conversion to open. And most important, during desufflation, all escaping CO2 gas and smoke should be captured with an ultrafiltration system, and desufflation mode should be used on your insufflator. So the ARIS, the AAU robotic surgery system, made a recommendation and guidelines also, and they recommend the use of intelligent integrated flow system to allow the surgeon to keep intra-abdominal pressure as low as possible, ensuring a self-maintained constant pneumoperitoneum. And for the COVID-19, thanks to the ULPA filters, the smoke evacuation and filtration mode allows capturing the particle above 0.01 micrometers, and the SARS-CoV-2 aerodynamic size has been reported in the range of 0.06 to 0.014 micrometers. And the same for desufflation. It is mandatory to confirm the complete and correct disinflation of the pneumoperitoneum at the end of the procedure. So the French Society of Urology made recommendation also. So you can see on this slide the diameter of the virus and the diameter of the bacteria. So the COVID-19 aerodynamic size has been reported in the range of 0.06 to 0.014, and with the air seal system and the ULPA filters, you can filter up to 0.01 micrometers. So recently, a very interesting paper in Annals of Surgery was published about minimally invasive surgery and the coronavirus. And last month, a comment was published, and they recommend the need to use new insufflation system like AirSeal, which offers continuous smoke evacuation through an ULPA filter, allowing the capturing of particles bigger than 0.01 micrometers. And in addition, the new type of three-way insufflators keep the abdominal pressure low and has an integrative active smoke evacuation mode, which prevents the risk of aerosol SARS-CoV transmission. So of course, this system has drawbacks and limitations. The first drawbacks is when you use the AirSeal, your CO2 consumption is much higher. I couldn't find any publication stating exactly how many times you consume more CO2, but in daily practice, it is much more. As Luc Joyeux said, hypothermia is a major concern, especially in children, and you have to, when you use the AirSeal mode, you have to check and to control the temperature of the children. As Henri Steyer stated before, there is a theoretical risk of contamination of the intra-abdominal space with non-medical grade air during the suctioning, with a risk of air embolism, but I couldn't find any reported case in the literature. And finally, its cost, of course, because when you use the AirSeal trocar and we use the trilumen, this is an additional cost of 300 euros per procedure. So in conclusion, patient safety is paramount and the room for error is less in children. And I think that this kind of device can be very interested in children for complex procedures. Thank you very much.
Thomas.
Yes.
Thank you so much. Thank you so much to everybody, because we are on time. We have 10 good minutes, even 12 minutes to have a good discussion about that. Perhaps first, two preliminary remarks. The first one is that I don't know for the attendees, but in my mind, this round table shows that we have really to know the systems we use, even the basic systems we use, because we use since years every day insufflated electrosurgery. And I guess that most of us don't know really what they can do and what they can not do. And so I think it's important, certainly if you see with this pandemic, that we know which system is good for which type of surgery. This is my first remark. My second remark, and it's a little bit to begin the discussion with Juan, is that everybody speaks about this paper coming from the New England Journal of Medicine, but you have to know that experience is an experience and real life is real life. And the authors of the paper had to say that because on YouTube, of course, everybody says, oh, you have, when you go to the market, you have to take your clothes and not touch the things anymore, etc. They did an experience. So they pushed physically COVID in the middle of a water system on different types of surfaces. And then you can see that depending on the surface, it stays there for 3 hours, 12 hours, and sometimes 24 hours. But it's not so in real life, of course, because in real life, you do more aerosolization. And if you do that, you don't push it in a special mix system with water on a surface. So it's just an experience. Huh? This is important to notice in the beginning. So discussion about, are there questions, Mario?
Yes,
from...
Henry, we have some questions from François Bermure. It is a general question for all the panel. It says, could be efficient to use some devices that uses ionization of air, like the ultravision or midline, to help microparticles to fall down in the floor, in the surgical field. And the second is, remember that the ash could, during the eruption of a volcano, could be interesting to humidify the gas that is insufflated. Would that work for a virus also?
So the second question is for Luc.
Yeah, so I'm not aware of any study regarding, gas plus COVID, huh? But yeah, that's indeed a good question. So maybe we can do a multi-center collaboration working on that. Indeed, it could work. What we know is the humidification and warming and the gas decreases inflammation of all the organs and specifically the peritoneum or the pleura. And so it could have definitely an impact, because the higher the inflammation, the more porosity, permeability of the bowel. So if the patient is COVID positive and has some high viral load into the gut or into the blood, definitely with more inflammation, it can go through and potentially get then in the aerosol of the gas. Huh?
Somebody would give a response or try to respond to the first question?
Just to say that this is a very good question in terms
of course it comes from François Bermure.
Absolutely. And because it's true that humidifying the gas, the particles are not so much aerosolization during the procedure. So we have less aerosolization. So I think it's important to use always humidified gas, not only for the peritoneum, but also to reduce the size of the particles.
Okay, I have a question for Thomas. You see on YouTube some videos showing a little bit with the same system as Juan showed us with the mask, the air going out of the air seal system. But this is, of course, when you don't use the valve closed. It's when it's open, for example, when you have to extract a spleen, you have a steady insufflation in your abdomen with the system, even if it's open. But of course, you are speaking about the system when it's completely closed.
Yes, exactly. Yes, I've seen with interest this video, but the thing is, it's not CO2 from the abdomen that you see outside of the abdomen. It's CO2 that comes from the trilumen, because to avoid any leakage of CO2 from the abdomen, the CO2 creates a barrier of air to prevent any leak at the level of the trocar. So in this video, you can see air coming from the trocar, but it's not air coming from the inside of the abdomen. And it's totally different. And of course, you have to close the trocar. You have something that you can add at the trocar, and you have to use it as often as possible. And thanks to your presentation today, I've noticed that I didn't use the air seal system in the appropriate way for desufflation. So thank you very much, because you have to do something special at the end of the procedure so that the CO2 in the abdomen is stuck in the trilumen system and there's no CO2 from the abdomen going outside in the operating room. So thank you very much.
So you see that this confirms, yes, Fabio, this confirms that we have really to know exactly how our system works before we use it. And we don't do that enough.
Exactly.
Fabio?
I want to precise, because just before with the presentation, I can speak of everything, but this device is very nice. Probably is one of the best in the market, but there are other systems of aspiration that can be combined with the insufflator, and that automatically evacuate the gas with another trocar. For example, also Thomas shows that it can be used with the Veres needle separately, and so also other market. But you have to inform very well just before, as you told you, Harry, because there are also cheaper aspiration gas, active aspiration gas. You have to inform. Thank you to give me this topic, because it was very interesting, very large topics, but I'm informed about a lot of devices.
But again, I think it was important, Fabio, to show that even with our basic systems, if we adapt the ULPA filter and so on, we can be quite secure. And so it's not, if you cannot afford it because you are in a country where you have not the money to pay all this specialized system, even with the basic system, if you arrange it a little bit and you explain that very well, you can find solutions.
Yes.
So I have a question about the masks. Do everybody in your operating rooms use always FFP2 only for certain occasions, or what do you do actually?
So Henri, do you want that we go with the poll question?
Yes, so that's a good idea, Mario. Go with the first poll question during this.
We can make everybody participate to this excellent question.
Okay.
Okay, so let's go with the first question.
We ask all the attendees to go to this poll.
Everybody is invited to respond to this question. Everybody.
Okay, and we wait a few minutes.
Yeah. As we are waiting, I would like to comment that since the beginning, we recommended in our protocols to use FFP2 masks, and in every patient we operate now, not only PCR positive for COVID virus, we use a double mask. We use the FFP2 and then in front a surgical one, because with this you can change the external mask and put a clean one in case it gets contaminated. So this is the way we are doing right now in every case.
Wow, this is super protection.
Yeah.
So Mario, can we have the
Yes, we have out of 67 participants respond, 94% they use the mask.
Okay,
We
so
go for another question.
yes.
If you agree, okay. So in case of suspicion of a COVID, are you using special insufflation devices? In the meantime, somebody has another comment?
We will perhaps go through the poll.
If you want, I can do a comment about the mask just before we spoken about. The use of the double mask is also useful mainly for the effusion of the virus, because if you are positive, the second mask block the exit of the virus, but is not confirmed more safely with another mask just in front. I read some papers that are not so sure of this.
I think it's probably a good idea, the fact that if you have COVID on your mask, you take it out with your gloves, then you put it away, and then you put another one above the first one. It's not a bad idea. It's not a bad idea. Mario?
Wait, so from 68 participants, 68% respond no insufflation device, 31% yes. Okay, we're gonna go to the last question from this group. In case of suspicion of a COVID positive, can I see? You're postponing the surgery if it's not urgent.
This is very good.
We have some seconds for another comment.
As we are waiting, I would like to comment one thing about AirSeal, because all the graphics you have shown us, Thomas, was about 15 millimeters of mercury maintaining the pressure. I would like to ask how precise is to use low pressures, because that's a problem with all the insufflators, desufflators devices, with low pressures, not as high as 15 millimeters of mercury.
Very short response, Thomas, because we are 30 seconds late.
Of course, of course. With the SC system, you can choose the lowest pressure is 5. So you can choose 5, 6, 7. You can choose whatever you want. And even in very low pressure, it's the pneumoperitoneal is maintained stable.
Okay, thank you.
Thank you so much, Mario. We go through the last poll, and then we can end this discussion. Thank you, everybody, for this round table. It was great.
From 75 participants, 91% decide to postpone the surgery. And I would like to take the time also to inform you that in order to get in all the credits, you need to send the evaluation form that you will find in the IRCAD website. We're going to send the information how to download the evaluation form, and then you can send it to get the points for the accreditation.
Thank you so much. I hope that after this roundtable, most of the people will change their mind and use ultrafiltration systems, even on the normal insufflation systems, with at least COVID plus patients, because it's for the security, not only for the surgeons, but also for the nurses and the anesthesiologists who are in the room. Thank you, and I give the word to Philippe for the next session.
Thank you.
Thank you very much.
Thank you very much. Good afternoon.
Good.
Thank you for this wonderful roundtable. Now we move to the next session, which is a urologic session, but as a first presentation. It's my honor and pleasure to present to you Dr. Reva Mata, who is working in Lebanon in the St. Joseph Hospital, the hospital which was destroyed the 4th of August by the blast. So Reva did a survey of the literature regarding pediatric laparoscopy during the COVID-19 pandemic. And it he'll record it to the roundtable and also prior to the session of urology. Reba, if you are connected, Maria Grazia Scuderi is
Hi.
present and is the moderator of the session, working in Catania, Sicilia. Good afternoon, Maria.
Good afternoon.
And you will be committed to comment and to ask questions and to manage your session.
Of course, we have to go very quickly. So good afternoon, everyone. Welcome to urology section. I'd like to thank our president, Aristeyart, Philippe Montupet, all ESPES executive board members, the IRCAD team for this very interesting and new first e-congress. And at the end, for this opportunity that they gave me. The first presentation, as Philippe told, of this session is from Lebanon. And me too, before to start, I want to underline how we are enthusiastic about our colleague contribution. Who are clearly showing what real resilience means. Such a beautiful country which has already gone through a devastating civil war, hand on earth, we wish a fast recovery, and we are sure that Lebanon will make it again. So our first presentation is the pediatric laparoscopic during the COVID-19 pandemic, a narrative review by Dr. Riva.
Hello, everyone. Thank you for the lovely introduction. I'm really touched, especially after everything we've been through. That's true, it's all about resilience. And this week we resumed our activities after 6 weeks of total stop of all our activity. We finally resumed this week. So I'll be presenting today my presentation, which is a narrative review of the literature in the pediatric population. Can you see my screen that I'm sharing?
Yes, we can see.
Okay. So no disclosures. The pandemic caused by the SARS-CoV virus resulted in a major shift in the delivery of surgical services. The reluctance to perform laparoscopic surgery emerged from the theoretical risk of that the viral particle transmission in aerosols or in the smoke, especially due to the artificial pneumoperitoneum. And this was beautifully described previously in the round table. So we know that viral carriage and transmission is present and distinct in HPV, hepatitis B, and HIV. However, these concerns are speculative. There is no documented case currently that documents that documents that the viral particle.
Would you mind to stop the sound, please? Okay, you can continue.
Okay, sorry. So currently there is no documented case that demonstrates that the viral particle of the SARS-CoV is present in the surgical aerosols, and no viral transmission has been also reported in the operating theater. However, the absence of evidence is not evidence of absence. So surgical societies quickly rushed to publish guidelines regarding MIS in versus open surgery. And the rapid response was from multiple societies, mainly in the adult population, but little has been published in the pediatric populations. So as previously was stated in the round table, in the adult population, the overall favored MIS, arguing the benefit of improved patient outcome, satisfaction overweighing the theoretical risk of viral transmission, has yet to be demonstrated. So we reviewed the current literature. So a narrative review was conducted using the PRISMA guidelines. Search were performed using PubMed and Google Scholars. All the major surgical and medical journals were reviewed. We included original research, randomized trials, and review articles. Articles were evaluated initially based on the title and the abstract, and 2 authors independently performed the research, and of course, disagreements were discussed. 206 articles were identified from this database and search engine. 34 articles were included after duplicate filtration. And finally, 14 articles met the critical appraisal. Out of these 14 articles in pediatrics, 13 articles recommended laparoscopic surgery, but we have to pay attention and bear in mind that they also recommended abiding by the necessary modifications that were previously stated in the round table. and of course reduce operative time, reduce the electrosurgical devices and the number of staff present in the operating theater. Only one article recommended open surgery, arguing for also the operative time, and it was simpler for them and to use simpler equipment in the open surgery and thus less risk of aerosol generation. So similar to the adult surgery, the overall attitude in the pediatric favor minimal invasive surgery to open surgery when it is clinically indicated. Of course, some critical recommendations should be used to minimize the risk. It is very important to always consider conservative treatment whenever safe, and also postpone all elective surgeries. 97% of the current attendees agreed to postpone all the elective surgeries according to the institutional or the local guidelines. Consider specific time-dependent disease, and of course dedicate a theater specific for the COVID positive patients, a specific colon, and also use reusable instrumentations. So the general recommendations include the strict use of the PPE and the prevention infection strategies. Most people we have seen today, they use the FFP2 masks. Use small trocar incision during placement to minimize the leak. Use the low pressure, the lowest possible setting of the electrosurgical devices, and of course, perform CO2 aspiration during exfoliation as previously it was mentioned. So as a conclusion, MIS should be performed in the pediatric surgery when clinically indicated if we provide certain protective measures, and we should implement them. Although there is no evidence that exists in the literature currently regarding the risk of COVID transmission or carriage in the surgical aerosols, a lot of clinical trials should be done and are needed to understand the effective presence of the virus in the smoke and during surgical procedures and its concentration. So until then, we should monitor emerging evidence. Thank you.
Thank you. Thank you for your nice presentation. Very interesting. So there are no questions. I have a question for you. What was your personal experience for the first COVID emergency, and if there is something new, if something's changed now?
So at St. George Hospital, what we did is that we tried to first of all try the conservative management. For example, like the simple acute appendicitis, they were treated medically, and we are three surgeons in the division. We all had the same attitude. I only operated on 3 peritonitis patients that I could not postpone, but of course, after we did the PCR for the COVID, so they were not suspected, but we took the necessary measures. And then in July, we resumed a little bit our activities, which was between the first wave and the second wave of COVID, because currently we are in the second COVID wave. And we were able to resume through procedures. I did the splenectomy, like Thomas explained. So we had to, in the patient with sickle cell, that I could not postpone the operation a lot. So we had to pay attention also for the air leak. But all these patients had a confirmed PCR to be negative.
Okay, thank you very much. We have time just for one question. So thank you a lot. We are moving to second presentation. Is robotic-assisted transperitoneal laparoscopic synchronous bilateral adrenalectomy for Cushing syndrome in children, from French, Thomas Blanc.
Good afternoon, everybody. So we will show you a video, but to introduce this video, just to remind you that autonomous secretion of cortisol from the adrenal glands is a rare but challenging condition in children. Because of bilateral micronodular or macronodular adrenal disease, surgical strategy is a definitive treatment to correct hypercortisolism and its complication. Robotic-assisted transperitoneal laparoscopic synchronous bilateral adrenalectomy has never been reported in children. So we present here our surgical technique in supine position with 4 robotic ports along the abdominal midline and 1 assistant port. Can you start the movie, please?
Autonomous secretion of cortisol from the adrenal glands, also called ACTH-independent Cushing syndrome, is a rare but challenging condition in children. Because of bilateral micronodular or macronodular adrenal disease, surgical strategy is a definitive treatment to correct hypercortisolism and its complication. In our center, 4 children underwent synchronous bilateral adrenalectomy with a robotic-assisted transperitoneal laparoscopic approach, 2 for Carney complex in prepubertal girls and 2 for McCune-Albright syndrome in infants. The children were operated in supine position with only one setup working for both sides. 4 8mm robotic ports were inserted along the abdominal midline with 1 assistant port. The 30-degree laparoscope was placed through the umbilicus and the operating trocars were inserted below the xiphoid process, midway between the xiphoid process and the umbilicus and between the umbilicus and symphysis pubis. The case presented is a 7-month-old baby girl weighing 4.9 kilograms. On the MRI, the 2 adrenal glands were macronodular without tumor. The procedure was started on the left side. The descending colon and splenic flexures were mobilized medially using monopolar curved scissors. The duodenojejunal junction and the entire aspect of the left kidney were identified. The left adrenal gland was exposed in a very fatty environment. The edges of the adrenal gland were freed, being cautious not to grab the adrenal to avoid any dislocation of this very fragile gland and to avoid any bleeding. The posterior aspect of the adrenal was separated from the entire aspect of the kidney. The left adrenal vein was dissected and controlled with a vessel sealer without bleeding. The adrenal was totally freed and extracted in a finger glove. After booming the robot, the procedure was done on the right side. The ascending colon and hepatic flexure were mobilized medially using monopolar curved scissors. A kosher maneuver was performed to mobilize the duodenum until the vena cava was visualized. The right border of the vena cava was exposed and the internal edge of the right adrenal gland was dissected. The entire aspect of the vena cava was dissected from the liver. The limits of the adrenal gland, the renal vein, and the adrenal vein were identified. The right adrenal gland dissection was performed similarly as on the left side, without grabbing it, but by lifting it to avoid bleeding. The right adrenal vein was dissected and controlled with a vessel sealer without bleeding. The adrenal was totally freed and extracted in a finger glove. Neither intraoperative complication nor bleeding occurred. Mean duration of hospital stay was 14 days due to the time required for an equilibration of the hormonal treatment. In conclusion, robotic-assisted transperitoneal laparoscopic synchronous bilateral adrenalectomy is a safe and feasible procedure in children, including infants.
C'est la photo du vieux temps, ça. Le son. Le son. No sound.
So, thank you. Can you hear me? Okay.
Yes.
Thank you for this exciting video. We have time just for one question. I have read the comment, amazing video. So I have a question for you. what was the difficulties, the obstacle that we have found during the procedure in a 7 months old patient?
Thank you very much for your question. The issue with these very young children with hypercortisolism is that you have to do the procedure in a very fatty environment. So you have to struggle with the fatty tissue. And as you've seen in the movie, the adrenal was quite difficult to find in the fatty environment of the mesocolon. But with our experience, we know how to create space, even in very small children. And as highlighted in the video, we had no difficulty in the perioperative period, no bleeding, no conversion, and no organ injury. So of course, you have to be very careful because the space is very tiny, but you have to be very meticulous during your dissection, but you can do it without any problem.
Thank you. And just a technical questions. Do you use the XI robot?
Yes.
Yes, and the distance between two arms was 4 centimeters?
It's shorter because you have to put 4 arms.
Yes.
And the distance between the xiphoid process and the pubis was 13 centimeters. So it was there's no conflict because you work in a very tiny area. So there's no conflict in between arms, between instruments with the patient.
Thank you very much. Unfortunately, we have to move on. So the third one presentation is robotic surgery for iatrogenic ureterovesical stenosis. Present Dr. Badir. Thank you.
On va faire un petit changement. We're going to do a small change in the program.
Okay.
Maria Gracia, and we're going to move to the next presentation.
Okay.
In the meantime, that we fix the problem with this presentation.
Absolutely. The next presentation is vas deferens sparing laparoscopy removal of a large prostatic utricle. Presentation of a techniques from Mahmoud Marei from Manchester and Cairo University.
Hello. Good afternoon, ladies and gentlemen. Can you hear us?
Yes.
Good afternoon, ladies and gentlemen. Thank you for the opportunity to present this work. So, enlarged prostatic utricles represent a part of the Mullerian duct remnant spectrum, and they are classified or graded according to their relationship to the bladder neck and the external urethral sphincter, their size, and the distal opening into the urethra or towards the veriomontanum. There are important technical considerations and surgical difficulties regarding the excision of possible Mullerian duct remnants and prostatic utricles, which relate to the relationship of the vas deferens as it travels from lateral to medial to approach the wall of the prostatic utricle or the Mullerian duct remnant, and then travels alongside or within its wall. This is a view from the front, and this is a view from the back, demonstrating this anatomical relationship. There are two thoughts or ideas about how to avoid damaging or jeopardizing the vas deferens while excising them. One of them is near total excision, where a transection of the Mullerian duct remnant or the prostatic utricle is done above the level of the entry of the vas. And the other one is a longitudinal splitting or division, preserving the vas as it enters from lateral to medial if the entrance is very high and would then necessitate a long dissection if they are to be mobilized. So we present a case of a 4-year-old boy with a large prostatic utricle associated with penoscrotal hypospages that presented with recurrent urinary tract infections, where during laparoscopy we found that both vasa differentia entered into the prostatic utricle high up around the fundus or the cornea and traveled along its wall. This is the video presentation of the case that we have operated. So this is the bladder and the prostatic utricle behind it in a cystogram, and this is the endoscopic view with the scope going into the urethra all the way in and then through the utricle, showing urine with debris. And this is the laparoscopic view with showing the bladder and then the deep rings on either side with the vas difference entering them. And this is combined cystoscopy with laparoscopy, shining the light into the bladder and demonstrating it. And then the bladder is being pushed or mobilized anteriorly to show a bulky structure, which is the prostatic utricle. Behind it was the vas difference traveling on either side from lateral to medial to join into the cornea or the fundus of that utricle. And then this is the cystoscope introduced into the prostatic utricle to demonstrate it and identify it and create countertraction. The retrovesical space is created by incising the peritoneum and mobilizing the bladder anteriorly. Here the peritoneum is pushed laterally and the vas is shown traveling along the wall of the prostatic utricle, signifying difficult mobilization that would jeopardize or damage the vas if it's to be mobilized. So we've decided to bi-halve the structure in the midline all the way down in the midline, away from the vasa on either side, down to the urethral opening. And this is the view of the utricle from the inside. And then we started trimming the utricle on either side. This is mobilization of the utricle from the rectum. And this is a barbed stitch being placed down in the apex of that incision. We searched for the opening of the vas into the utricle on either side. It wasn't possible to find it. In adult practice, sometimes they inject methylene blue into the vas and see where it would be emerging on the outside, but this was not feasible or possible here. This is the side of the utricle structure suspended by vicryl stitches to the abdominal wall. And then further trimming of the cyst is done to leave only a rim or a ridge or a margin of tissue on either side overlying the vas difference as a continuation of the vas towards the ejaculatory ducts and excretory system. And then this is tubularization of this tube on either side. The right side is completed and now the left side is being completed. So we believe that this is an approach that can maintain the continuity of the vas as we are showing here, allow maximal trimming of the prostatic utricle or the Mullerian duct remnant, and tubularize the structure all the way to preserve fertility. So this is the operation completed with the vas remaining in continuity all the way down to the ejaculatory system and the urethra on either side, and with the structure trimmed and excised to the maximum possible. So the patient was discharged on the second post-operative day and had an uneventful recovery. So this is the thought or the idea of the procedure that was performed, with the median of the structure excised and tubularization on either side. So this technique allows for preservation of the vas whilst excising the utricle and achieving the primary goal of preventing the urinary tract infections and preserving sperm delivery. Thank you very much.
Thank you. Very interesting.
Thank you very much.
I made this operation with combined approach. It is very easily. And I have two questions. First one, why you don't use the endostapler to cut the redundant part of the remnant, the utriculus?
The
yes.
stapler, the endo-GIA stapler.
Yes.
Well, it is possible, but the staples will be non-absorbable structures left along, you know, the continuity of the vas. That would, my preference would be to do the stitching, and with the barbed stitch, you know, I would think that that would be
was better with the resorbable.
Yeah.
The utricle was the utricles were very large, so we could excise.
Yes, I saw it. Yes, it was easy to perform the suture. I have one question for Dr. Azeri. Basal reflux may persist. Can you hear me?
I can hear you.
Okay. So, do you want to answer to these questions?
So, the question is that there could
basal reflux may persist.
The basal reflux may always persist in these cases, and there is no definitive way, to my knowledge, that can avoid that. There are kind of literature and publications in adult practice about reimplantation and vasal reimplantation, which is technically extremely demanding. It would possibly require an anterior sagittal approach, a perineal approach. However, at that age, in a 4-year-old, all what we can do is to observe, and if recurrent epidermolysis happen, then we can come to that problem and start thinking about addressing it. There are some of these children that might end up with a vasectomy. We don't think that this will be the case in our patients. We think that as far as the follow-up has been completed, it has been at least maybe 1 year now, and the patient has not had any recurrent urinary tract infection.
Without recurrent of UTI or epididymitis?
No.
No.
Without no epidermolysis and no definitive or documented urinary tract infections. Back to your question about the endo-GIA stapler, I just want to add one thing, that I think trimming with the ligature or the Lotus device or an energy device and then suturing would leave less of the Mullerian duct remnant bulkiness overlying the vas. So it will be more precise and would allow more excision of the unwanted tissue and more preservation of the vas. That is another addition to
the goal. Okay. Thank you so much. Thank you.
I have a question, perhaps.
Yes.
Maria.
Question for President. Yes.
Congratulations first for this fantastic case. I used it once in para-ureteral diverticula, and I did the same with the cystoscope and the laparoscopy. And indeed, when you have this double approach with the light coming from the urethra or the bladder, it makes it much easier. My question was, I was perhaps not completely in your topic. Did you speak about how long you put a urinary drain after the operation?
The catheter
drain?
We kept the catheter, but I think we kept it for a couple of days, 3-4 days. The child was very well the next day, so we could send him home basically one night, stayed over, and then catheter came out and was okay, still okay, fingers crossed. Indication was we didn't want to do these operations after we discovered the utricle, but he was keep coming back with urinary tract infection and very turbid urine in the prosthetic utricle. So we decided to go ahead, and then we finished it like that.
Congratulations.
Thank you. Thank you.
Thank you. So the next presentation is assessment of the effect of surgical correction of varicocele in children on testicular condition. Is from Russia, Dr. Yazik.
Dear chairmen, friends, let me introduce our work about assessments of the effect of surgical correction of varicocele in children and testicular condition. Particular attention is assessment of fertility is paid to the function to the blood test barrier, which can be analyzed by the presence of Claudin 11, inhibin B, and other markers. I have nothing to disclose. And the target is to determine the degree of impairment of SCB function in children with varicose cell for scientific justification of surgical intervention, as well as determination of the duration of follow-up period. The tasks of the study was to determine the echographic signs of the structural testicle damage and the microcirculatory state before and after surgical treatment of varicose cell. To investigate the correlation between the level of inhibin B and ultrasound data and testicular microcirculation depending on the duration of observation of the patient before surgical correction of varicose cell. Assess the state of the SGB in children with varicose cell in pre- and post-operative periods based on the level of Claudin 11. To perform a post-surgical long-term evaluation of the SGB function status after correction in varicose cell. Decrease of the level of inhibin B is strongly correlated with the decrease of testicular volume on the quantitative indication of spermogram. In this regard, is a sensitive markers of spermatogenesis and infertility. Claudin 11 is a key protective factor in the intercellular interaction of sertolid cells and prevents the passage of anti-sperm antibodies from the systematic bloodstreams from the SCB, as well as germ cells into systemic circulation. The sertolid cell barrier is a type of histochemical barrier in animals. It's formed by the tight contacts between sertolid cells and prevents migration of mature sperm into wound. The design of our research is on a slide. According to the objectives, 96 boys aged 11 to 17 years were included into this study. 76 children of them were the West left-sided varicose cell of the 3rd degree, and 20 children for the comparison group without any andrological surgical disease. Children with varicose cell were divided into 2 groups, depending on the observation period before surgical correction. 38 children with a follow-up to the 6 months and 38 children with a follow-up of more than 6 months, but less than 1 year. Before surgery, all patients underwent ultrasound of the tissues and organs inside the scrotum with Dopplerography and determination of the level of inhibin B, anti-sperm antibodies in Claudin 11, using enzyme-linked immunosorbent assay. The same state of examination was carried out 1 and 6 months after surgical treatment. Based on the study, the following studies were carried out. An ultrasound examination of the tissues onwards inside scrotum. This figure shows an ultrasound picture of varicose veins of the left testicle and pampiniform plexus. There is a number of methods for surgical correction of varicose cell. We prefer surgery according to the Marmar operation and laparoscopic ligation of the testicle vein and the most advanced surgical treatment methods with the highest percentage of positive results. We found that the early postoperative period, 1 month after surgical correction, children of all groups showed a tendency to improvement, and after 6 months, there was a significant increase in the volume of the left gonad and the normalization of the resistant index. After surgery, regardless to the method of surgical correction and the terms of follow-up to surgical treatment, we noted a significant increase in the level of inhibin B. We found a direct correlation between inhibin B and the volume of the affected testicle. A similar correlation was obtained between the resistant index of the parenchymal vessels of the left testicle and its volume. The low concentration of Claudin 11 that was relayed by us before surgical correlation did not change after surgical treatment and corresponded to that of the comparison group. In our results, surgical correction of varicose cell regardless of the chosen method improves the state of testicular blood flow. 6 months after surgery, statistically significant increase in the testicular vascular resistance index is noted. A positive correlation between the resistant index of testicular parenchymal vessel, testicular volume, and inhibin B level and the postoperative period allowed to use the indicators and markers of assessment the state of the sertolid cells barrier. There were no signs of impairment in function of sertolid cell barrier as a result of surgical intervention based on the results of serum Claudin 11 concentration. Surgical treatment of varicose cell in children does not adversely affect the level of inhibin B, which is assessed as marker of the state of the SCB in contents of immunological barrier function. Increase of inhibin B throughout the follow-up period indicates a positive effect of surgical correction during period of puberty. Comprehensive analysis of the markers of the state of hemotesticular barrier in combination with ultrasound of the scrotum organs showed that surgical correction of varicocele does not negatively affect the testicular condition in the early after 1 month and the long term after 6 months postoperative period, and also positively affects the future the formation of the productive sphere of adulthood. Thank you for attention.
Thank you. Very interesting. And I have one question. So, any other further tests been carried out beyond 6 months or in case of recurrence?
Sorry, it's...
So, did you test the inhibin B after 6 months or in case of recurrence of varicocele?
Yes, of course, we tested.
What was the level of...
The level is the same, because if we use a corresponding group, it's the group with nothing changes.
Nothing's changed.
Yeah.
Okay. And what do you think about the second degree of varicocele? So about what do you think about the second degree of varicocele? Test or inhibin B can be useful?
Of course, the more correlative results is in the third group. In the second group, it is not so correlated, but it's higher too.
So it's interesting to test as well. Okay, thank you. Any questions for the audience? Any comment? Thank you very much.
Thank you.
So the last presentation of this urology section is from Leeds for and against robotic transvesical surgery in children, Dr. Azad Najmaldin. Good afternoon.
Can you hear me now?
Yes.
Am I supposed to share the screen now?
Go ahead. The green arrow, please.
Yeah, yes, I did. Is it working? No?
Not yet.
Green arrow. Here, what? Is it not working?
Actually, no.
Well, I don't know what else to do. So one big green arrow in front of me, I'm pressing it, it doesn't work.
And it should open a window, and then you select your presentation and share.
I have opened my presentation. I am on you. I tested it. It worked. Can't see anything.
So on your Zoom on your Zoom window, at the bottom of your Zoom window, there's a green arrow. You click on it, share.
I am pressing the arrow.
And then there is a window opening. You select your presentation.
Yes.
And at the bottom of this window, bottom right, there's a share.
Can you see it now?
Yes, great. Just have to run. Yeah, perfect.
Sorry. Here it is, me. 2 minutes is gone. Right. Okay, Maria, keep an eye on me, please.
No problem. We have time. So let's go.
It goes with age. Anyway, first of all, thank you very much, Maria. And thank you so much for everybody in ESPES who made this initiative and made this e-Congress possible. It's unique. It's the first time. I am delighted to be part of it. Now, You all know the place of minimally invasive surgery in children for bladder surgery is pretty controversial. Nothing is settled. The majority of surgeons in Europe is still doing open surgery rather than laparoscopy or robotics. First 10 years I did open, second 10 years laparoscopy, third 10 years robotic. Position, you don't need to talk about. Now, a few little points with regard the patients and the bladder. If you are very lucky, you may get a bladder of this size. The majority fall between midpoint from pubis to the umbilicus. You could put your ports anywhere here as is shown, but you can go further in if the patient is large or if the bladder is small. You need to have a purse string around your primary port and be wary when you place ports, working ports, be wary of the crevices of peritoneum. Now, clashes is not uncommon in robotic, particularly when the specimen is very small, and you just have to bear it and learn it and avoid it. View is superb, much better than laparoscopy, and the vast majority of the cases, if you are careful enough, you hardly see any bloods. Now, the dissection is straightforward. In the majority of cases, a monopolar hook diathermy is used. Now, suturing, 8mm needle, usually spatulated. It stands the pressure of the robot, the instrument's handling. And you may or may not need to repair the bladder wall. Here you are, you see this great big gap when you have to repair. But there, when you mobilize the ureter, you don't have to bilateral, etc., etc. Stenting is important, in my opinion, and I tend to fix them for so many days. A urinary catheter, urethra, I try to avoid. Usually a suprapubic cyst fix is good and serve the purpose. Analgesia is very rarely required, and they are usually home the following day. You may be, if you're lucky, you may be able to send them home in the evening if you happen to have done surgery at the beginning of the day. And I usually bring them back or ask somebody to remove the catheter and stent. They don't have to see me, and they don't have to be done in the hospital. And they are usually reviewed regularly. 9 different operations in a small number of patients. Now, the first 4 years, 26 patients, 44 procedures. That means most of them needed more than one procedure. The youngest I have done was 1 year of age. The oldest is 14. And pre-existing bladder morbidity, such as neurogenic bladder or acute on chronic cystitis, etc., were nearly in half of the patients. Previous bladder surgery existed at just over 10%. Conversion was my problem. A third of the patients were converted. Do please remember that this is a learning curve, and I am doing it not just to teach myself, to serve the purpose and to do better than my previous technique, which were laparoscopy or open. So sometimes a conversion happens before actually placing the ports. Sometimes it happens after a reasonable amount of dissection, or even part of the half of the procedure if they were double procedures. The contributing factors are interesting. You may be seen. The majority have the pre-existing morbidity within the bladder. Muscle relaxation with moderate anesthesia, which I'm going to come back to in a minute. Small capacity. They were the main reason for conversion, fogging and splashing fluid on the surface of the telescope were others. On 2 occasions, the nurse was so inexperienced, didn't know what instruments is what, where to stand, what to touch, etc., etc. You probably wouldn't put up with such assistant nurse, but I'm afraid in our country, the rules dictate that you have no right to tell anybody who are lesser than they are. You just have to bear with them. So in those circumstances, I had no choice but to change. On one occasion, the technique was a new technique, a new operation, but I failed to pursue it. Operating time, fairly reasonable, as you read it. Hospital stay less than 1 day and follow, as I said. There were no complications in theater. There were no complications in hospital. And I have not done redo surgery. My biggest problem were conversion. Where were the problems? Space. The problem is sometimes you have a 4 or 5 kilogram baby. The bladder is going to be small. Sometimes you find that the bladder wall is thick, neurogenic, or infected and thickened over a period of time, and they're very difficult to distend. Anesthesia, if the patient doesn't relax or fully paralyzed, it does affect the bladder size, and you just lose the space. Instrument size, you all know, splashing and clashing between instruments, patients, patient anesthetists, etc. You just have to be careful, and they are all avoidable. Large obstructed ureter, they are a problem for any technique you employ, and modern anesthesia is, as I said, is an issue. The majority of people who are working with specific surgeon with this kind of technique, whether it's robotic or laparoscopic, they understand their circumstances and they relax the patient. But if you have an anesthetist for the first time coming to anesthetize your patient, often they are not paralyzed, and often they are not relaxed, and often you can't distend the blood. And of course, the usual problem for all pediatric surgeons, small number, 9 different operations in 26 patients. One patient is 5 kilogram, another patient is 10, another patient is 25. So you have to change. And each time they have their own problem, produce their own problems. If you want to compare my own results, you will find the conversion were much higher in robotic compared with laparoscopy. And probably because, one, I used to have dedicated anesthetists, dedicated theater team during laparoscopy, but with robot, I didn't, and I don't. But for anesthetic time and operating time, they were both shorter with robotic surgery. Complications were equal, hospitals, they were equal. Ergonomic was by far superior. You, at leisure, you could do the operation. For those of you who are used to laparoscopic bladder surgery, you do find you do have to stretch your arms, shoulders, etc. Cost, I don't need to say anything. Now, the conclusion is robotic definitely facilitates surgery. It makes laparoscopy significantly easier. It does give you low complications. It does give you very good results. And you find that the conversion is high, especially if you are starting and you are learning and you don't have anybody to teach you. The success of the operation is dependent on the size of the bladder and whether or not the patient is paralyzed, in my opinion. Smaller instruments are undoubtedly helpful, and the importance of dedicated theater team will be overemphasized. And that video you probably have missed, that is my young daughter. She's Down syndrome, and you see the shaking hand, the surgeons. She scored 73 in doing the first line exercises using a robot. So I guess what I'm trying to say is if you could manipulate robots to 73% success scoring, then I think anyone and everybody would find it's far more enjoyable to use during surgery. than you would otherwise. And thank you.
So thank you very much, Azad, for so clear presentation. So, which are for you the best advantages of robotic surgery for this kind of procedure?
It's primarily is the manipulation and handling and suturing. It's not just good for the patient, it's not just good for accommodating your instrument sutures within the bladder, it's good for your shoulders, your back, your brain, etc. And I think often people ignore the comfort of surgeon, but here I like to re-emphasize, you could operate at the age of 70. You probably find with laparoscope, you may have to give it up at 69. So I think there is an advantage, yes. And I think the viewing is perfect.
Yes, that is perfect. And did you ever do the tapering of the ureter?
Yes, yes, only one occasion. Only one occasion. As I said, you've given me 5 minutes to talk. That's why I've run through. Really, that obstructed ureter slide, which is in the middle, that was quite large. Yes, but it's not easy laparoscopically, and it is not easy robotically. But it is definitely easier.
Yes.
There's only one case.
Yes, one question from Steyart.
Yes, Azad, hello. First,
hello.
For all the attendees of this Congress over the world, I present you Azad Najmaldin, who is the founder of the ESPES. It was his dream, and it made it possible, and now ESPES is at its 10th anniversary, and it's principally due to Azad Najmaldin. So thank you for that. I have one comment and one question. The comment is, you know, I'm married with an anesthesiologist, and I think that modern anesthesiologists are able to use new drugs and so on, that curarization is not always necessary anymore because there are new drugs. But this is just a comment. My question is, you spoke a little bit about space, that you had problems with space sometime in the bladder, and we have the same experience, of course. But I see that with the robot, you used 5mm instruments. Did you think about using 8mm that are moving much shorter in the bladder?
Yes, yes. One of my slides had that because, as I said, I heard a threat from Maria yesterday, stick to 5 minutes. And I got 18 slides, so I couldn't say spend more than 10 seconds per slide. Yes, some of my instruments were 8mm. At the beginning, they were all 8mm, then shifted to 5mm, then combination, then finally just 5. So I think there's no doubt. In fact, my slide, it says that it's more versatile, it's easier to use, and you've got more choices. The problem is, if you've got 1 or 2 kilograms, in a small bladder, particularly if the bladder is thickened and inflamed, you just find there are big holes. And the 12mm telescope, it does heat up the bladder. And within 20 minutes, it causes so much inflammation on the surface of the bladder, constantly fluid dripping on the surface of the telescope. And that's what I meant by splashing. So forever you have to wipe your face while you're doing the operation. These are the problems with the robot, but I think there are still advantages, at least in the majority of cases, over laparoscopy for me. And I think going back to the anesthetists, I got lovely anesthetists. I have wonderful anesthetists. The problem is I have changed 14 different anesthetists in doing 420 robotic procedures, 14 different anesthetists. The one who appears in the morning, when I said, I want a fully relaxed patient, they tell me, go and sit down, have a coffee, don't tell me how to do the operation. There is no comparison between fully paralyzed abdomen and bladder from paralyzing agent compared with morphine-like agent, sedating the patient, semi-paralyzed. Paralyzing means paralyzing, but there's no doubt from an aesthetic point of view, from patient point of view, paralysis is not as good as analgesia. But for surgeons, it's a menace. And I have seen wonderful surgeons around the world operating in tiny little spaces, and my heart pumps from 60 per minute to 260 because they hardly got space from distended bowels, from non-distended abdominal wall.
Thank you.
So my regard to your good wife.
Thank you very much. Thank you very much indeed for all speakers, audience, for this stimulating discussion. The urology section is officially closed.
Est-ce que tu proposes 2 minutes de break ou la session suivante?
Ah ben, c'est fait.
La réponse est donnée. Bon. Perfetto. Bon. On est aux 2/3. Et c'est bien. Maria Garcia, elle a bien préparé son travail.
C'est bon.
C'est bon? Yes. It's the fourth scientific session of 3 papers, and it's devoted to research, miscellaneous, robotic, learning. And we are very grateful to Carlos Guiné from the Hospital Valdebron in Barcelona, Spain, to be the chair of this session. Carlos, thank you for your collaboration, and take the session now.
Thank you very much, Philippe. Thank you. Good afternoon, dear friends. Good afternoon, everybody. I'm glad to be here to introduce this very interesting session. We have very, very interesting papers to be presented. And I want to highlight the tremendous work and effort that Henry, Philippe, all the executive board, all the scientific board and IRCAD have done to perform this electronic congress. So thank you for accepting this challenge that was very difficult this year. So we're going to start with the first presentation that comes from Naples, Italy. Dr. Scolino will talk about the endoscopic treatment of the pilonidal sinus, in which they have a huge experience. Maria, please, we hear you.
Thank you. Good afternoon. I would like to thank the organizer for this congress. And as you know, the advent of pediatric endoscopic pilonidal sinus treatment, PEPSIT, has revolutionized the surgical approach to pediatric patients with the pilonidal sinus disease. We reported with our experience, very good outcomes with this technique for treatment of both primary and recurrent PSD. After a 3-year experience with this technique, we believe that the key point for success of a procedure was not only the standardization of the operative technique, but also the accurate pre- and postoperative management, including laser ablation and wound treatment. So we aimed to standardize a multi-step PEPCIT protocol and to assess the long-term outcome of this protocol. 127 pediatric patients with PSD were operated using PEPCIT in our unit over a 3-year period and were included in our study. The average patient age was 16.7 years. 15 patients had recurrent PSD after open repair performed in another unit, surgical unit, and 7 patients presented a concomitant pilonidal cyst. Our multi-step PEPCIT protocol included 3 steps. The first one was preparative laser epilation. The second step was PEPCIT procedure. The third step was postoperative management, including wound dressing and laser epilation. Before surgery, all patients received the laser epilation using the pulse dye laser. The treatment area included the intergluteal crease and an additional 5 centimeter area on both sides from left to right of the natal cleft. Thereafter, patients received the surgical procedure PEPCIT. The 10 French fistuloscope was introduced through the external fistula orifice. All the hairs and the bulbs were identified and removed under vision using endoscopic grasping forceps. The inner aspect of the fistula was then debrided using endobrush and finally coagulated using a monopolar electrode, commencing in the main tract and traversing where necessary secondary and accessory tracts. At the end of the surgery, the external pit was left open. In the third step, the patients received our specific drug.
A 2% eosin solution is topically applied on the wound. An oxygen-enriched oil-based gel is directly injected into the fistula's tract and also topically applied on the wound. The wound is covered with a wet gauze. A normal dressing is finally performed. These dressings are repeated at least twice a day for 2 to 3 weeks postoperatively.
After completion of the wound healing, patients received definitive laser epilation. Regarding the results, the average operative time was 25 minutes. No complications occurred inter-postoperatively, and most patients were treated in a day hospital setting. Preparatively, patients received at least 3-4 laser epilation sessions at 4-6-week intervals, according to their local status. And the average healing time was 24 days. This was the wound healing outcome at 1, 2, 3, and 4 weeks postoperatively. The overall success rate was 95%, with a recurrence rate of 4.7%. All recurrences were successfully treated using PEPCIT. And patients required an average number of 7 laser epilation sessions to achieve radical hair removal. And all patients returning to their daily activities mean at 2 days postoperatively with no physical limitations in the postoperative period. And we would underline some technical key points. One of these was the use of an adequate instrumentation, in particular the fistuloscope, that can be rotated in different positions using its removable handle. One trick is to turn down the fistuloscope endoscope in order to achieve a good vision of the fistular roof and to identify and remove some hairs on the fistular roof that would be missed using the normal position of the fistuloscope. Other technical tricks are use of a standardized technique, an adequate setting of the operative theatre, and the experience of the surgical team. In conclusion, based upon our experience, we believe that PEPCIT should represent the gold standard for surgical treatment of pediatric patients with PSD. The procedure is very easy and fast to perform with a short and painless postoperative course and a very low recurrence rate. But it is crucial, in our opinion, to adopt a standardized multi-step protocol, including pre- and postoperative laser epilation, PEPCIT procedure, and wound, specific wound dressing. The best result of our protocol was, in our opinion, the great results, the great satisfaction of our patients. And we look forward to see you in Naples with our next PEPCIT symposium that will be held on December 11th, 2020, with our missed courses next year. Thank you for attention.
Thank you very much, Maria. And we have two questions from the audience. The first one is, have you made any comparisons between the PEPCIT and the GIPS technique? Coming from Dr. Dieguez.
No, because we have a shift from open surgery to directly to endoscopic procedure. No, we did not perform the GIPS technique before PEPCIT in any way.
Okay, and from Dr. Stoica, how long is the follow-up of the patients?
We follow up the patients after surgery at once a month, and we continue the laser epilation treatment until there is no longer any visible layer in the treatment area. So the follow-up period is at least 1-2 years after surgery.
All right, and I have a question myself. You've been working with this technique several years, and do you think it's the last version of the technique, or are you trying new innovation like the use of phenol or trichloroacetic acid on something different?
No, this was the last version of the technique. We probably we are applying also laser energy to treat the external orifice, but we need more further experience to establish this technique.
Thank you very much. Thank you very much, Maria. We move on to the next presentation that comes from the Netherlands. Dr. Leijten will talk us about the education in minimal invasive surgery. He's going to talk about transferability between the robotics and laparoscopy. Eric, please, all yours.
Oh, thank you. Good afternoon, and thank you for the opportunity to present my work here. I'm going to talk about the transferability of the robot-assisted versus the conventional minimal invasive method in training, because as we have already seen today, it's really important to have a correct training, and that there is a high complexity in the pediatric minimal invasive surgery, which makes the skill training also really essential, because otherwise you would just be practicing on children. Therefore, and we have a lot of new techniques, as we have also seen today, from which the robot-assisted surgery is considered a more intuitive approach compared to the conventional minimal invasive surgery, such as laparoscopy. So we try to find out what is the influence of these two techniques on each other during the skill training, and how do they influence each other. We did this by using two simulators, the EUSIM augmented reality simulator, which provides instrument tracking by colored markings on the instrument tips. And also, because it was an inanimate box trainer, we could adapt it to tasks of the other simulator, which was the Robotics virtual reality simulator, which is a robot-assisted simulator, which is a standalone from the Da Vinci system. So it doesn't have to be at the OR. And we could use outcomes like time, but also more instrumental metrics off screen, for example, for safety, And from these, we calculated composite scores from previous validation studies we performed on both simulators. This was the flowchart of the groups we recruited. We recruited participants without any experience in either of the simulators or the clinical experience, but with the experience in the medical field, so they know what they were talking about and what they were going to do. And there we have the first group that they had introductory talks for the conventional MIS tasks, so the intracorporeal suturing, tilted plane needle transfer, and the anastomosis needle transfer. Especially the suturing is the thing that I will show today, which I did up to 20 times or earlier when they reach a plateau phase. After that, they switched to the robot-assisted learning curve, and the other group, group 2, did the other way around. And thirdly, we also had a group of participants with minimal invasive experience, but without a robot-assisted experience. From the overall results, we found that there was a better time and composite scores from the robot-assisted after the robot-assisted task during the conventional minimal invasive task, and also from the robot-assisted on the minimal invasive task as well. So it works both ways, but there was also more results from the robot on the minimal invasive, which we saw from the results here. You see that the composite score, which ranges from 0 to 100, which we also calculated a cutoff score from experts from previous validation studies, and you can see on the left that the group that first performed the RAS performed a quicker gradual increase, and on the right you can see that the clinical experience of the group, the clinical third group, has a similar curve as well as the participants without any clinical experience. So it's like a control group. That's what we have shown here, is that there is transferability in both groups, so they have a transfer in both ways, which makes it a positive effect from robot-assisted on the minimal invasive, conventional minimal invasive results, vice versa as well. But our most difficulties were that there is no pediatric surgical simulation for the robot-assisted surgery, because the EOSIM, the conventional minimal invasive system, was able to be adapted for pediatric surgery, but the robot-assisted surgical system was not. So that limited our results to the real pediatric simulation, but would be very interesting in the future. Thank you.
Thank you very much, Rick. And let's check if we have questions from our colleagues at home. I don't think there are questions yet. So I have a question myself. As you know, with the robotics, we have a lack of haptics. So have you checked or have you considered to do any exercise in dissection to see the transferability between the conventional minimally invasive surgery and robotics?
We did it with dissection, but we also, in the further results, we also checked the off-screen, especially because due to the lack of haptics, off-screen movements are very dangerous. And we saw that the robot-assisted experience actually made the participants perform very much lower with the off-screen parameters compared to the conventional minimal invasive participants. So they were much aware.
Perfect. And if you have both technologies available in your center, what would you design there? How would you design the education for the new trainees? First robotics and then minimal invasive surgery simultaneously?
Well, from my experience from the studies, it's very interesting because actually you see participants that they gain their skills most fastly with the robot-assisted system, and the laparoscopic system goes a bit further as well. So I think a combination of the two would be very interesting to have a really short learning curve.
Right, we have a comment in here from Monsieur Wegner. He says, surprising, group 1 should be better than group 2 normally, as it has been explained at the beginning of the robot. Do you have a comment on that?
What does he exactly mean, group 1? It was the group 1 that was indeed better, yeah.
Oh, okay. Thank you very much, Eric. It's been very, very interesting. We move on to the next session, to the next presentation.
Thank you.
Thank you very much. The next presentation comes from Paris, from France. It's from Dr. Blanc, and it's about the robotic surgery in neuroblastic tumors. Thomas, it's your turn. Thank you.
Good afternoon.
We hear you.
Thank you very much. Do you see my presentation?
Yes.
Okay. So good afternoon, everybody, dear chairman, dear colleagues. I have no disclosure. So neuroblastoma, ganglioneurobastoma are tumors and can be fragmented during surgery. In 2010, the IRCAD published its first guideline for the surgical treatment of adrenal masses in children, including neuroblastoma. In 2013, John Meehan published a review about robotic surgery for pediatric tumors. He said that papers specifically on pediatric surgical oncology utilizing the robot were noticeably absent. 7 years after, things haven't changed very much. Since the beginning of the pediatric robotic program in Necker in 2016, we have operated 335 children, including 76 oncology cases. We have operated 84 tumors in 81 children during 76 procedures. Neuroblastic tumors, renal tumors, endocrine tumors, thymoma, inflammatory myofibroblastic tumors, germ cell tumors, and others, and the procedures were performed by 4 different surgeons. When you have to manage a neuroblastic tumor, first you have to ask if it is a localized or metastatic disease, and for the surgery, if there is any surgical risk factor. The approach was based on the location of the tumor. So for kidney and adrenal tumor, we use a transperitoneal approach with 4 ports in the midline. For pelvis and presacral tumor, we use the trocar at the level of the umbilicus. And for the thoracic approach, we use the W approach developed by Marion Durand and Nadia Kendallop for pediatric surgery. So we have operated 22 neuroblastic tumors in 19 children. The mean age was 6.5 years. The youngest was 10 months. And interestingly, 50% of the children were younger than 5 years. The mean weight was 27 kilograms, the lowest 7.7. We have managed 12 neuroblastoma, 3 ganglioneuroblastomata, and 4 ganglioneuroma. The location of the tumors, 50% of the tumors were adrenal neuroblastic tumors, but also posterior mediastinum in 4 cases, pelvis in 2 cases, around the renal pedicule with a healthy adrenal in 2 cases, and rare locations such as interaortico cave space, circumcondyle ganglia, and paravaginal. So among the 19 children, 8 had 1 IDRF at the preoperative imaging workup, 7 contact with the renal pedicule, and 1 encasement of the renal pedicule, and 1 patient had 2 IDRF, encasement of vena cava, and contact with the renal pedicule. So 47% of the children had IDRF positive before surgery. So we have operated 12 neuroblastomas. So this is examples of adrenal neuroblastoma. The first patient was the only one to be NMIC amplified, and we had to do a nephrectomy during the removal of the neuroblastoma. This case is interesting. You can see this is a very large neuroblastoma in a 4-year-old girl, MIC-N non-amplified. After surgery, the tumor was quite big, and we had perform the procedure with the robot. You can see the operative field at the end of the procedure, and this was a 10 centimeter adrenal neuroblastoma. Other location of neuroblastoma, Zucker-Kandel ganglia. You can see here the large mass. The inferior mesenteric artery is not an IDRF, but you can see here that there is a contact with the renal artery. And here, this is a pelvic neuroblastoma in a 10-month-old girl. 3 ganglioneuroblastoma, 2 thoracic and 1 paravaginal in a teenage girl. This case was very interesting because at the beginning of the procedure, we couldn't see the tumor, that one in between the peritoneum and the perineum. And it was very interesting to do this procedure with the help of the robot. And this is the postoperative aspect 6 months after the procedure. And 4 ganglioneuroma, 1 adrenal, 1 interesting cases. It was a 5-year-old girl with many tumors. You can see here a prerenal tumor, 2 thoracic tumor, and 1 pelvic tumor. And this is another interesting case. This is a 16-year-old boy with a ganglioneuroma encasing the renal artery. So I will show you a short movie. So this is the kidney here. You have the tumor here. And of course, we wanted to keep, to preserve the kidney. So we had to free the renal artery and to go until the aorta. So step by step, we freed the artery, avoiding any spasm, not to lose the kidney. So as the renal artery was totally encased, we had to open the ganglioneuroma, which can be done safely. Here you have the vein here, and here you have the artery. So we are going closer and closer to the aorta. So the tumor is almost freed. And then you can very easily see the anatomy. So this is the renal artery. This is the renal vein. You have the aorta here. The loop is, the tourniquet is around the renal vein. And this is the aorta and the renal artery. So we had only 1 conversion. This was a case of interaorticocave tumor, and we had to convert, except is no complication in the intraoperative course. In the postoperative course, the length of hospital stay was 2.7 days from 1 to 5 years. No postoperative complication, no readmission, no reoperation, and the follow-up is 1.5 years. So in conclusion, this approach is feasible and safe in highly selected neuroblastic children in tumor. It reproduces all the steps of the open surgical approach required to treat the tumor in respect with the oncological surgical principle and in order to maintain an excellent oncological results with the advantage of short hospital stay and cosmetically more acceptable incision. This approach is an interesting option for precise dissection in selected positive IDRF. And of course, experience in advanced laparoscopic and oncological procedure is required. Her objective is expand the boundaries and define indication. The next step is image-guided surgery. And you can see on this picture, on the slides, at the console, I have the 2 images. I have the reconstruction in 3D and the operative field, and it's very helpful to do the procedure. The dual console is very interesting for this kind of complex procedure. So this is a case performed with Professor Sarnaki. And of course, training is very important. Last year, we were very happy to welcome you for the first masterclass in pediatric robotic surgery and urology. Unfortunately, this year, the COVID has prevented us to organize a second section, but we hope to see you soon in Paris. Thank you very much.
Thank you very much, Thomas. Very impressive. Congratulations for your series and your results. That's very impressive. Let's see if we have some questions from the audience. I don't see any yet. So do you perform conventional minimal invasive surgery for these tumors, or you go directly to the robot?
For easy indication, we keep on doing laparoscopic approach, but for more complex cases, of course, we prefer to do with the robot.
So what do you think that the robot has to offer better than minimal with laparoscopy, for instance, thoracoscopic? Which is, in your opinion, your best advantage?
I think that the quality of the vision and the quality of the dissection is a major advantage with the robot. I think with the robot, you can have a very bloodless field to operate. You see very well. You control everything. This is very important because you control the camera and you control the 3 arms of your robot. So you can switch from one instrument to the other. So I think that these are major advantage for difficult cases in small children.
Okay, so do you think that the robotic approach, in your opinion, which will enlarge the recommendations for minimally invasive approach of these tumors?
There's no, this is a very interesting question because when you look at the literature, there are no recommendation except the umbrella protocol.
That's right.
And we have operated 21 kidney tumor and 7 cases didn't respect the umbrella protocol because the tumor were beyond the ipsilateral border of the vertebra. And in selected cases, I think that you can go beyond this contraindication, but it's very important to analyze the cases, to discuss the cases in tumor board, and then to make a recommendation which tumor should be operated with the robot, which tumor should not be operated with the robot. For instance, it's a poor indication to do median neuroblastoma with the robot because you have to dissect, for instance, the superior mesenteric artery, and you don't want to take any risk. So it's better to do this in open approach.
Okay, thank you. I think we have a question from our president, Henry. Henry?
Impressive series. Congratulations, Thomas. What are in thoracic neuroblastoma? I think there is no doubt that mostly you have to do it minimal invasively, with or without the robot. But in abdominal neuroblastoma, what are for you still the contraindications to go minimal invasively?
Median neuroblastoma. I think if you have a tumor encasing celiac trunk, superior mesenteric artery, don't take any risk, go in open surgery.
Thank you.
Even if you've seen on the videos that you can dissect very precisely the renal artery, but don't start with this kind of surgery.
If it's lateral, it's probably a good indication. If it's central, it's not a good indication, except if you are in the pelvis.
Yes, because in the pelvis, you don't have such risk of vascular injury.
Okay, that is a good lesson to remember.
We have then a take-home message. Thank you very much, Thomas.
Thank you very much.
We will continue with the next presentation that this time comes from Belgium with Dr. Jojo that will show us a training model for the endoscopic surgery in spina bifida. Luke, please, all yours.
Thank you very much. Does it work?
Yes, perfectly.
Thank you very much. So I don't have anything to disclose. I wanted to, and thank you for giving me the opportunity, present our work in our fetal surgery center in Leuven. So we started back in 1994, and our spina bifida program in 2012. And based on the ideal guidelines, mainly, we decided not to move clinically until proven preclinically in animal models. So we first performed a systematic review, which is recently published regarding the learning curve of fetoscopic spina bifida. And compared to open, we showed that it takes obviously longer. It's 35 cases to reach competency for the standard open approach versus at least 56 cases for percutaneous fetoscopy. And so we designed this program in 5 steps. First, training in a pelvic trainer, then rabbit cadavers, then live rabbits, then fetal lambs, and finally moving to humans. So regarding the first 2 stages briefly, those are meant, as always, to acquire surgical skills for this type of complex surgery. And so it took us like 10 + 9, so 19 hours of work on such a pelvic trainer, using the guideline LAST exercises as well as the one from the SAAGS. And we also developed a low fidelity silicone model in different setting. And then we switched to live rabbits. So this is a high fidelity training model that we have developed and validated. So briefly, we simulate in 10 steps spina bifida fidoscopic repair in the abdominal cavity of a rabbit that mimic the amniotic cavity. And we dissect and suture a patch on top of the stomach that mimic the fidoscopic back repair. So this is how it looks like, all the different steps. On the left part of the image is what you clinically do. And we got this from the group in Houston doing the same procedure. And on the right side, this is what we mimic in a rabbit model. And so at the end, and that's key, after we've done the first part of the procedure, which is a fundoplication, we suture a patch on top of the stomach and we quantify whether it leaks or not at the end of the surgery. So this is basically the primary outcome, the water tightness of the repair, because it matters. So we compared two groups of surgeons, so novices and experts. So 3 laparoscopic surgeons were involved, and the novices were the one using the single port before, and the experts were the one using the 3-port laparoscopic system from Storz. To measure the learning curve, we used the robust cumulative sum analysis using a composite binary outcome, mainly based on water tightness of the closure, operation time less than 3 hours, and an OSAT score of at least 18 out of 25. And we could demonstrate a difference between the two groups of novices and experts. There were significant differences for all the parameters that we use: watertight repair, operation time, fetal repair time, and OSATs. And then we validated with the construct validity, comparing the competency between novices and experts. And obviously, novices didn't reach competency yet as compared to experts. They were crossing the line of the cumulative sum, which is on the left side, whether the experts were below it. And then we validated using the criterion system, comparing our model to human millifinoscopic surgery. And we could tell that 33 cases were at least needed to reach competency level for a trained laparoscopic surgeon in our model, which is at least equivalent to what we see in complex laparoscopic surgeries. So in conclusion, this demonstrated using an expert survey that our model is valid and can be used to train and retain skills. And the last stage before moving clinically, we tested the feasibility of different port access, so 3, 2, and single ports in the same setting, except that it was in the fetal lump model. The primary outcome was the water tightness. Specifically, we use also operation time of the different steps. We, again, applied humidified and heated CO2, as I explained in my previous talk, because it's safer for the fetus, and performed the surgery in exactly the same 10 steps. And in the end, what we could show is it was better in terms of water tightness for 2 and 3 ports as compared to single port. And regarding the operation time, the lower was for 3-port technique, and with a lower also pressure to get a good vision in the cavity. So in conclusion, for us, 2 and 3 ports are feasible, but 3-port fetoscopy is shorter, and this matters because it's been shown before that the shorter the operation time, the better the outcomes for the child in terms of prematurity. And again, this has to be performed under humidification and warming of the gas. So in the end, between 2015 and 2019, it took us 104 plus 16 hours of work to reach that level, and finally to implement it in humans. And so far, we've done 3 human cases fetoscopically after having done more than 70 cases open in our center. And we use a 3-port, 3-layer watertight repair through an exteriorized uterus. This is it. Thank you very much. And I'm happy to take any questions.
Thank you. Thank you very much, Luc. Very, very interesting. Congratulations for your program. Let me see if we have any question from the audience. If not, I have many.
I'm sure you do.
I love it. I love it, and I agree with the 3-port technique. But my question is if you want to form a surgeon on that, what technique would you like to teach? I mean,
so if we would move on now, and I would have like a new surgeon coming to our center, definitely the 3-port technique. We would not teach so far the 2-port. I mean, we've learned it. We've learned all the difficulties, strengths and weaknesses of each technique. But as I've shown, it's shorter, it's easier, it's more ergonomic, and nothing to compare to robotic surgery. Of course, we're not there yet, but definitely would go for the 3-port.
Okay, and I assume that's with the uterus exteriorized.
Yes. So far, everything that's been published clinically in terms of prematurity, it's the safest technique. Yeah? With percutaneous fetoscopy, gets an earlier delivery at around 30 weeks in average, versus 37.
Yeah.
Yes, Henry?
Luc, just one question about human. Can you say a little bit about where you are with the first cases? What are the very, very first results?
So we've done 3 cases so far. We've stopped due to COVID.
We didn't understand. You did? You did how many cases?
So we've done 3 cases so far. So we stopped our fetoscopic program due to the COVID. Can you hear me?
Yeah.
Yeah, okay. And so under the supervision of Michael Belfort from Houston, the largest experience in this type of surgery. And so far they are all delivered. One was delivered at 32 weeks. One was delivered early at 27 weeks due to an oligoamnionitis, and unfortunately died after a couple of days in the NICU. And the third one was delivered at 36 weeks. So, and they are doing, the 2 alive ones are doing fine. No shunt so far. Of course, they are too young to see any urinary results, but they are doing okay. I mean, our plan is whatever happens to go to 10 patients, same as what you are doing in Barcelona. And then we'll sit again, more bilaterality, and see whether we move forward. But we have an agreement from our ethical committee for 10 cases as a pilot. And if our results, of course, mimic, are comparable to what we do open and also comparable to the published literature, we'll move forward.
Congratulations, Luc. I'm afraid we don't have time for more questions, although I have many more that I will do that in private. Thank you very much. We move on.
Thank you very much.
To the last but not least presentation is with Dr. Zimmerman. We'll talk about SEALS. 20 years of SEALS, a survey on opinion and experience among IPEC members. Is coming from Germany. Peter, please, your turn.
So, hello.
Hello.
So we will start. So you can see the presentation?
Very well, thank you.
Okay. So dear colleagues and dear chair, since the introduction of SIPES for appendectomy and gastrostomy in 1993, several techniques and indications, including simple ablative procedures as well as complex reconstructive surgery, have been described. SIPES was primarily invented to improve the cosmetic appearance by hiding the scar in the navel. And the aim of our study was to investigate the perspective and experience of IPEC members on SIPES. The survey was conducted using an online provider for web-based surveys between December 2019 and April 2020 on behalf of the IPEC Research Committee, and all IPEC members were contacted by email and invited to complete an anonymous questionnaire that included personal background and 39 items on SIPES. The online questionnaire was completed by 184 pediatric surgeons from 40 countries, corresponding to a recall of 21%, and the mean age was 48 years. And the primary practice setting was a university hospital. 76% of the surgeons performed SIPES for more than 6 years and more than 50% with 2 to 10 cases per month. In contrast, 38 surgeons had never performed SIPES, mainly due to disbelief in any advantage, inadequate resources, or lack of proficiency. The performed SIPES procedures in decreasing frequency were appendectomy, macrolevatecolectomy, treatment of ovarian pathology, U-stitch gastrostomy, cholecystectomy, inguinal hernia repair, and splenectomy. And the most performed procedures were simple ablative and non-complex surgery, and complex reconstructive site procedures like choledochal cyst resection or pyeloplasty were performed rarely. Most surgeons stated that better cosmetic appearance is the main advantage of SIPES, and other indicated benefits were less tissue trauma and shorter length of hospital stay. On the downside, clashing of instruments was perceived as the biggest problems of SIPES. Other stated drawbacks were higher difficulty of SIPES procedures, lack of triangulation, higher incisional hernia rate, and more wound infections compared to conventional MRIs. Most surgeons operate with regular laparoscopic equipment. At the same time, only 12% of surgeons use techniques that can facilitate SIPES, such as long bariatric scopes. The most institutions commercially available SIPES ports were used, and alternative devices were also frequently applied. 25% of the pediatric surgeons indicated a decline of performing SIPES in their institutions during the last 5 years. Almost 40% of the respondents reported that their frequency of using SIPES stayed the same, and 36% reported an increase. 70% of the respondents felt that there's no convincing scientific evidence that SIPES offers any benefit to multi-port minimal invasive procedures. So in summary, the role of SIPES may be mainly simple ablative procedures and non-complex surgery. Clashing of instrument was perceived as the biggest problem of SIPES, and alternative techniques like homemade ports were used by 1 out of 4 surgeons. 3 out of 4 surgeons reported that the frequency of using SIPES stayed at least the same or even increased. And the majority of IPAC members considered the scientific evidence for the benefits of SIPES not convincing. So in conclusion, SIPES has found its place in pediatric endoscopic surgery. The role of SIPES may be mainly simple ablative procedures and non-complex surgery. However, since 70% of IPAC members stated that the scientific evidence for benefits of SIPES is not convincing, further studies and discussions on SIPES may be needed. So thank you.
Thank you very much, Dr. Zimmerman. Let's see if we have some questions. It's very interesting. I would like to know your opinion about is congruent with the findings of the survey?
Yes, so we do SIPES appendectomy on a regular daily basis and also do cholecystectomy, but we don't do any complex procedures in SIPES technique. So we may have the same opinion and experience like the IPAC members have.
All right. And do you think that new improvements like in the robotic platform with ESPES or the use of magnets to separate the tissues will enlarge a little bit more the complexity of the procedures performed with cells?
So we don't have any experience with the SIPES robot by Intuitive, but probably this could bring SIPES on the next step. So we'll see.
We'll see. Let's see. We have some other questions. If not, I think we are done. Thank you very much for these impressive works we have seen today in this session. I think Mario, maybe we have a cool question to.
Yes, Carlos. Mario moved to Philip, and I have first to thank Peter for his very good survey and very nice presentation. And the pool question is, do you consider that single port endoscopic surgery has better benefits in comparison with a multi-site port placement laparoscopic approach in children? Your answer should be yes or no benefit at all. Last, no comments since I don't perform single incision endoscopic surgery in children. You have a few seconds, very good. We have results continuously going on. It's stabilized. Yes, has benefit 29%. 29%, no benefit at all. 21, 21st. And no comment since I don't perform, 50%. Do you have a comment, Carlos or Peter?
Peter, do you have a comment on yourself?
So yeah, after our talks, this should be the right answer, right?
Probably.
Thank you very much, both of you. And it was a very nice session. Thank you again. Now we are moving to a special advice, a special session for awards. And I leave the talk to Mario and to our president, Henry, to talk about the awards.
We will do the awards after the next lecture. So in the meantime, I would like to remember to all participants that in order to get the credits, is it working? No? Let me see, hold on.
So we have a little technical problem. The future president forgot to put his microphone. So there is another one.
Is it working now? Is that okay?
Okay.
Is it working?
Yeah. Is it working?
Perfect.
Yes, okay.
So I would like just to remind you that in order to get the credits for the Congress, you need to download the evaluation form and send it to the UMSA. We will send you again the link in order to get all the information for the evaluation form. Thank you. So we can go to the next lecture. So we're going to talk about the IPEC guest lecture. And our next speaker from this lecture is from Netherlands. He made his medical studies and his specialty in general surgery in Amsterdam. And during this period of time, he also worked as an emergency doctor of the medical mobile helicopter team. Later, he made his training in pediatric surgery and developed a particular interest in the field of minimally invasive surgery. He has traveling in different parts of Europe, in the United States, and in Asia, improving his skills and knowledge in pediatric minimally invasive surgery. He got a PhD degree with the thesis of how to implement safely minimally invasive surgery in the pediatric population. Now he's working as a consultant pediatric surgeon with special interests in thoracic surgery, hepatobiliary, inflammatory bowel disease, and traumatology in children in the Amsterdam University Medical Center. He's married and father of 3 children, and besides medicine, he has a passion for golf, hockey, and running. This year, he was the program director of the IPEC Joint Congress 2020 with ESPES and EUPSA that was supposed to be in Vienna, but unfortunately, as you know, this was canceled due to the COVID-19 pandemic. Dear friends, I have the pleasure to introduce Dr. Matthijs Omen, that will present a lecture of hypertrophic pyloric stenosis. Slice in the olive, stay focused. Please, Matthijs.
Thank you, Mario. Everybody can hear me? Can you hear me?
Perfect.
Yes.
Perfect.
Okay, I will try to set up my slides. Well, first of all, thank you, Mario, for your kind words. And also thank you, ESPES, especially the Executive Board, François Beckmer, Philippe Montupin, and of course my friend, the president, to give this talk about hypertrophic pulmonary stenosis. I tried to make it a little bit more veganistic or vegetarian. That we are in a different world now. We have to breathe different, act different, eat different. You will see it. Well, the content will be an introduction and then something of the background, history. I will say something about surgical aspects and then about non-surgical aspects. It's, of course, as we all know, a quite common pathology in daily surgical care for pediatric surgeons all over the world. The incidence is 1 to 3,000, so we see it quite often. It's, as stated, a nice operation for the fellows. You heard that the first paper from Braga was, it's a nice operation for the fellows, but serious problems can occur. So stay focused, because there can be a perforation, leakage, an abdominal wall can become dehiscent, prolonged vomiting, and as we can see later, other complications. Harold Hisbroom was the first in 1888 who described it in a post-mortem study, a Danish guy who we know from some other pathology. But what about the surgical aspects? Well, it started first in Italia, where they did a dilatation in children via gastrostomy, but those results are quite poor. And then in England, they started with the pyloroplasty. And the first pyloromyotomy was done by Sir Harold Gellan Stiles in 1910. And the procedure was named after Ramsted, who performed it a year later and gave it his name. So we know the problem, and as surgeons, we know the solution. So here is the open pyloromyotomy. As you know, it is done via a mini laparotomy, and you spread the muscle. Very nice operation, but this is ESPES, this is IRCAD. We aim for the minimal invasive part. You see the big scar. Later it went to semicircular, and in 1991 he did the first extramucosal pyloromyotomy. It's wide accepted, but still it remains, is it better? Can everybody do it? When are you confident? So I go to the operation step by step, because the goal is splitting the muscle, not too much, not too less, and of course, low to zero complications. Essentials: the position of the patient, use of only 1/5 trocars of umbilical, an optional use of 1 extra 3 millimeter, but usually now everybody, I think, is doing it percutaneously with 11 or 15 millimeter blade. So after the opening serosa, spreading the thickened hypertrophic muscle, but is it enough? Perforation, can it be done in 20 minutes? So step by step, splitting of the muscle. We have a fantastic view now with the camera, so you see what you do. Not too much, we test it with air. And very important, the wiggle wiggle. Once you've gone too further, you got a problem. When you've done a little bit too less, you can proceed. So here's the incarnation of the olive, wiggle wiggle. And of course, very important, the low to zero complications. And that's what I think is a learning curve, very important. So we did some study in our institute and in our country to focus on the results. Is there a learning curve? Is it better? Can we quantify it? So years ago already, we did a systematic review and meta-analysis to focus on the major complications. Open versus laparoscopic pyloromyotomy. So here's the number of articles that were identified and screened. 4 were included. And the only thing that was really significant and various laparoscopic, you can see it in the black figure, is to the left, so it's various laparoscopic, is the time to full feed in hours. So, conclusion, at best, time to full feed is better, and maybe post-operative hospital stay, at best a few hours. So it might be acknowledged, we then said, as a standard of care, if done with pediatric surgeons who have expertise in this procedure. So how many do you need to become a surgeon with expertise? So the next study, you see here the groups. The difference is not significant between the open and the laparoscopic group. We looked at complications. And you see here no complications in almost the same, 21.5% versus 21.1%. So not very significant. But if you look at the figure, you can see the green line, open pyloromyotomies. It's a straight line about the same in time. And the red line are the complications in the laparoscopic group. You can see there's a decline downwards. And it crosses in the middle between 31 to 40 patients. So the conclusion then, that the number of complications decreased significantly between the first and the second group. So we then stated 35 procedures as being the learning curve. It's good to hear that also Dr. Joy is quantifying his learning curve. But is it enough? Because you did see that the decline went further. So is there a tail of the learning curve? So we looked again in the next group. And you could see there were no complication difference, a little bit bigger, but if you look at the major complications, there was still a difference, but the groups were maybe too small. So a further decline in overall, a major complication of the learning curve is seen, but the debate whether which one is better is not finished as long as it is not clear whether the minimal invasive operation is beyond the initial or tail of the learning curve. So now I'll need anything and everything. I just do my 35 LPs, so now I'm cool. But there are some new insights. And like Ari said, that's one thing I learned, paper is paper, real life is real life. Sometimes you see things which you cannot ignore. So in our group, we sometimes occurred omental herniation at the port sides. So how many were those? So we did another study, retrospective. Then it were 474 infants. You see it's leveling up the laparoscopic group. And in the literature, most complications are perforation, incomplete, but which complication only occurs in either one of the approaches. The baseline characteristics were the same. No significant p-value we could see. And here are all the complications. So you can see that 3 are really significant. Cirrhosis tears of the stomach, who of course only are with the open group. Nope. Facial dehiscence and omental herniation. And you see that the omental herniation only occur in the laparoscopic group. So to say more about the complications, we of course graded it to the Clavin-Dindo classification and look especially after grade 3A or 3B. That means that any intervention has to be done. So if you look at this, you could see that facial dehiscence 6 times is a reoperation in the open group, but also 6 patients need an intervention of omental herniation. That's something to think about. So in the discussion, omental herniation occurred at both sides of the emetum in the 2 stem wounds and occurred independent of closure of the fascia. Possible causes: adhesion of the omentum to the instruments, muscle relaxation not good before the trocar removal, CO2 pushing abdominal contents. So what can we learn about this? Well, we have to think before we operate. And besides that, are there non-surgical aspects we have to look on? And you think, we as surgeons, what do we have to do with non-surgical aspects? Well, outcomes of surgical care are depending on, of course, the operation and good workup. And good positive care is, of course, depending on 1 and 2. And good workup, of course, is essential in 8PH. We talked about the operation, and now we're going to talk about a good workup. The pre-operative period is very important in HPS. Excessive vomiting results in dehydration. loss of electrolytes, we can cause metabolic alkalosis, as we know, and respiratory problems. Respiratory problems? Did we miss something? Well, first, metabolic alkalosis has an effect on central control of ventilation and respiratory drive, especially in delayed diagnosis. And then in the beginning, we found some poor literature. So we thought, let's look on this more better. So respiratory problems open to severe metabolic alkalosis in infants presenting with HPS. So what's the incidence of respiratory problems in our group? And can we say something about lab results? So the retrospective study we did, you could see that 23 have a respiratory problem, but the problem is there is no standard classification tool for it. So we scored it as being present or absent. We scored on hypopnea, apnea, desaturation, periodic breathing, event with cyanosis or pallor, and need for oxygen. And we found 23 patients, and they are admitted here, and 8 of them needed at least oxygen, and 1 of them was admitted at the intensive care unit. What could we say about the laboratory values? Well, of course, some were significant. Of course, basic says bicarbonate and pCO2. Bicarbonate was separately analyzed and used as a marker for metabolic alkalosis. So we did a multivariate analysis of the bicarbonate and presence of the respiratory problems. And the odds ratio were 2.18 per 10 millimole of bicarbonate if corrected for age and blood weight. Nevertheless, one of the conclusions was that 5% had respiratory problems. Did we miss something? Is happening more we don't know or see? So the next study was a systematic review again on available literature. So first we started Real Life, our own study, but then what is it in the paper? So here is the identification, papers, screens, which were eligibility, and included were 13. Here those are those 13, and I have to go to the conclusion that in spite of the limitations, patients with hypertrophic pulmonary may have a risk to develop perioperative apnea, and we found reported incidence of 27% pre-operative and 0.2 to 60% post-operative. And the precise underlying mechanism of apnea is still not completely clear, but it's important for surgeons because it's depending on this association, the timing of surgery could be reassessed. So what can we do with this? I mean, we have to, I think, take step by step to elucidate this more. So we did a Delphi analysis to reach consensus on the pre-operative care in infants with HPS. It was internationally done. A Delphi is to reach consensus when there is no proof available. So we did it among pediatric surgeons, pediatric anesthesiologists, and pediatricians. You see the overview of the consensus process. They got all the literature and summary of the evidence, and it went by round 1, 2, and 3 to have a final approval to find a consensus. The characteristics of the panel members, you can see here 16 pediatric surgeons, the majority, 11 pediatric anesthesiologists, and 6 pediatricians, mostly pediatric intensive care doctors. And they looked at a lot of things, laboratory values and cutoff. Appropriate cutoff values prior to surgery, blood sampling when, resuscitation policy, and the use of something more like an ejecutive tube or PPYs. To conclude, it's very important that the panel recommended that the blood sampling should be repeated until the infant is ready for pulmonary myotomy if those levels are succeeded, pH below 745, basic says lower than 3.5, bicarbonate 26, sodium 132, potassium 3.5, and chloride above 100, and glucose, of course, above 4. And they recommended isotonic crystalloids to be used with 5% dextrose and potassium if urine output is demonstrated. Well, this recommendation could be, with a degree of caution, used internationally, so we can have more uniformity in the care of patients worldwide. So in summary, HPS is more than just good to learn by minimal invasive surgery. There is a learning curve, and we stated that it's 35. For example, the first presentation of 45 in nine years, I think, so that was like 5 in a year. So there's quite some numbers you still have to make in the coming years. So it has effects on the supervision and training. So you have to make the numbers as fellow. And be aware of underreported complications. Again, paper is paper, what are real life. We found omental herniation. We found things about preoperative workup. Are there other things? So again, preoperative workup also reduces morbidity, and is there consensus in every country? Even in our little country, there was no consensus in the beginning. So where to find the focus? Work together and collaborate. Look outside your hospital. Look outside your country, and paper is only paper. Look outside the literature. So I think it's very important for organizations like ESPES and EUPSA and IPERC to work on this. Thank you for your attention.
Thank you very much, Matthijs. Thank you very much for this nice lecture. And then I pass the microphone to Henry to thank for the Congress and more information regarding the awards.
Yes, thank you, Matthijs. I was happy to see you again.
Good to see you.
Bye-bye, thank you.
Bye-bye.
So it's we are close to the end of this great first. I hope that you enjoyed it, like we here in the IRCAD in Strasbourg enjoyed it a lot. I repeat you, if you enjoy it and you found it fruitful, don't hesitate to donate to our next project, who is an e-learning platform. And you have just to go to the website of the ESPES to click on the donate button and to follow the rules. Even 5, 10, 15 euros could be interesting for the ESPES and for this new great project. So before ending my presidency, I'm very pleased to do 2 last things. The first one is to help to distribute the awards for the best communication and the best case report. And it will be Alessio Piniprato, who is the head of the scientific committee, who will present those awards. Alessio?
Hello, can you hear me?
Yes, we hear you.
We hear you.
Okay.
A little bit more light will be nice if you can
see your face.
If you can see your face.
It's difficult now because if I turn on.
Okay, okay, let's go then.
Okay, listen, I will share a slide just to show you which are the presentation that has been voted by the board, and I will just show them. Okay, can you see the slide?
Yes, we see. Yes, we see.
Okay.
You can put it in slideshow view.
There's one presentation already done there. Alessio, if you want, we have also the slides done by the video.
If you got it, so we just decided we voted the best case report and the best presentation, and the best case report that was elected by the board is thoracoscopic total excision of a high risk stage 4 thoracoabdominal T10 L3 neuroblastoma. That was presented by Dr. Dokkum from Turkey, and this was enough for him to gain a free registration to the next ESPES Congress. So I congratulate with Dr. Dokkum.
Is Dr. Dokumshu present? Is Dr. Dokumshu still there? Now, he's not there anymore, so he will receive his free registration to the next Congress next year, I hope, physical, which physically present. We will send it to him. Thank you, Alessio. And for the best communication?
Yeah, for the best paper presentation, the choice was of robotic surgery for pediatric neuroblastic tumors, preliminary results from Tom Blanc from France. This was an impressive series of patients. And the paper and the group won publication fees waived on frontiers, provided the paper is accepted after peer revision, as last year occurred in the ESPES Congress in Venice, in Vicenza. And I want to underline that both presentations were focused on tumors, which means the frontiers of minimally invasive surgery.
So can we show, yes, this is the best communication. Is Thomas Blanc still with us? Okay, Thomas?
Yes.
Congratulations.
Congratulations. Thank you very much.
We are very happy. We were impressed by your paper. And this year, it's everything about neuroblastoma, if we understood well. There was, for the case reports, a very, very tricky and very imaginative approach. I guess, Thomas, that you appreciated too.
Of course.
And for the series, of course, you are now one of the main robotic surgeons in oncology in pediatrics. So I think this communication is an honor for, this prize is an honor for the ESPES too. So you understood that if you want, we can help you to publish that your work in Frontiers of Pediatrics, and it will be for free for you if you do that.
Thank you very much for everybody, and congratulations for this wonderful virtual Congress. What a success. Thank you very much.
Bye-bye. Thank you, Thomas.
Thank you very much.
So the second happy thing I have to do is to pass a little gift to the new president, because the keys we have not, because we cannot touch us. So I give him a good bottle of French wine, and I'm sure that the ESPES is now in very, very good hands. So I say goodbye to everybody. And I was very honored and happy to be your president for 2 years. Mario, it's up to you.
Thank you very much.
I guess that we will have a 15 minutes break. And at 4:30, Mario will begin with the General Assembly. I will say to all the attendees, even if you are not member and you didn't pay your fees this year, you can participate exceptionally to this General Assembly, so you can understand a little bit what we live, what is a living society. And you are all, it's free, you can all come to participate and to see what all the projects we have and we will develop in the 2 or 3 years coming. This session, the General Assembly, will begin at 4:30 p.m. in 15 minutes. Thank you, and congratulations to the new president.
Yes, and for the nice Congress. Hola. Hello, everybody. Are we ready? Yes, perfect. Well, welcome again. Now it's time for the General Assembly that we're going to start. So I think all the members of the Executive Board are online. And we're going to start also with the approval of the minutes of the last General Assembly in Vicenza. Isabella?
Yes, I sent the minutes of General Assembly Vicenza. Maybe all members already received the approval of the minutes. We cannot vote.
Yes, we all members of in the executive board approve the assembly. So this is a very special moment because the General Assembly this year is going to be taken in this fashion. And unfortunately, there is not possibility to vote. So we're going to use this General Assembly mostly for information. And then we will can clarify questions. If the participants have some questions, we are going to be happy to answer to everybody. But this is going to be just more an information General Assembly. So for the minutes, okay, thank you very much, Isabella. And then we can go directly to Fabio Chiarenza for an update about the Treasury and the membership update.
Thank you. Now we'll go to open the file. Okay. Can you see the video or not? Not again?
Yes, yes.
Sorry. Sorry, little problem now.
We see your slides, but not in slideshow mode.
Okay.
Now?
Now I go.
You have to go up there, yes?
Yes, yes, I go.
Okay.
Okay. I go now. Perfect. Okay, first of all, I thank the president, ex-president Aristayat, and congratulations to the new presidents. I have to particularly thank Paul Philippe that maintained the treasury in very good way. This was in difficult years because we had no live Congress, we had all that you know. So we had less income, not only for the members, but only for the Congress, obviously, and other sponsors, etc. So we started with the asset at 31 December 2019. We had the bank account and the PayPal account that was in total 67,40,73 euro in December 2019, with a positive asset of 590 euro. This year, the asset is total 85,000 euro, 317, in bank account 84,000, and in PayPal account only 1,000 euro, because usually as suggested by Paul, I transfer the payment and the money in the principal account of the bank. We have had various expenses that banking fees, web hosting, expenses with the winter board meeting. Also, if it was aborted, we have had some expenses for reimbursement on the flight ticket, accreditation, CMA, ESPES, secretary expenses, and that in total, after this assembly, are about 6,000 euro and 89. About membership, the income of membership this year was lower in terms of number of paying members. Why? Because you know that we increased the fee from 40 euro to 50 euro, but we have a little bit less paying member at now. But the total of paid of amount of fee is stable, about stable in the years, about 8,120 euro. We had an income of Vicenza Congress of 4,066 euro without other expenses. And we had a great gift, I think, great investment by the president that I thanks personally and by all the board, I think also the members of the society, because he collected 5,000 euro in a beneficency event that he organized in Strasbourg, and they donate 5,000 euro to improve the e-learning platform in which the past president was very confident to start. The total income now is, but we are lucky with the 5,000 euro, about 27 euro 86. So we are in positive. In conclusion, we have a fine, even we have had COVID period, we have had a financially stable year, and I have to underline that we have a decrease of membership. Why? For sure, for COVID, other problem, but could be for the increase of the fee. I don't think so. Is for sure we have to improve, I think, improve the numbers. This year the Congress was for free, was very fantastic, was very participated Congress, but probably we have to study another formula to maintain also a financial income to our Congress. So we hope that next year we can have in the live meeting that will be in Lugano more than 300 participants and an income, a good income. So in conclusion, we have income lower than 2019 because if we don't take in account the Presidenza sponsorship, we have a lower income. Okay, and at least only a few words about the membership, because we have no great news, as I told you. We have paying valid member 185. It means that they are regular paying members. Then we have also 187 awaiting order. That means that a lot of people have to pay the fee, and also is not again cancelled as member. So is again active member, but is not renewing the fee for this year, and someone for last year's. In the next time, I have to organize with the secretary to send to all the members not paying a letter, an email to stimulate to pay and to become again member, full member, paying member. I think that ESPES is a new society in which every president and every board has the focus to maintain low-cost society, but high quality scientific scientific level. This is the reason why I ask in the name of all the board also to stimulate your young and old surgeon to become members, and for the members that had not paid to pay the fee, because this is now the only way in which we can obviously sustain our society. And I thank you for your attention, and everything is open for any question.
Thank you very much, Fabio. Yes, it's a good moment really to encourage all our members that get updated with their membership, and to encourage also other colleagues, young or older surgeons, to become members of ESPES. As you are absolutely right, we are 10 years old of this society. It's a young society, but it depends a lot of the support and the participation of the members. And this year, unfortunately, we with the COVID pandemic, we had all these problems, but we are very grateful that anyway we were able to perform this Congress with a zero cost, because thanks to this support of Professor Marisco and the IRCAD team, the expenses for this Congress were zero completely for ESPES. And even the way that we work in the team to get in the same fashion in order to be to create the union for ESPES, we are not even considering extra expenses, even for the executive board members that are participating for this Congress. Everything was done as volunteers with all our heart and with all the force that we have. It's our commitment with the society, and we're very happy for that. Thank you very much, Fabio. So I don't know if in the audience there are some questions. Could I know how many participants are online with us? Is it possible to know that? 100? Perfect. Is there any comment or question for Fabio Chiarenza, for treasurer? No questions? Yes, Henry?
So, there is just one comment.
I can't hear.
Okay.
Yes?
Okay. There is one comment from Juan de Agustin, who says we need all members to pay to support the society.
Thank you, Juan.
Just reading.
Indeed, I will just say that we are far most the society with the lowest annual fees, €50, and if you are in a national society, it's €40. So really, we count on you.
Exactly. Thank you, Henry. So if we don't have any more comments or questions, then we can go to the next point. Joseph, are you ready to present the information for the website? No?
Joseph, are you there?
No, probably he had a problem. Okay.
We'll try to join him and we go to the next point.
Exactly. So we go to the next point. Alessio, you're ready to present the situation with the Journal of Frontiers for the ESPES publications, please?
Yeah, I've got a presentation if you allow me to show, so that I can demonstrate the activity of this year after the Vicenza Congress. Can I share the screen? Hello, can you hear me?
Yes.
Yes, we can hear you very well.
I share the screen. Okay. Okay, I have modified my position so that you can see my face better than before. And I share this one. So after the Vicenza Congress, as this year, the best presentation received a waive of the fees required from Frontiers, which is the journal that ESPES has a relationship with. And but more than the winner of the prize, there was the possibility for everybody who was registered in the ESPES and who was presenting a paper on a minimally invasive surgery topic in pediatrics to participate in this research topic that was open in February the 3rd, 2020, and that received papers and submission up to the end of September. We received the sort of proposal from 30 authors. 21 papers have been submitted to Frontiers on this dedicated topic. 8 have been already accepted and published, and I would show you the list of accepted papers. 3 are still under review, and 10 have been rejected. This makes reliable that we will end up with 10 papers accepted, and all the papers that have been accepted have paid less than 50% of the fees expected for Frontiers. So I think that this is a huge success. These are the accepted papers. As you can see, the belonging of the authors is from worldwide. There's a paper from the ESPES board that was cited before by Fabio Chiarenza. And this another part of the accepted papers. As you can notice, most of Europe is represented. And as you can see, this was the first one that has been published. And in the acknowledgement, this paper states that it has been published thanks to the contribution of the ESPES and of the scientific committee. So at the end, the committee and the board facilitated paper submission. With this partnership, we aimed at increasing the likelihood of acceptance of good quality papers, and to be selected for as winner of the best presentation does not necessarily mean that the paper will be published, as the paper that won did not receive enough priority to be published. So it's not something that skips the need for peer revision. The partnership allows reduced publication costs, which is most important in this time of crisis, increases the visibility of the society, allows us to be inclusive and share knowledge and innovation for a society that is projected to the future. So thank you, and I think that this was a huge and wonderful experience.
Okay, perfect. Yeah. Thank you very much, Alessio, for this important information, and we encourage also our members to continue to submit in the Frontiers Journal. Thank you very much. I don't know if we have some questions from the audience. No questions or comments? Yes, Henry?
So just a comment from me saying that Alessio and the group of the scientific committee did a really hard job, because this is a hard job, you see, 21 publications presented, and finally, for the moment, 8 accepted. Meanwhile, work from the scientific committee to help to make it better in English to help a pre-review before reviewing. So you can see too that Frontiers is a very high level scientific paper, and that's why the impact factor is so high. So thank you, Alessio, again. It's a great job, and I think really for the ESPES, it's a great opportunity.
Yes, I agree, but I also have to say that this was your suggestion. This is merit of Henri, and I mean, this is a good catch up, as I say. So thank you again.
Perfect. Thank you very much. So if we don't have any comments from the audience, then we go to the next point, which is Isabella, that will inform about the results of the elections for honorary secretary.
Dear colleagues, dear friends, before I announce the name of the new honorary secretary, Please allow me to have a short presentation and to say some words about these 3 years when I was ESPES Honorary Secretary. So, first of all, I should answer a few questions. Why ESPES? Because ESPES is a new, ambitious, modern professional society. Why Honorary Secretary? Because I wanted to serve the society as best I could to help its development and to preserve its values. To whom I am grateful? I am very grateful to all those who had a positive influence for the destiny of society, to the presidents Azad Najmaldin, Philippe Montupet, Ciro Esposito. I'm very grateful to the president in whose mandate I carried out my activity as Honorary Secretary, Henri Steyer. To my predecessor, Mario Mendoza. To all my colleagues from Executive Board, Treasurer, Executive Assistant, Ordinary members. What I learned how to be part of a team, to work together, people from different corners of Europe and even of the world, to collaborate in order to develop one of the most beautiful dreams now come true. In 2020, the Society has almost 400 members from all over the world. In the last 3 years, the congresses took place in Brussels, Vicenza, and now in IRCAD, Strasbourg. In 2020, September 17, total ESPES funds are 85,000 euro. In the last 3 years, ESPES developed 2 important committees, Educational Committee led by myself and Scientific Committee led by Alessio Piniprato, which developed a strong connection with Frontiers in Pediatrics Journal and helped a lot to organizing this Congress. What's next? I'm very happy to announce you that Maud Lindeboom from Utrecht, Netherlands, was elected as new Honorary Secretary. Congratulations, Maud. I will continue to participate in the development of society, making the experience gained in recent years available to those who may need it. And now, allow me to share with you some of my precious memories. When I became Honorary Secretary in 2017, Mario revealed me a big secret. He lost his hair in those 3 years of Honorary Secretary position, and I was afraid not to happen to me too, but fortunately I was luckier. Now I have long hair again. These are some precious memories for me from Wrocław, Naples, Bucharest, also Bucharest, Brussels, also Brussels, Brussels again, Vicenza, Galeone. And now it's time to say goodbye. Thank you for all the wonderful time we spent together, for all the extraordinary achievements and great experiences, and I wish you all the best. Thank you very much. I cannot hear you. Microphone.
Do you hear me? Do you hear me
right
now?
now? Yes,
okay.
no.
You know, it was a very, very, very great experience to work with you. And I see that you look younger than 2 years ago. So I think that this job was very, very, very good for you.
Thank you.
And I'm so happy that you accepted to work with me and to be the leader finally of the MOOC we will organize about basic science skills in our new e-learning platform. You will be the leader of that, and I will very, very happy to work again with you for 2 or 3 years.
Thank you so much.
Thank you so much, Isabella.
Thank you very much, Isabella, for all your devotion and commitment with ESPES in these years. Thank you. Thank you very much.
Thank you.
And I don't know if it's the time to have also Maud.
Yes.
The podium.
Yes, hi.
I don't know. Okay. And then Isabella,
Hello,
I
Maud.
let you introduce her.
Yes, can you hear me?
Yes, yes.
Yes, okay. Yeah, thank you so much to the IRCAD and the ESPES, and especially Dr. Dragici, Professor Esposito, Professor Mendoza, and Professor Steyer. I am very honored to be able to take on the task of Honorary Secretary for the ESPES, with all my hair intact, hopefully, for the next coming years. I'm a pediatric surgeon and associate professor at the University Medical Center in Utrecht. And since 2008, I've been performing minimal invasive pediatric surgery with Professor van der Zee. As a pediatric surgeon, I've served as an active member on the Education and Training Committee of the EAS for 4 years. And I've also served as an active member on the Ecolasia Committee for the ISDE and several smaller research committees.
Yes.
So to be able to serve as a member of the executive board and contribute to a strong united ESPES is an incredible opportunity for me, for which I'm very grateful. And I hope to follow you, Isabella, with this task and maybe even be younger in a couple of years than now. I'm very excited to work together with President Mendoza and all the committee members and Gaia Tamara, of course. So I hope to see everyone in real life soon. Thank you.
Thank you very much, Maud. Thank you,
you.
and welcome aboard.
Welcome aboard.
So I don't know if we have some questions from the audience for Isabella or for Maud. Comments about the elections or something that somebody wants to know? No? Perfect. Then we're going to go to the next point, which is going to be the Congress 2001. Due to the situation with the COVID pandemic, we were very concerned about where to develop the next Congress, and especially also if we're going to be able to perform it. So in the executive board, we decided to make a vote to evaluate the candidatures that we have. And we decide that the next Congress 2021 will be in Lugano, Switzerland. And we don't know exactly how the situation will be for the pandemic. We really hope that it's going to work, and next year we're going to be able to join in person, everybody. But we will keep you informed about all this situation. So I would like to share with you now the flyer, so you can see the dates that we're going to propose. So the dates that probably we're going to do this Congress is going to be September 15 through 17. It's going to be in the Palacio dei Congressi in Lugano, Switzerland. And we're going to start to post more information in our website in order to keep you updated about how the things are going. So everybody's going to be welcome in Lugano. And yes, Henry, you have some questions, comments?
Yes, just to say that there were 3 candidates. First was Maastricht, second was Barcelona, and the third was Switzerland. And so normally there must be quite a vote in the General Assembly, but due to all what happens, it could not happen in Vienna. And so we had a decision to take, because you know that this is hard work to organize some such things, to make the to see that the rooms and so can be booked and so on. So there are deadlines, and that's why exceptionally the executive board decided to choose for Lugano. And we hope that the 2 other candidates will present back their proposition for 22.
Exactly. We're going to be open also for proposition for the next years. You can start sending all the information for these candidates. The other thing is that being also in the area, for me, it's going to be probably easier to be more updated about the possibilities for next year. in order also to avoid as much as possible any expenses or any excessive cost or losses of money in case that the pandemic continues. So I think also from the strategical point of view, also this could be in the interest of ESPES at this moment, something that could be useful. So I don't know if we can open also for discussion. If somebody has some questions, comments from the audience regarding this. Is it possible also to share the photo of the flyer with the society, please? Okay. So we're gonna give you some seconds if somebody has questions, comments.
No question, Mario.
No questions, no comments.
No.
Okay. Perfect. Thank you, Philippe. So we're going to go then to the last point, which is the barrier. This is again open for all participants, for the audience. If somebody has something to add or comment.
Joseph is here.
Okay, perfect. So we can probably put him online also in order to have some update about the webmaster.
Ladies and gentlemen, do you hear me?
Yeah.
Perfect. Yes.
Perfect.
Okay.
You're online.
I would like to congratulate to ESPES leaders as well as to IRCAD team. It's a big jump ahead to make such a e-congress. Our webpage is based for current informations and should to be simple and clear, no commercial. It should be for connections and for cooperation and cooperation with IT professionals, as we've seen, is very, very important and very, very great. We will publish visits on our webpage after the finishing of this Congress. And thank you so much for your trust. And I'd like to cooperate with you ahead. Thank you very much.
Thank you very much, Joseph. You are one of the seniority members in ESPES because you have been now almost there for 3 generations as a webmaster, doing always an excellent job. Thank you very much. We all are very grateful with all the commitment and the support that you do to ESPES.
Thank you very much.
Thank you very much. Yes, Henry?
Yeah, and me too. I have to say the same, of course, that you did a great job, always with your smile. And so thank you for all that. And the future will be great because we will cooperate to make from this website an e-learning platform. And so we will work together more and more with professional ITs. And so I think you have still a lot of job to do.
I'll do the best. Thank you very much.
Thank you very much, Joseph. Well, if I don't know, do we have still somebody that wants to say something? We have comments from the audience. No, is that okay? Yes.
Question is from Dr. Concha. Please, what are the next educativo activities for next month?
Okay, one that is for sure coming, it's the annual masterclass that we are always doing in the ERCAD. That's going to be probably in March, April. We are going to decide the date, and we will post everything in the ESPES website. So probably the next Congress or the next educational program is going to be the masterclass.
Thank you.
Yes, because all the on-site activities in Berlin, in Naples, in Braga that are organized, Isabella told you about that, because all these courses are endorsed by the ESPES, but I think they will not go further. The last one is in November normally, and it's Berlin, and it was just cancelled too. So I think that on-site activities will not go further. And that's why we have to do a big job to serve you with, again, e-learning things. But it's a long work, it's a hard work, but we promise you that we will propose you some fantastic things.
Yes, we have one endorsed ESPES course, which is taken in Naples at the beginning of October for neonatal surgery, minimal invasive surgery and neonatal surgery. But this is an endorsed course, which is taken care or is leading by Professor Ciro Esposito. Okay, but ESPES is just endorsing this course, but this is one nice course also. Yes, another question, comment?
Yes, a question of Paul Philippe. Why not have a Commons e-session with IPEG?
Common e-session in...
A common e-session with IPEG.
We still have or are still working in the IPEG ESPES Joint Force program. This is still going on. And then we will need to talk to them also how to continue to collaborate and how to evaluate for another courses and future congresses for sure. We are very sad that we were not able to do the joint congress in Vienna. We had great plans for this congress, but unfortunately, you know the result, how it went. So we are still working. The IPEG ESPES Joint Forces program is still going on, and it will be.
Yeah, I think we did a great job to try to organize this Vienna Congress, and it could not happen. And then we had a lot of work to do to decide, do we go, do we not, this e-Congress. So all our work power was for this e-Congress. Now that the e-Congress is finished, I think it's the role of the new president to imagine new things. And of course, the collaboration with our IPEG friends must be reinforced and every day. And so why not through e-congresses or e-courses? I don't know, but this is the beginning of a new story.
Correct.
Nothing else.
That's it? No more comments? Well, I would like to thank everybody who stay since this morning until now, joining this fantastic first e-Congress. I think it was a success, and I want to thank all of you, first of all, because we did this for you. You are the main people that were our goal to satisfy and to offer you scientific activity of high level as every year. And I would like to thank again, Professor Marisco and all the team in the IRCAD. This is a very professional team. I know that probably you noticed during the Congress how things were very smoothly. The quality of professionalism, you know, IRCAD, it says everything. So thank you very much to all the team in IRCAD. Thank you very much to Francois Begmour, to Philippe Montupet, our great chairman Congress. He did a great job. All the members of the executive board that participate, Gaia Tamaro also as a executive assistant was also very helpful with the information, sharing the information with everybody. I don't know, Henry, if you want to say also something.
No, just to say many thanks to all the people you seated and all the people I see there, because it's the executive board. So thank you so much for these 2 years. And it's time for champagne, I think.
Yes, exactly.
Bye-bye, everybody.
Thank you very much. So we close officially the Congress and the General Assembly. Thank you very much to everybody.
Bye-bye.
Have a nice weekend.
Thank you.
Bye-bye.
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 Goodbye.
Bye.
Bye.